progression-free survival. Overall survival also appeared to improve, though follow-up period was short. In that study, 100 days after transplantation, there was a second random assignment to either observation or DARA maintenance. DARA was given every 2 weeks until disease progression or for a maximum of 2 years. Results from this second random assignment for maintenance therapy is still awaited. What about other studies? There are other phase 3 trials evaluating DARA as maintenance therapy after autologous peripheral blood stem cell transplant. There is the AURIGA and the DRAMATIC studies. Evaluating maintenance with DARA plus LEN versus LEN alone in newly diagnosed multiple myeloma patients after auto stem cell transplant. Now, there are some management aspects of DARA-based therapies. It's generally well tolerated. There's a higher frequency of neutropenia in the DARA arm. There is development of hypogammaglobulinemia, depletion of natural killer cells, so increased frequency of infections, especially respiratory tract infections. So adequate supportive therapy with growth factors, prophylactic antibiotics, immunoglobulin replacement, and vaccination is required when you're using daratumumab. There can be mild first dose infusion reactions in 30 to 40% recipients. CD38 antibodies also can affect certain lab assays. Daratumumab interferes with the blood group compatibility, as is well known, because it binds with the CD38 molecules present on reagent or donor RBCs. So how do you deal with that? How does the blood bank deal with that? Dithiothiol or DTT treatment of RBC screening cells negate this interference by daratumumab. So DTT, which is a reducing agent, acts to denature CD38 by cleaving the disulfide bonds. But it can destroy the KL antigen on the surface of the RBC. So another alternative in denaturing CD38 is 1% trypsin, because it doesn't destroy the KL antigen. In Apollo Gleneagles Hospital, where I work, we are using DTT for patients who are receiving daratumumab for cross-match. Also, daratumumab can be detected as a monoclonal band by serum protein electrophoresis and immunofixation electrophoresis, and may interfere with response evaluation, especially if patient's M protein and CD38 antibody have the same heavy and light chain isotype and co-migrate in the same region. So what is the way out for that? The way out is a DARA-specific immunofixation electrophoresis reflex assay that can distinguish between the residual M protein and daratumumab. What about elderly patients? Can we use daratumumab in the elderly? Multiple myeloma, as you know, has a median age of presentation of 70 years in the West. Here in India, we get myeloma patients who are of a lesser age. And elderly patients generally benefit less from novel agents, whether it is a reduced ability to tolerate therapy. Both ALCYONE and MAYA studies showed that daratumumab-based therapy is well tolerated in elderly patients. And it is feasible in frail elderly patients also. ALCYONE study in age group more than 75 years. Number of patients in the DVMP arm was 104 and in the VMP arm was 107, so fairly well matched. Median follow-up was 40.1 months. PR or better, in the DVMP arm it was 87.5%, in the VMP arm it was 70.1%. CR or SCR, DVMP arm 41%, VMP 24%. MRD negativity was reached in 24% in the DVMP arm, and VMP arm it was 8%. Overall survival also improved, but these didn't reach statistical significance. What about the Maya study? In the age group more than 75 years, Should we favor these drugs as first line, as it helps us achieve the deepest response possible, because clinical outcomes depend on the depth of response? I believe there is a debate on this issue in this session, so I would be leaving you nicely poised on that front. So thank you.
Thank you, Dr. Somo, for the excellent and lucid. So we will take the questions at the end of the session.
Thank you.
Okay, so we will go to the next session. Yes. Now we heard how we can approach a newly diagnosed myeloma patient with all the drugs which are available, including the very recently the anti-CD38 antibody, the daratumumab that we have heard. Now we all know that there is the autologous transplant has got a very important role in the management of the myeloma. In the last few minutes we have already heard also. So now it's an important topic. If there is a relapse, because we know that myeloma very well-known colleague, Dr. Rahul Bhargav. So I will invite Dr. Rahul Bhargav to the stage. He is senior consultant hematologist in the Fortis Hospital, Gurgaon, and among all of us, actually, he is very active and very young hematologist. So
Really pre-treated, and you have to spend time, not like VRD, which is the standard of care, run of the mill, start it, forget it, do the transplant, and so on and so forth. So is the transplant still relevant? The answer to that is yes. Keep it simple life, don't read it too many things, early, late. India deserves to get an early transplant. Every single multiple myeloma up to 70 years of age needs to get transplanted. So let's look at this. So burden of disease perspective, relapse refractory, advanced investigation and diagnosis. One is till 70. And that you will have a reason to come to the hospital. So one of the reasons could be multiple myeloma, of course, and that's increasing in both the areas. So highest in southern and northern zone, at least in northeast, because the publications have come from there and the registry seems to be better managed. Relapse, so definition of relapse, relapse but not refractory. Relapse refractory, primary refractory. It is not like a resistance pattern of a Klebsiella which you can see on a culture report. Then it comes as, okay, patient is refractory to lenalidomide, patient is refractory to bortezomib, which makes your life easy. So it's a very, very clinical decision, guys. Understand, in umpteen number of conferences, we have asked, what is the refractory disease? When do you call it refractory? So it's all a clinical disease. So the thing is, it's like, you have to have a clinical acumen and you have to live into myeloma for long to understand this patient is not going to respond to lenalidomide. A person who has started progressing on 10 milligram lenalidomide, you will be tempted to increase to 25 and then you say, oh, on 25 it is also progressing. There will be 30% subset in our clinic only, when the dose is increased from 10 to 25, patient do respond. So is it refractory? It's only at 25, the maximum dose which you have given, that probably defines the refractoriness. And VRD being the standard, people will get VRD for 4 to 6 cycles. I mean, we don't go into our practice to 6 cycles, 4 cycles, followed by transplant, followed by lenalidomide 10 mg. And when they relapse, either within 2 years or more than 2 years is what we're going to determine. Okay? Could be biochemical relapse or could be clinical relapse. We often debate in our department, we have got 4 people, which we keep on debating about whether to treat it on a biochemical relapse. Yes, I tend to treat the patient on biochemical relapses. We have seen, moment you have a free light chain which is increasing post-transplants only in 10% of subset, it will be benign or it will be plateaued, but rest 90% people, it just goes on and on and on in post-transplant patients. So I would request that whichever data which comes by and as a young student, you tend to pull out papers too often to show to your bosses that, okay, biochemical relapse should not be treated. I would urge on the side of treating these patients either by increasing the dose or changing the regime or bringing a new molecule so that they never go on to the clinical relapses. So don't go, you have to mug it up because you have to pass the exams and you have to remember those things. But yes, biochemical relapse is where you need to treat. And this is criteria which we have already spoken about. Investigation is what we know. So consider when selecting treatment and relapses is tumor features, host features, and treatment. The most important thing in these subsets is how the patient has fared. How long has patient responded to the previous regime? So simple ideology, let's not complicate. VRD he has received, one patient has received VRD and he continues to take VRD for 4 years. After transplant, lenalidomide maintenance for 2 years and then he relapses. What do you do then? Can you bring Velcade or bortezomib, which he was exposed 2 years back, can I bring it back? Of course I can bring it back. So 24 months is the holy grail somehow, that a person who has not seen that 24 months, the product can always be brought in back. So people who relapse tend to relapse before 24 months, you need to do something change. And something change means radical change. So you have got PIs and IMIDs. So understand you have PI and IMID. At the same time, you have to understand the toxicity. A good hematologist needs to understand the toxicity and the interaction of every drug which they use. Please guys, please spend your time at least 10 minutes on understanding the toxicity of a drug, rather than mugging up what is the progression-free survival, because that's obvious. But what is more important in this subset is these are heavily treated, pre-treated patients. 1 line, 2 line, and 3 lines. Then you need to understand, should I use calfizumab at a ejection fraction of 35%? I'm tempted to use because at the age of 78, he has received bot, Lendex, pod, Pomdex, and so on and so forth. What is the next line? Dara he cannot afford, Melphalan. He says, doc, I can use, should I use calfizumab at a 30-35% ejection fraction? Probably yes, under supervision. Because you need to know that it can cause TTP as well. There's a guy who has got a high creatinine, you need to understand. So important thing is, please make a chart which drug can be utilized in which organ if there's a failure. So lenalidomide should not be used generally if you have a renal dysfunction. So renal dysfunction, liver dysfunction, cardiac dysfunction, and peripheral neuropathy, and divide the drugs of what all you can use, because that's what the host features are going to be. And that's comorbidities, and that's what you determine what agent you are to use. In a simplistic model, people responded, relapse on VRD post-transplant, changed to calfizumab, pomalidomide, and dexamethasone. Simplest model, change from one PI to another PI, change one IMID to another IMID, and dexamethasone continues to be there. So in future, we are going to see more and more dexamethasone-free trials, okay? And tumor features is how the tumor features are going to look like. If there's a 17P, it is going to be bad. Once a guy is bad, he's going to be bad. Do you do a fish testing? If your fish can permit that at relapse, because there's an evolution which always takes place, can I use something more? Why? There are only two things which you have to remember, 11, 14, which you can use venetoclax, which is still expensive for people, but it's one of the first targetable medication for multiple myeloma. If you use venetoclax in 11, 14, 60% response rate comes by. 17P abnormality, TP53 abnormality, can I use, if I have to choose between len and pom, I use pom. And why there's no data for pom? Because pom will not be given by any other drug makers in US to do a trial. Celgene will not give pom, they will only continue to give lenalidomide, which is like soaring high. So if you see the tables, lenalidomide is the fourth most expensive medication in US. So when you see all VRD and no VPD as a trials, you understand because it's being driven by economics. So science and economy has to go through together, and which you have to think through it. You have to see through any trial which you see through, how that trial has been designed and what purpose it serves. And the treatment, of course, the previous therapies is what determines. So specific consideration, age, frailty, drug dose reductions, comorbidities, and aggressive 414, 14, 16, and 17P. You don't have any targetable agents against 414 and 14, 16. If you have 414 at the baseline, probably you'll continue giving IMIDs. I mean, proteasome inhibitors, which are more common. So 43-year-old gentleman diagnosed as multiple myeloma receives 3 doses of bortezomib, develops a severe peripheral neuropathy, so much so he's crippled. He cannot move, undergoes a transplant, and relapses within 2.5 years. What do you do next? So he was given Kyprolis, Pom-Dex, goes into CR, and he's on Kyprolis maintenance. So almost for a year, he's on Kyprolis maintenance. So this is now 414, because he has got 414, because these people are sensitive to IMIDs. So philosophy is very simple. What you can give the best. So 3 drugs replaced by 3 drugs, that's what you require. And these are the comorbidities while considering cardiac disease, thromboembolism. Not very common, because thromboembolism has somehow in India has been able to overcome that. Peripheral neuropathy is still a major problem because we are highly malnourished, which can lead to a peripheral neuropathy. Renal impairment continues to plague our problems. Which agents to give? Liposomal doxorubicin still holds its ground. We have got a patient with frail lady, 60 years old, 6th-line refractory, post-transplant, progression-free survival was 3.5 years. Down the line, 7 years now. Now she has responded to bendamustine. There was an extramedullary disease. You are pushed against the wall. What do? She responded to bendamustine. Daratumumab, Kyprolis, everything she has received. And 7th line, she has received bendamustine. The progression-free survival still goes on to 1.5 years. So she's still doing well. So this is where we are coming back. And ixazomib is not to be remembered because these drugs are not available in the country. And I would suggest that first chance is the best chance, and second is the last chance which you're going to get. Then you're not going to get the patient, for sure. And this is what the lost patient, lost treatment are. I mean, the line of therapy lies, only 5% will, 5th line will only be taken by 14%. And I would say this second, what the Americans shows, if I do really, the second line will be only taken by say 30-40% people alone. The rest people just don't take it. So your chance is the best chance is the first chance. Please remember that. In India, whatever may come by, your chance, first chance is the best chance. And these are preferred regimes. You can see all kind of a generic medications which are being applicable in all kind of a combination. You see why NCCN writes everything. Have you ever thought while this is a busy slide, every single combination is up there? Because it's an insurance-driven thing. If it is not written on NCCN, across America, people will not write. And East and West has got a different philosophy. Eastern side of America will have a different philosophy than a Western side. Please remember that fact. So America is a conglomerate of many, many ideologies. So what the Mayo says might not be followed at MD Anderson. And that's why they require this NCCN, so that the insurances can give you everything. And while we are reading as students, we thought, oh my God, I mean, everything is on board. First we thought it's alphabetical, and then we should like to pull out the data, and so we just kept on fighting within ourselves. I mean, I'm thankful to Tufan because he taught me so many things during my DM days, and on whatever I'm here, one of my colleague, Raki Kar and Tufan, actually drive me through to read all this. So, I mean, this is crazy. Do you see? Everything is on board. What do you give? How do you choose? So simple principle is 3 drugs replaced by 3 drugs. Comorbidities needs to be seen. and what is important is the progression-free survival. So how do you read? So you don't read anything. So the most important thing in India is not the OS. If you go on Twitter and you read Vinay Prasad, every goddamn trial is bad in this country. I mean, in the world. So thankfully, we don't do trials, so that's why we are not ever criticized. But Americans do any trial. If you see JAMA, every week they will come out and say, this trial is bad, this trial is bad. So in my mind, what is more important, and I can be wrong. I would love it to be proven wrong. Why? I only see the PFS. The only thing which has to be seen is not the overall survival. I cannot give an overall survival difference because they will have a multiple line of therapy. Overall survival is a combination of number of PFSs which comes by. What is more important for us in India is how long you can prolong his life. Because it will have two proponents to that. The more the amount of time he lives, he's going to praise you. So he's going to build up your practice. He should not die. Isn't that? He will not go to another hospital. So it is more important that he lives longer. And the second most important thing is that the more you get a progression-free survival, the larger the chance is he might go to see the sunshine of 2023. And that time might be the CAR T cell might have knocked off few zeros. So from $300,000 might have gone to $30,000. Probably. Who knows? I mean, the technology moves very fast. And that time he might get an opportunity to have 40% long-term survival there than itself. So idea is, please don't go towards the overall survival. It's a very busy slide. So how do you choose this? 3.7 months, 5.6 months, 16.7 months, and so on and so forth. What is the more important is that the fourth drug, daratumumab, needs to bring in early. If you need to add upon that, can I use dara, kyprolis, dexamethasone? You can use. Because it's going to have a progression-free survival. Where to stop? These are indefinite therapies. Where do you stop? So best response, bring it down to SCR or MRD negative. That's where the component of MRD comes in. So when, as a sitting practitioner, what I do is, I choose a regime, give it for 3 to 4 cycles, bring it to MRD negative, try to bring it to MRD negative, and then put it on maintenance, because people cannot take it for lifelong. In these trials, very, very easy to initiate. But if you see the end point, it is like till progression. Till progression means there's a 3 trillion economy versus 16 trillion economy. That's what you have to realize. And if I ask my colleagues, in American colleagues, I asked on Twitter, how do you treat your people who are uninsured? There's no answer to that. So we might be a lower middle income group country where we might be still be using VCD, VTD. He might have a chance to survive, but there in US, they just die. They don't get treatment. You see that that's a disparity. So we are no longer a low middle income group country. We are a different nation. Okay? It's gone? Okay. So these are various clinical trials, and you can go through the various studies. The highlighting point in this was just to remember that whenever you add DARA, that's Castor and Pollux strategy, whenever you do that, you start getting larger progression-free survivals. And it's a good drug. So 3 drug versus 4 drug, I would prefer using a 4 drugs. If kyprolis can or calfizumab can be added, please use 4 drugs, because you're not going to get a third chance. Use it 4 drugs, and you still see the results. So this is what the treatment selection based on drug resistance is. Previous HCT, yes. Consider second auto if the patient is more than 18 months, less than 18 months. You can have a short remission, poor compatibilities, and so on and so forth. Consider changing from 1 IMID to second IMID and third, and so on and so forth. Drug selection continues, 3 drug regimes continues, refractory, V refractory, DARA refractory, and LO refractory is what needs to be done. Summary of race base, refractory to lenalidomide, DVD, later relapses, DARA-POM. Refractory to bortezomib, add kyprolis and DARA. Lenalidomide sensitive, DARA, DRD, and DVD appears to the most effective. Bortezomib sensitive, anything can be used, and dual refractory, change over to various regimes. So it's not very difficult to remember. Just what have you used previously, change it. Change it with a different group of drugs, and you will get the results. And late relapses is what we see. Practice points, higher efficacy of neuroanti-myeloma drugs. Treatment of relapse is complex. Therapy selection depends on several variables. In general, triplet medication remains the choice. Participation in clinical trials, which is very, very difficult. Retreatment involves at least 6 months of acceptable if the response was maintained for at least 6 months. Repeat use of IMiDs is also feasible, and previous prescribed drugs may have a less intense dose and change to administrative schedules. Salvage transplant, probably yes, which we all need to do. And that's what the latest things remains. In terms of other things which are coming up is panobinostat, Silingsor, one-time alkylating agents, Milflan. This is very interesting. I mean, this is going to change a game changer in the coming future. Novel strategies, CAR T cells, and newer investigation modalities, oral inhibitors, and Pembro is coming up. So these are the newer approaches for triple therapies, and this is what the summary slides looks like. With this, probably, thank you everybody for your patient hearing. So the philosophy, the more important is, rather than remembering all these fancy data, what is more important is to understand the philosophy of treatment of myeloma, which is continuous in nature and has to be tailor-made according to each patient's pocket, as well as socioeconomic condition, as well as where he comes from. So one size fits for all does not hold true in today's world. Thank you.
Okay, so thank you, Dr. Rahul. So we have heard from two speakers how will you approach a newly diagnosed cases and how will you approach a case of relapsed refractory myeloma. Whatever questions are there, according to our schedule, it will be taken at the end of the session. So thank you, Dr. Rahul. We will take the questions in later part. Now we will go to the next session.
So our next part of the session is the most interesting one, that is the debate. The debate is on, the topic of the debate is, all newly diagnosed patients of multiple myeloma should receive CD38 antibody-based therapy. And I will invite Dr. Meet Kumar. He will speak for the motion. Dr. Meet Kumar is the senior consultant hematologist of Fortis Hospital, Gurgaon. Dr. Meet, please.
Good afternoon, everyone. Thank you, sir, for the kind introduction. And I think after Dr. Rahul's talk, there is nothing else remaining to convince the in general public that how should a patient of multiple myeloma should be treated upfront and at relapse. But for the sake of debate, I'll start with my few slides. In the beginning only, I'll tell that I think many of you would have heard about what a chimera is. So what is chimera, do you know? So that's a combination of 2 or 3 different organisms. So today I'm going to be a chimera in front of you because I'm going to speak in for as well as in against, because my opponent has somehow not been able to be present here voluntarily or involuntarily. So I'll start the presentation. The topic is all newly diagnosed myeloma patients should be treated with CD38 based therapy. My opponent is Dr. Girish Badarke, who is my respectful senior from my DM days. I assure you all that this may not be a typical political debate that's going to happen, but surely in this debate, the science is going to win. So there are essentially 2 different types of CD38 monoclonal antibodies that are available to date. One is daratumumab and the other is isatuximab. I'll not be focusing on isatuximab because daratumumab is the one that is available to us and there is significant data available. So if Dr. Girish was here, he would have definitely started thinking in his minds that I don't have enough proof to say that CD38 antibodies are the way forward for treatment of multiple myeloma for newly diagnosed patients. The data has already been shown by Dr. Somu sir and Dr. Rahul sir. So the first one is this Cassiopeia trial that had compared the randomized trial between VTD with or without DARA for 4 cycles, followed by transplant, followed by 2 cycles of consolidation, followed by a second randomization for DARA maintenance versus observation, and there was significant benefit seen in terms of overall response rate, in terms of MRD responses, and in terms of progression-free survival as far as when the DARA was added. So the progression-free survival at 19 months was 93% versus 85%, and that was statistically significant. Overall survival benefit was not seen in this trial, probably because of the shorter follow-up. The longer follow-up with the second randomization is under analysis. In the next meeting or so, maybe, we will be able to see that data. So it's very important for us to understand what impact this new drug can have. So rather than going to debate, I'll just try to focus what all things we should keep in mind. So daratumumab addition, does it cause any increased toxicity when it's combined with VTD? There is some increase in cytopenias, but that is not statistically significant. The toxicity is not very great. There was a concern initially that adding DARA to the induction regimen may impair the stem cell collection, mobilization, and engraftment at the time of transplant, but that also has been negated with the currently available data. So DARA does not impair stem cell collection, engraftment kinetics of a stem cell transplant. The most interesting and the thing that should be most highlighted for patients with myeloma is, we all know there are some subgroups of myeloma called high-risk myelomas, and that is typically categorized based on the ISS staging and the high-risk cytogenetics that has already been mentioned previously. So interestingly, for patients with this high-risk group of myeloma, addition of DARA to such patients helps in improving the progression-free survival as well as overall survival that can be derived from this trial. Had Dr. Girish been here, he would not been convinced with that. I would have to show him the next trial, that's the Griffin trial, and that also compared sort of, instead of thalidomide, it was randomized using lenalidomide. The data again was concordant by using DARA with or DARA in combination of RVD. So the data showed again that the responses were deeper throughout the time period when the patient was on treatment, and beyond that, there is a concept called minimal residual disease in myeloma that is rapidly come up and has been established, including in many centers in India. And that has been, the data shows that patients who receive DARA-based combination achieve 3 times more MRD negativity as compared to those patients who do not receive a DARA-based regimen. In addition to that, patients who stop DARA, the chances of sustained MRD negativity beyond 1 year is significantly higher, as we can see in this cartoon, that is 28.8% versus 2.9%. So that's the thing that needs to be understood. Addition of DARA to the conventional regimens helps in achieving deeper responses, MRD responses, and that's the way forward probably, with certain hiccups that we'll be discussing subsequently. It has definitely impact on PFS and OS. Not yet convinced. Another trial, Alcyon trial, already highlighted. So this compared VMP versus DARA VMP for 9 cycles followed by DARA maintenance. The outcomes were similar. This was especially for patients who were transplant ineligible, and the patients went on to receive this treatment. Interestingly, PFS was definitely superior in the patients who received DARA, 68% versus 50%. Can you believe this? The first drug in myeloma that has shown an overall survival benefit is daratumumab. So daratumumab is having efficacy that has got an impact on changing the overall survival kinetics of patients with myeloma. Adverse effects, against we discussed, we have to believe something. So drug is working, the drug is efficacious, and probably with some hiccups, as we will discuss, the DARA is the new upfront regimen that's going to take place. In patients, that's another study on transplant ineligible patients of DARA without DARA in patients who are receiving Lendex. Again, the data were recapitulated that were same. In the interest of time, I'll just skip these data, these slides. But I know Dr. Girish is not going to be convinced still, had he been here. So his debate still holds that this myeloma is an indolent disease that keeps relapsing time and again, time and again, time and again. So what do we do? What is the benefit if we achieve MRD negativity that is deeper, 3 times than the non-DARA-based combination regimens? So do we believe this? Is there any role or is there any prediction that MRD negativity, such deeper responses, can help us in treatment of the patient? So this is an interesting data that I'll be sharing here, and that shows that there is a significant association of MRD negativity and superior outcomes that implies both overall survival and progression-free survival. This is visible in these charts. So this data shows that patients who have, there's a meta-analysis in which the patients who had achieved complete remission post-consolidation, they were followed up with the outcomes in terms of MRD response. So those patients who had achieved complete response, if they were MRD positive, their outcomes, both in terms of PFS and OS, were significantly worse as compared to those who had received achieved MRD negative status. So that is the significance. Here I'd like to mention here, MRD means achieving minimal residual disease by means of next-gen sequencing or next-gen flow cytometry in the tune to 10 to the power 5 to 10 to the power 6. So this is again very interesting data. This is like this excited me as well. So this is a comparison wherein the patients who had different ISS groups and they were treated with whatever regimens, what was the impact of their outcomes on the MRD status post-consolidation. So those patients who achieved MRD negative status post 4 cycles of induction and consolidation, their responses were negated by the baseline ISS score. And this was similarly seen in patients with high-risk cytogenetics. So do you understand that? Patients with high-risk criteria, high-risk group, based on baseline criteria, will have no impact if they achieve a MRD negative status post-induction and post-consolidation. So that's an interesting thing. So that's a drug in 2021 to go-to drug for achieving the MRD status negativity is DARA. So that's what the highlight is. So we know that a drug is working. So now Dr. Girish would have said, my patients do not have so much money, 9 lakh rupees to be spent for 2 months of therapy. They cannot afford that. Point well taken. And probably in Indian setting, this may not be applicable to all patients, but we have to accept and realize that ultimately India is a country where social and economic divide is so much that the same treatment cannot be provided to each and every patient. To add on to the benefit, when the new drugs come, there is no chances that all the patients can afford that. So, but sooner or later when the generics come up and there are other options available, the patients do get the benefit of such drugs, and that is what the landscape change can happen in terms of patient treatment for multiple myeloma. Lot of side effects with these medicines, is it so? Infusional toxicity, some patients do experience mostly grade 1 to grade 2, that can be easily managed. Some patients experience blood group incompatibility that can be easily overcome by treating. There are STET protocols that have been used now across India by use of dithiotritol that can be treated before blood group analysis. Myeloma patients on DARA experience IgG kappa on IFE, persistence of IgG kappa. There are some soft pointers as to how to differentiate between these two, whether that's a DARA-related band or a disease-related band. But there are some specific modalities that are being tried and they are slowly inching into the clinical practice, like the use of DARA-specific IFE assay. So with this thing, I like to end here and thank BeSHCON for giving me an opportunity to be present here. And I would like to conclude with the statement, the theme of the conference itself, that is, old is gold, accepted, but new is the platinum. So we have to stick to this, stick to the theme, and say that we have to accept the newer changes that are coming up and start following them. So with thanks to the entire team at Fortis, the wonderful colleagues, Dr. Rahul is already here. I rest my case. Thank you. But since the thing is, I already said I'm a chimeric person today. If I can see the slides of Dr. Girish, I'd just like to highlight what I could realize while preparing these slides. Can I have the slides of Dr. Girish also?
Yes, Meet. Dr. Girish is not present, so you please continue with his slides.
So I'm asking...
You will speak both for and against the motion.
So that's why I'm a chimeric person today, sir.
Really very, very tough job. That's... And we are grateful.
Sir, can I have Dr. Girish's slide? Are they with the committee? Slides. I have not gone through them. The disclaimer is I have not gone through the slides. So please pardon me if I am not able to justify Dr. Girish, and I'll be not biased in my favor.
I think that point should be well taken by all persons available here, because anyway, you have to speak something at the last moment and you have to defend whatever you have said yourself only. So this is really tough job. Anyway, let's see.
Yes, sir. So I'll be defending myself for these slides. So this is Dr. Girish's slide. So what probably he tries to highlight here is the conventional regimens that have been used for transplant eligible and transplant ineligible patients. And he has also cited the same trial that I was citing, that was the use of DARA upfront for patients transplant ineligible and use of VMP versus DARA VMP, and similar data for transplant eligible patients. Okay, so what he says here is the poor risk conferred by high risk cytogenetic abnormalities is not completely abrogated by adding a CD38. Point well taken, Dr. Girish, if we are able to, if you are able to hear us. So that means that it's not completely abrogating the high risk cytogenetics or the ISS group. Point well taken, but the thing here is, in a complete ocean, if we add a drop of benefit, that will add on to the long journey of myeloma patients. So even if it is not giving a very good control for patients with high risk cytogenetic group patients, but still it improves the outcomes by almost 15 to 20%. So that's a huge number for patients who can go for the treatment with DARA-based regimen. So few unanswered questions. In transplant ineligible patients, DRD and DVMP have not been completely head-to-head with VRD. That is perfectly acceptable. Most of the trials we all know are pharma-driven. There is some benefit, vested interest that's sitting somewhere, and that cannot be negated. This indicates that next to the new DARA-based regimens, VRD continues to represent an appropriate standard of care treatment. There is no doubt about it, Dr. Girish. There is no doubt about it. VRD will and has and will remain the standard of choice if the patient is not going for DARA. PFS and OS in the intention to treat population, this is with reference to Griffin trial. I am not sure what he intended to show here. I'll skip this. So importantly, bortezomib is given for a fixed period of time in the VRD regimen, whereas DARA is given until progression. Dr. Rahul already pointed about these issues, and that is indefinite therapy is not the need of the hour, but probably we are inching towards a scientifically proven way to improve the outcomes of patients suffering from myeloma. So as on these trials, daratumumab is used until progression, but there is some soft thoughts going on in the minds of various researchers whether DARA will remove the need to undergo autologous stem cell transplant. So there are a lot of thoughts, a lot of questions that still need to be answered. More and more trials will guide us in that direction. So concerns about mobilization of stem cells, Cassiopeia trial very effectively showed there is no difference in the outcomes of patients who do undergo DARA versus no DARA regimen. So he probably wanted to say that DARA is not a Brahmastra. I agree. And yes, so this was a slide I already pointed about. All patients cannot afford 9 lakhs for 2 months of therapy. But having said that, it is no justice that we deprive patients who can go for this treatment for lesser or less aggressive treatments. So there are majority of patients across India are treated under government schemes, agreed. So that is what probably in the next few years to come, the first phase of any medicine that comes or becomes available is to prove its efficacy. Medicine says, the science says that we have to prove the efficacy first and then see its implementation. So the first point we have to understand, accept and rely on is that the medicine is working. The next question, the next hurdle comes the cost. That is for sure an impact, that's for sure an important thing to be considered. But having said that, till that becomes available, till the generics become available, till that time, we need to offer this particular type of treatment for those patients who can go for this treatment. Can we really use DARA for all NDMM? RVD still remains standard of care accepted. DARA can be used at first relapse and achieve better PFS and OS. I'll slightly differ from him because we want the science to win and not the individual. So I'll say, DARA can be used, definitely at relapse it can be used, but it should be offered to patients who may be willing, because we have seen that achieving this MRD negative status is a big thing in improving the outcomes of myeloma patients. So patients especially with high risk category who may not fare so well with the conventionally used drugs, triplets, regimens, they should be offered with a quadruplet regimen that includes a DARA-based monoclonal antibody-based therapy. So old he gold hai, but that's the theme for the previous conferences. We are sitting in 2021 BeSHCON. the theme for this conference is old is gold, agreed, but the platinum is new. So the new is platinum. So we'll stick to the new 2021 conference theme, and can I declare my first part as the winner and not the second part?
Yes, yes. Continue. So thank you, Dr. Meet, for performing this very Herculean task, actually, to defend what you have said, just say opposite to that, and that too without any preparation, without seeing the slides is a really tough job. Anyway, so from your debate, now it is clear that, okay, there may be some people who are affording, there we can go for Dara. We should give them offer, we should offer them, if they can afford, then they can go for it. So I think now is the time for taking questions.
Thank you.
So can I request the organizer to give 2 more chairs, and so that I can request all the speakers to come to the dais. 1 more chair will do, I think. No? Okay, otherwise what we can do, we can ask the audience for questions. If the question is to any particular speaker, then I will request that speaker to come to the dais. So any question from the audience on these 3 topics? Yes. Mike, please. Mike, please.
I am Professor.
So, Dr.
Oh,
Dr. Rahul
speaking to Rahul.
And Dr. Meet and Dr. Somo, can you please come to the dais, please? Okay.
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 I am Professor Pranab Bhattacharya. I am actually a pathologist. And my question to you, so what is the chance of developing plasma cell leukemia in the relapse phase of the multiple myeloma? My first question. 8 to 10%, right? And the treatment of choice in that cases?
So either DTPH or liposomal doxorubicin-based regimes. Secondary plasma cell leukemias are difficult.
Dr. Santanu Basu sir and Dr. Madhu Chandakar ma'am. Santanu sir is consultant in PLS Hospital, Kolkata, and Madhu Chandakar ma'am is senior consultant hematology in PLS Hospital. And our sponsor for this session is AstraZeneca. Over to you, sir and ma'am.
Hello. Good evening. It's a pleasure to be here at the BeSHCON and chair the session along with my colleague in Peerless, Dr. Shantanu Basu, popularly known as Shantanu Da to all of us. And this is a very important session today. What we are talking about is wait and watch. How long? A very practical question that all of us face in our clinics when we see a new patient of chronic lymphocytic leukemia. So the first talk will be by Dr. Prantar Chakraborty. CLL in India, how different it is from the West. Prantar is there?
This is not my talk. The first one, CLL in India. Yeah. So, good afternoon everybody, and what a way of trying to learn when Corona is teaching us so many things.
So I have been given this task of understanding whether CLL in India, it is different. That everybody agrees, I think. Now, how different is it? So, I don't know how many of you remember this. During my childhood, there were two persons, Pankaj Kapoor, along with, I've forgotten, I think Zaver was there, and there were several videos on Maggi hot and sweet sauce. And the tagline was, it's different. Now, why do I bring it here? Because in 2021, that same tagline has been again launched by Nestle. And if you see the new videos, the perspective has changed, the technology has changed, but it's different remains there. Now, I think while we are looking at COVID-19, we have understood that India as a country is different from most of the countries, most of the continents, and we have to understand why, right? For COVID-19, I think the scientists are telling us, the epidemiologists are telling us, we will need 10 to 15 years to understand why we are different. For CLL, I think this is the first time that I don't have the guilt of saying that we do not have enough data, so it's all perception-based. Whatever I will share today will be based on publications and not any personal experience. So what is different? The biology, or is it the demography of CLL? Is it the natural history? Is it the outcome? It depends on what you're using, and I'll show you certain real data from the real world. Its impact, economic impact, social impact, and obviously, no talk on CLL can be without access, because the multinationals are going on launching novel molecules, and then we have that guilt. So our journey will start from biology, and then we will proceed accordingly. So again, one of my favorites. This has also completed 50th anniversary, as we have also completed 50 years of our life on Earth. And you would ask always that the world scientists say that we can do prognostication by fish and other methods, but why do we see so many ugly CLLs? Now let us see, is the biology different? And this is from a publication from All India Institute. Actually, there are two publications, but I'm referring to the newer one. And this was published as an abstract in ASH, where the heading was CLL in India may have a different biology from that in the West. And why did they come to this conclusion? Because high-risk cytogenetic abnormalities were higher. Now, I will come why it was such, but definitely whatever they found out was that we were seeing the high-risk categorization more in our population than in the West. Now, if I look at another 510 patients over 18 years, this is from, again, All India Institute, but this is from Medical Oncology Department. And you will see 57% were mutated. So, obviously, unmutated was relatively higher than whatever we have learned. But if you look at the denominator, so from 510, it comes down to 273, because obviously earlier the technology was not there. And then del 17p by fish was 12%, but it was done only in 150 cases. Now, if you look at another study, this is from PGI Chandigarh. If you look at the percentages, again, totally they had 409, but fish is available for 218. But I always say that some data is better than no data, and deletion 17p, 10.5%, deletion 11q, 9.2, 13q with 28%. So, if you look at it, it might be that the institutional bias is playing a role there, or it might be that the patients are coming to us late. It might not be the biology, but it might be the effect of the environment on the biology which is showing us. So again, why is CLL ugly in India? What has been proven, but there is no publication on that, is the average time to diagnosis is much longer. People do not usually undergo routine complete hemograms. These publications are all from tertiary care centers. Mind you, these are not community-based data. So the referral bias would be there. And another very important thing which COVID-19 has again taught us, that because we are exposed to infections, do we have a cluster who actually have a better CLL, who would have a number of mutations which would make us better, or we have certain genetic susceptibilities or genetic determinants, haplotypes, which make this disease in our eyes ugly, which may not always be the case. Now let us look at demographics. You forget CLL, because you know, during 2021, I cannot go without COVID. And this is 3 days back. Look at the US data and look at us, right? So now you remember CLL. You'll see something, and these are on the basis of whatever data we have in our hospitals. Look at the numbers, 1/10 from that of United States. If you look at the rate, it is far, far less than what it is in US. If you look at percentage of all leukemias, compared to 30% in US, here you are seeing around 4%. And if you look at deaths also, compared to 1.3 billion people here and the 5 million there, their deaths are more than ours. So this is the demographic data. But one thing is very clear if you look at this, I know it's a busy slide anyway, 31.8% are below 55 years of age. Now this is not there in US. This is for any disease. Socioeconomic status, when you're looking at a central autonomous institute, you'll find some people who belong to middle to high income group. If you look at a state government hospital, you'll never find them also. So that does not make any sense. But if you look at the performance status, still 75% have a reasonable good performance score. If I look at the other data, median age of presentation is again 60 years. And range is 28 to 92. Now 92 is fine, but 28, and all of us have seen these young CLLs. Median total count was 45,000. Male to female ratio, as we see in other diseases, it is 3:1 because males would come to us. But if you look at the rise stage distribution, which I'll discuss compared to the other two institutional data, stage 4 is 19%. Most are in stage 2. But remember, they all have the referral bias. Now, natural history. Natural history, when we have treated with chlorambucil, or we have been mostly on wet and watch, and we have a panel discussion on this, so I'll not go into it. The natural history differs because the way we treat it. So if you look at one particular study where, 67% was the overall response rate with chlorambucil. Now, the Western world would not look at this data also now. Median overall survival 5.5 years. And we have seen, and we all know, that's why BR actually almost pushed out FCR, is because of febrile neutropenia and infections, which taught us that, saving the patient is more important than trying to achieve CR. So Indian patients are younger in chronological age, they have a higher morbidity pattern, they have more unmuted IgHV, but BR is better tolerated. We all know this. Now let us look at the outcome, and I'll show you certain outcomes where no CLL trial has done it. And these are, mind you, not trial data. These are from real world data in the OPDs. So if you compare frontline chlorambucil and BR, India is only capable of sharing this data. And look at this. BR, neutropenia grade 3, 4, 52.6%. Chlorambucil plus minus prednisolone, 10.6%. But obviously, CRU is 77 versus 3.2. But chlorambucil infection rate, look at that 0, right? And median time to the next treatment, it was not reached in this particular cohort of BR, and it was 33 months in chlorambucil. Now, if you are managing an elderly person who says, you know, I don't want to come to hospital, but obviously I don't want infections, 33 months is not bad. So this is the survival data, and it's not that I'm telling you of only 10 months, 20 months. At 100 months also, chlorambucil, prednisolone, 60% survival, right? No one would believe this, I know, but this is what CLL in India is. As I was telling you about time to next treatment, this is what I can show you. And this is real world India data. And if you try to look at the toxicities, comparing BR with clinical trial data and real world data, you'll see that we were not doing that bad. ICOST all had shown about 59%, but when they used it in less than 70, it was only 24%, but we were looking at something around 50%. But still, we are seeing more infections. That has a lot to do with our environment and other things. I'm not going into those. Now, if you look at chlorambucil plus minus prednisolone with clinical trial data, these people see that PFS is around 18 to 20 months. We have not looked at PFS, we have looked at time to next treatment. This is 33 months. Now, does that mean that we can handle chlorambucil better? No. It only means that if you are willing to use chlorambucil in a country like India, which still has not written the epitaph of chlorambucil, you can do well. And that is why CLL in India is different. Now let us come to the social impact, right? What about anxiety, decreased physical functioning, depression? Now, frankly speaking, we as hematologists, when we have been taught, we try to look at platelets or total count or blasts. It is now, I think, if we get time and if our paramedics like counselors and others, patient ambassadors help us, we have started looking at quality of life. But I think the most important determinant of quality of life in India is the economic determinant. I know there are several people who always tell economics should not come into science, but let me tell you what we are seeing here. This is before the era of generic ibrutinib, because this was published last year. United States cost of diagnosis, no one mentions. Insurance company gives it or not, how much they co-pay, we couldn't get that data. But for us, diagnosis and prognostication, including IGHV mutation study, at PGI Chandigarh also came to $230. Now you compare 6 cycles of BR, $2,300, $94,754. So when I talk of generic and biosimilar molecules, you can understand that India is different only not because of the disease, not because of us who do not have the luxury of only seeing CLL patients for 30 years, but also because our pharma industry has given us generics and biosimilars which help us in treating patients. Chlorambucil, even in the United States, it costs 12 cycles, $9,000. This cost is around $100, right? But still, because it's only $10,000, you'll never see something about chlorambucil except when a new molecule comes and then when they do a trial, they will always compare with chlorambucil. Then they don't compare with the new kids. They never compare with FCR. They will compare with chlorambucil. That is another story. Now, if you look at cost of ibrutinib, $2,000. This was patient support. But all of you now know what is the cost of generic ibrutinib. Now, this is what I personally feel is game changing. So when we talk of access, when we talk of a molecule, unless the molecule is affordable, it is not accessible, right? If you ever get time, you can look through this article, because not only ASCO, not only NCCN, there were several international organizations who did a press conference on this article, published from PGI Chandigarh, on quality of life. So when you say people on ibrutinib have a good quality of life, people on bendamustine and rituximab do not have it, let us see what is the reality in India. And if you see that all these are different, they are obviously different from healthy controls, but the quality of life is affected even before treatment is started. But if you look at people on chemoimmunotherapy, and you look at after chemoimmunotherapy, and you look at ibrutinib, you don't see much. Because I know it's an oral drug, it might have less side effects, but if you have to continue it for a prolonged period, and then you look at quality of life, this is what you find. I'm not going into these details regarding fatigue or pain, cognitive function and all, but if you look at social functioning, and you compare ibrutinib versus on chemoimmunotherapy and after chemoimmunotherapy, obviously summary score shows that ibrutinib is better, social functioning ibrutinib is better, but in certain areas like cognitive functioning and physical functioning, there appears to be, at least in this cohort, not much of a difference. So when you try to translate Western data into Indian patients and try to convince your patients, remember, our patients are different. Now I come to access, right? Post-trial access, access to laboratory investigations, access to drugs. Today, as I told you, I will only show you data. I will not give you my perceptions. So comparison of access to novel drugs, you have one who is ex-PGI, Swaminathan, and the other two, and this is the data. I know it's a busy slide, but if you look at this access, acalabrutinib is now available in India. This is last year, so it says not available. But frankly speaking, lenalidomide and rituximab is something which, again, the generic and biosimilar industry has made it. If you talk of idelalisib, if you talk of nivolumab, copanisib, and all others, pembrolizumab, it is actually available in India. But whether people can access it is a different story. So I come to the last slide, and by whatever cost you compare, if I compare the cost of Indian drugs into dollars, all Americans would like to come to India because the amount they co-pay is also more than what our person pays out of their pocket. So, India is different. And within India, you have India and Bharat, right? India is a continent. So obviously, its CLL is different. You will see younger patients. You will see more patients with advanced disease. You have less choice. Now, whether it is good or bad, the panel will discuss. You will have the guilt of non-access to IGHV mutation studies, non-access to the newer molecules. Whether you should have the guilt or you have a more chance to innovate depends entirely on you. Thank you very much.
Hello. Thank you, Prantar, for the wonderful deliberation. I have a point to make. We are talking about a disease where the patient is not so sick, looks apparently quite okay in society, can contribute to the society also while being treated for CLL or wait and watch. So the difference, is it only because of the disease, or it is this middle age where a lot of comorbidities are there.
Yeah.
So I need to know what contributes to the morbidities in these CLL patients.
Yeah. So if you look at that real world data, they actually did a chronic illness grading there. And India being the diabetic capital, India having more hypertension and other reasons, it has been shown that though the performance status initially may not vary with the Western population, our comorbidities are more, definitely. But the problem is that we are detecting them when they feel that they have something, which is not the case in the West. Most of them are being diagnosed when their routine count shows lymphocytosis. So obviously we are seeing a population with more comorbidities. And there you have to be prudent. You call it go-go or slow-go or no-go. Your thinking should be an Indian thinking, because again, I don't want to draw similarities. The way we have seen, we have managed COVID-19, it gives me a firm belief that we will be managing CLL also with our Indian philosophy.
Thank you, Prantar. Thank you for this. We are running a little late, so we'll take the questions if you have the time at the end of it. Now, may I request Dr. Anupam Chakrapani, Senior Consultant Hematologist at Apollo Hospital, to take us through the new drug again, you know, the platinum part. Expert guidance on personalizing management of CLL with acalabrutinib. Anupam, please.
So, very good afternoon, and after a long gap we are here. And whenever I take a talk, I always think what I am going to learn from this talk and how it is going to be important for my clinical practice. So as Dr. Prantarda has already said, so India is India and Bharat. So you come across patients in your clinic who comes and asks for the best treatment, what is available for that particular disease, where money is not a problem. So the whole idea of this 20 minutes presentation to take you through this new drug which is now available in India, acalabrutinib. And now we have a generic ibrutinib which is available, and we are using day in and day out in our patients. And now we are realizing that this drug has some side effects like atrial fibrillation, bleeding and all. And in my clinic, I feel that around 10 to 20% of the patient, I have to stop ibrutinib because of the associated side effects. So how this drug is different from that ibrutinib? And I'll come across through this presentation so that we will go with some idea about this new drug. Yes, this is very costly and it is available as per the patient assistance program. It comes around 1.5 to 2 lakhs per month, which was the cost of original Imbruvica. Now it is available in 10,000 rupees. So first to go with the definition of CLL, it's a peripheral blood lymphocyte count more than 5,000 per microliter with the clonality by flow cytometry CD5, 19, 20 and CD32, 31. And monoclonal B lymphocytes, this is the asymptomatic subtype of CLL, you can say, with a clonality, but there is no organomegaly or lymphadenopathy. So MBL, monoclonal lymphocytosis, is one of the most common pre-malignant condition we come across in humans. And around 5% of the healthy population, those who are more than 40 years, may be harboring a MBL. And around 1 to 2% per year, MBL patient progresses to the CLL. So if you take the US populations in 2018, around 21,000 new cases of CLL, and out of that 4,500 deaths due to CLL. Median age is around 71 years, but in Indian population it is a bit younger, it is in the range of 60 years. If you see the division of that 20,000 newly diagnosed patient in US, around 33% of the patients are less than 65 years, and around 5 to 10% are less than 55 years. So if they are going to survive for another 20-25 years, so you need a very good medicine with a minimal side effects. And majority of the patients, those who get diagnosed with CLL at the age of less than 55, they generally die due to the direct cause of CLL. So, as we know, as per the CLL working group criteria, diagnostic criteria and indication to start the treatment, this is a slide just to tell you when to start the treatment. So, all your patient does not require a treatment at the time of diagnosis. So there are certain criteria, based on that you decide which patient needs your treatment. And this is the algorithm, how to approach your patients. So when you diagnose a case of CLL, you should stratify your patient based on this CLL IPI scoring, whether it's fall into a high risk or low risk. If it is in the high risk, then your follow-up will be a little quicker, once in 3 to 6 months. But if they fall into intermediate and low risk, you can follow your patient once in a year or twice in a year. And in all patients, they should need to be screened for interval cancer screening, dermatology screening, vaccination, and all this is also a part of treatment of CLL. So what is the NCCN guideline says about the CLL treatment as of today? So we can divide our patient into two groups, those who comes with this, without this 17p or T53 mutations. So upper part is frail patients, elderly, more than 65, and the lower part is those who are young and fit, less than 65. So preferred regimen as per the NCCN guideline is BTK inhibitor, either ibrutinib or acalabrutinib plus minus obinutuzumab, and you can offer venetoclax as well. Other recommendation is bendamustine rituximab, which is the most preferable regimen in our country, and we are well versed with that. Other options are like obinutuzumab, chlorambucil single agent, rituximab single agent. Those who are fit also, NCCN suggests that patient should be offered BTK inhibitor in terms of ibrutinib or acalabrutinib, plus minus obinutuzumab and venetoclax. And second line, other preferred regimens is BR, which is the most common regimen, and other also like FCR, FR, high dose methylprednisolone with rituximab combination. So this is for the patient, those who are without 17p deletion or TP53 mutations. Patient with 17p deletions and mutation, preferred regimen, again BTK inhibitors with plus minus obinutuzumab and venetoclax. Other regimens, so here bendamustine rituximab doesn't work, those who are having this mutation, so there is no point in wasting money and time. Either you can give rituximab with high dose methylprednisolone, which is available for us, or obinutuzumab or alemtuzumab. But if you are going for obinutuzumab, better you go for generic ibrutinib, which is available in our country. What is the guidelines in relapse refractory CLL settings? Again, upper part is for the frail and lower part is for the fit patients. Preferred regimen in the relapse setting also, BTK inhibitor comes as a category 1, with again other options are like duvelisib, venetoclax, and rituximab with idelalisib combination. Other regimens, whatever you can choose, lenalidomide rituximab, BR regimen, dose-dense rituximab, as per your treating physician. Fit patient, also yes, immunotherapy in terms of BTK inhibitors, venetoclax, duvelisib, and alemtuzumab in the other preferred regimen, bendamustine rituximab. So if you see the recommendation as per NCCN guidelines, both in upfront setting and in the relapse refractory setting, BTK inhibitors is now the category 1 recommendation, and now it is available in India freely, so that should be the preferred choice. Those who are having mutation at the time of relapse, then here also BTK inhibitors with other combinations, and other preferred recommended regimens are high dose methylprednisolone with rituximab, lenalidomide with rituximab. So based on this background, what is this new drug is? So acalabrutinib is a highly selective, potent, next generation covalent inhibitor of BTK with a minimal off-target activity. So that is the catch line of this, off-target activity. So we know that this ibrutinib, which is available with us, patients have a lot of complications like atrial fibrillation, like platelet dysfunctions. So this new molecule suggests that this side effect is less with use of acalabrutinib. So if you see this slide, how the BTK inhibitor has evolved over the years, and in the year around 2015 and 16, both FDA and European Union approval for by the help of various trials like Resonate 1, 2, Helios trial, the BTK inhibitor has shown survival benefit with the other comparator arm, and now this is the category 1 recommendation in CLL management. So acalabrutinib, as I told, is a highly selective covalent bond inhibitor of BTK, and it causes a permanent and prolonged inhibition of BTK activation. That is the advantage over the standard or first generation ibrutinib. So if you see, this is a very important diagram. So right side, if you see, this is the ibrutinib. If you see, there are a lot of non-selective SRC kinase or other kinases are getting inhibited by the ibrutinib. So that's why we come across a lot of side effects. And here, acalabrutinib, if you see the kinases inhibition is very less. It is in the range of around 1.5% as compared to around 10% in ibrutinib uses. So what is the, I will take you through two published data for acalabrutinib. One in the upfront setting and in newly diagnosed patients. It's a phase 3 study of acalabrutinib combined with obinutuzumab versus single agent acalabrutinib versus obinutuzumab plus chlorambucil in a patient with treatment-naive chronic lymphocytic leukemia. So they are newly diagnosed patients, and these patients, those who are more than 65 years of age, and inclusion criteria were more than 18 years, less than 65 years, previously untreated CLLs. So 3 arms. First arm got obinutuzumab 6 cycles and chlorambucil 6 cycles. And there was an inclusion that if the patient progress on this, they can be switched to a BTK inhibitor arm like acalabrutinib monotherapy arms. Second group got acalabrutinib with obinutuzumab 6 cycles, followed by single agent acalabrutinib till progression. And third arm got single agent acalabrutinib as a monotherapy. And the primary endpoint and the secondary endpoint was the progression-free survival, overall survival, which was monitored by the independent review committee. And they also stratified the patient based on the risk status of the underlying CLL, whether they are high risk or low risk, and how this drug was acting on that. So I will not go through into that inclusion and exclusion criteria. If you see the baseline parameters, that is the most important across the three arms, acalabrutinib with obinutuzumab or acalabrutinib monotherapy or obinutuzumab chlorambucil, they are quite similar in terms of age, in terms of stage of the disease, in terms of the risk status based on the chromosome or FISH or IGHV mutations. So they were quite balanced on all the 3 arms. And how does this medicine work? So if you see the topmost curve is of acalabrutinib with obinutuzumab combination. It's quite nicely separated with the downward curve, the lowest curve, which is only obinutuzumab with chlorambucil. So it gives an impression that addition of BTK inhibitor definitely improves the progression-free survival in these patients. And at the end of this analysis, at the end of median follow-up of 28 months, it has shown significantly better progression-free survival as compared to the comparator arm. And if you see, this is the subgroup analysis based on the mutation status of the patients. So here the upper 2 curves are patients who got either acalabrutinib alone or in combination. They did better irrespective of their high-risk status in terms of deletion 17p, TP53, deletion 11q or unmutated IGHV as compared to the obinutuzumab and chlorambucil arm. And these are the bar diagram of patients who undergone complete remission, partial remission and MRD negativity. So if you see the efficacy results, so this trial OS has not yet reached, but the estimated 30 months overall survival is in the range of 90 to 95% in acalabrutinib arm as compared to the obinutuzumab arm. So and the most important thing, if you see, around 25% of the patients, those who opted for obinutuzumab arm, has to ultimately shift due to the progression to the acalabrutinib arm. So around 25% of the patient needs to shift their therapy because of progression. And if you see, the overall response of acalabrutinib therapy is in the range of 85%, and the CR rate was also quite high. And this is the most important table, the side effect which we are facing with the ibrutinib, like hemorrhagic complications or the atrial fibrillation. Here the author found, or the trial investigator found, the most common side effect was headache. If you see, around 71 patients have any grade of headache, and around 2 patients have a grade 3 headache. So they found that the headache is the most common complication with acalabrutinib, and some patient requires 1 or twice daily of paracetamol 650 milligram, and gradually the patient accustomed to that acalabrutinib, and this headache problem generally subside after 1 to 2 months. Other problem they found is the secondary infection, that the incidence of pneumonia was quite high with the patient, with those who got acalabrutinib, but the hemorrhagic complications and the atrial fibrillation was less. So the adverse event of interest, they found that atrial fibrillation, bleeding symptoms and hypertension, it was relatively less if you compare with the first generation ibrutinib or the Imbruvica drugs in the CLL therapy. So that is the only advantage, and there is no efficacy. One should be very clear that acalabrutinib has no efficacy-wise advantage as compared to the standard ibrutinib. So there is no efficacy advantage, and the investigator suggests if the patient is not responding on ibrutinib, there is no point in shifting to acalabrutinib. So there is no advantage in terms of efficacy. So only the indication to switch to acalabrutinib is the intolerance and the side effect related to ibrutinib. That should be very clear. So we should not counsel our patient that, okay, you are not responding to ibrutinib, Imbruvica, we will offer you acalabrutinib that you may respond. No, that is not the case here. So only the side effect advantage of this second generation acalabrutinib. So this is the summary slide of this. So already I have discussed, so I will not waste much of the time. And this trial of acalabrutinib they did in the relapse refractory setting. So here the patient were taken who has already 1, 2, 3 or around 4 prior therapies, and they divided the group into acalabrutinib single arm 100 milligram twice daily versus adalimumab plus rituximab or bendamustine plus rituximab. So that was the comparator arm, and the patient distribution was almost the similar. But if you see the response, progression-free survival of the group who got single agent acalabrutinib versus bendamustine rituximab or adalimumab with rituximab, the curve is nicely separating, and there is a progression-free survival benefit in this relapse refractory setting. And this curve also, if you say in terms of the underlying risk scoring in terms of 17p, deletion 17p and TP53, acalabrutinib has an advantage over the other therapies. And this is the forest plot across subgroup analysis. This favors the use of acalabrutinib as compared to the bendamustine rituximab or adalimumab in the relapse refractory setting as well. And this is the overall survival curve. So if you see nicely after around 1 to 2 years, the graph is separating, and we expect that the patient, those who are on acalabrutinib, though after relapse with the 4 line of drugs, those who respond, they are going to get in a straight line. So if you see after a certain time, the line is getting straight. So after a certain period of time, if the patient is accustomed with the acalabrutinib, they are going to survive for a very long period of time. And adverse event also, they found a similar type of adverse event as in the newly diagnosed patients. So in a relapse refractory setting, if you use acalabrutinib, the incidence of atrial fibrillation and hemorrhagic complication are there, but it is significantly less as compared to the standard ibrutinib. So the same thing here, major hemorrhages. So the summary is that the ASCENT trial confirms that acalabrutinib is quite useful in the relapse refractory setting as well as in the high-risk patient with the high-risk feature as well. So I think with this I'll conclude. So acalabrutinib is a next generation, highly selective, covalent bond inhibitor of proton BTK with a minimal off-target activity. That is the whole important point of this drug. So off-target activity is very less. And the dosing is also 100 milligram twice daily, and it causes near complete and continuous inhibition of the BTK without significant drug accumulation. And data from landmark phase 3 trial has established that it is quite effective in de novo as well as the relapse refractory setting. So with this I'll conclude, and I must emphasize again that this new drug has no advantage over the, in terms of efficacy as compared to the standard Imbruvica. Only advantage is the minimal side effect which we come across with the ibrutinib drugs. Thank you, sir.
Thank you, Anupam. Thank you for this beautiful presentation. We have a little time. Anupam has finished before time, so we can take 2 quick questions. And while you're there, yes, Shomo, please. There
and
is
one more thing that personally I have not used drug till now, but whatever I have read, based on that I was talking.
Anupam,
Yes,
thanks for a wonderful lecture. My question is about this ASCENT trial. I couldn't understand one bit. There was 17p deletion patients. Were they randomized to acalabrutinib on one arm and BR on the other?
No, sir. The randomization happened irrespective of subtype of underlying risk status. So the 3 arms, what they did, say one arm got acalabrutinib monotherapy, one arm got acalabrutinib with obinutuzumab, and one arm got obinutuzumab with rituximab.
No, that was, I am talking about the ASCENT trial.
Oh, relapse refractory setting.
Yeah.
So there also they did not stratify the patients. Once they started the treatment and at the time of analysis, they retrospectively, they did the subgroup analysis. So at the time of enrollment, they did not stratify the patient.
But that is
so
very
those
strange,
who are
isn't it?
Pardon, sir?
But that is very strange. Won't they look at deletion 17p before starting a patient on a drug? That's what I'm asking.
So you can ask an ethical question. So if the patient is 17p, how can you enroll that patient without BTK inhibitor type of trial? So that is an ethical question. I don't know how the author or the investigator has answered that. But in this trial, they did not do the stratification in the beginning. They started the treatment and they electronically randomized between the 2 groups. And at the time of subgroup analysis, they found that those who were having 17p deletion, if they fall into the acalabrutinib arm, they did very well. They fall into the obinutuzumab arm, they did very bad. So that kind of impression they got.
Right.
So Anupam, that begets the next question.
Yes, sir.
That do you need to stratify at all if you are using ibrutinib or
Pardon, sir?
BTK inhibitor? If you are using BTK inhibitors, do you need to stratify at all?
Yes, sir. So today, if a newly diagnosed or relapsed refractory CLL, if we planning to start the treatment, if the patient falls into an indication to start therapy, yes, TP53 and 17p deletion test has to be done. And if the patient is positive, we should offer ibrutinib based or BTK inhibitor based therapy.
So that is only in deciding therapy.
Pardon, sir?
That is only in deciding therapy.
Yeah, deciding therapy,
Only
yes.
in deciding therapy. Suppose the patient has other indications for therapy. Do you still need to stratify with 17p?
So that's why the only contraindication is like hemorrhagic complication or the cardiac toxicity. Which
No, I don't mean that. I'm trying to ask you that if you have decided on a BTK inhibitor and you have large lymph nodes, let us say, which is an indication for treatment, do you still need to stratify the genetically? Because the outcome is much better.
Yeah, irrespective of stage of the disease, if you fall into 17, so that's why NCCN guidelines also say it. If you are 17p plus positive or negative, category 1 recommendation is BTK inhibitor. But if you are 17p positive, that yes, BTK should be there.
Okay. Right. Yes, Pranav, one quick question, because we don't have much time.
And I think with the availability of this generic, and in this COVID era, many of our colleagues and we have started using ibrutinib in CLL patient right and left, because at home they are eating and they are happy.
Absolutely. And NCCN doesn't make a difference.
Complete response in the acalabrutinib. Acalabrutinib, what is the complete response rate? Then ibrutinib. Number 1, as a monotherapy. Number 2, that the acalabrutinib has got atrial fibrillation. So far I know that
I'm not able to get the question.
a problem with the acalabrutinib, the further BTK inhibitor, has got problem with the atrial fibrillation as a complication.
No idea.
It has got atrial fibrillation as a complication.
So off-target activity of acalabrutinib is much less, and ibrutinib has a non-specific binding to the other kinases as well as the SRC kinases. So
Pranab, I think we can discuss it afterwards. Please.
I think that
Please. We don't have much time. We'll discuss it. We'll go to the next one. Thank you, Anupam. Thank you for this. We'll go to the next program, which is panel discussion on CLL management, real world scenario. May I request Dr. Rajiv De to come up to the dais. He's Associate Professor, Department of Hematology at NRS Medical College. To conduct the session, he's the moderator, and the panelists are Dr. Bashov Bagchi, who's Assistant Professor, Department of Medical Oncology and Hematology at AIIMS Patna, Dr. Shomo Mukherjee, who is a Consultant Hematologist at Ruby General Hospital, Dr. T.K. Dulai, who is a Professor of Hematology at NRS Medical College, and Dr. M.V. Chandrakant, if he is here, Consultant Hematologist at Narayana Super Speciality Hospital, Howrah. May we request all of you to the dais? Can we have a few more chairs? Dr. Chandrakant is not there. Oh, okay. Fair enough. Fair enough. Then we don't need a chair. Yes, please, Rajiv.
Okay. Good evening, everybody. I thank BeSHCON 2021 committee to invite me to conduct this panel discussion. One panelist hasn't attended, I think. So here we have 3 panel experts. And our topic is the panel discussion on CLL management, a real world scenario. It is not visible. We have discussed the previous 2 lectures, the status of CLL in India and the most advanced treatment modality for CLL, that is acalabrutinib. Now we are going to discuss what we actually do, because day in and day out we are treating CLL. Although compared to Western countries, the percentage of CLL is less here in India, but we are treating in our way. And we are actually doing individualized treatment depending on patient's affordability, patient's socioeconomic conditions, and the infrastructure. So here 3 panelists are there: Professor Tufan Kanti Dulai, HOD, NRS Medical College, Department of Hematology, Dr. Bashov Bagchi from AIIMS, Patna, and Dr. Shomo Mukherjee, Consultant Hematologist and Hemato-Oncologist, Ruby Hospital. So let's start with a typical simple case which we see everywhere. 63-year-old man with some comorbidities, hypertensive, hyperlipidemic, and incidentally detected lymphocytosis with normal hemoglobin and platelet, no constitutional symptom, a few lymph nodes here and there, no organomegaly, and flow cytometry report is suggestive of CLL. And there are informations on the IgHV status, which was unmutated, normal beta-2 microglobulin. FISH study showed trisomy 12 and no 17p deletion, and NGS didn't reveal a TP53 mutation. So CLL otherwise healthy. Now, with this background of this case, I am going to discuss these issues at diagnosis. So what are the minimum diagnostic workup needs to be done to diagnose a CLL patient? And what is the role of bone marrow examination? Although these informations are there with us, whether we should need to do all these investigations at diagnosis, let's discuss. So we know that the diagnosis of CLL is done based on peripheral blood picture as well as immunophenotyping. And there was a minimum diagnostic markers for IWCLL as per IWCLL criteria, that is CD19, 520 and CD23 as well as light chain, kappa or lambda. This is sufficient to diagnose CLL. In confusing cases, we may need CD20, CD43, 79B, etc. But this is a minimum diagnostic markers for diagnosing CLL by IPT. Now, when we can diagnose with these 2 tests, whether other tests are required or not. So what are the baseline diagnostic workup needed for CLL?
any expert panelist can take up the question.
Yeah, hello. Yeah, for diagnosis CLL, the minimum requirement, as you have mentioned, a good CBC, complete hemogram, along with routine biochemistry examinations, including LFT, LDH, creatinine, urea creatinine, and viral serology, HIV, hepatitis B, hepatitis C. These things, I think, enough for, and flow cytometry from the peripheral blood to stamp it as a case of CLL initially. And in few cases, recently there are some data that if you, in early stage CLL, like this case, 63-year male patients with no other problems of CLL, lymphadenopathy and everything, we may, if the finance permits, we can do the mutational status, IgHV mutational status, because there are few parameters by which we can say that this patient is in early stage. Okay. Otherwise, I think these investigations.
So at baseline to diagnose, I think peripheral blood and immunophenotyping is sufficient to diagnose.
Exactly.
Yeah, and now we know the extensive pathophysiology of CLL, and we know there are role of B cell receptor and downward signaling pathway, role of different tyrosine kinases, SYK, BTK, PI3K. So these, and there are some small molecules, novel agents to block these tyrosine kinases. So those pathophysiology are known to us nowadays. And with those informations, we can see that CLL genomics play a very important role, what Dr. Shomu was telling. That suppose deletion 11q, 18 to 20% has got deletion 20q. Deletion 17p deletion was found in 7 to 10%, and 40 to 50% of them are refractory. Trisomy 12, it is more or less a good cytogenetic abnormalities which is found in CLL, and it is found in 15 to 20% of cases. Deletion 13q, 55 to 60% cases we see deletion 13q, and which has got a very good prognosis. So those informations are there with us. And it has been seen that all the CLL cases we don't need to treat. And time to start treatment depends on the presence of abnormalities, molecular abnormalities. And it clearly showed that all negative or all negative with 13q deletion, they do a very good prognosis, and they delay the time to start treatment are much delayed in those groups compared to the other groups. And the prognostic implications of these mutations are obvious, especially the IgHV mutation, 17p deletion. The CD38 and JAP70 also can act as a marker for these poorly cytogenetic abnormalities, and they are also can classify the patients into favorable and unfavorable. So with these informations, what Shomo was just trying to answer, that as we have these informations, it has got a significant prognostic value, whether the role of fish, IgHV mutation status, CD38 and JAP70 has got importance at diagnostic workup, and what is the position of bone marrow examination in the diagnostic workup of CLL. Dr. Bashar, please.
Hello. Actually, bone marrow examination, we'll do the immunophenotyping from the peripheral blood we can do. And bone marrow examination would be required if we go for a fish. Now at diagnosis, fish may not be required because if we go for wait and watch in asymptomatic cases, fish may not be required at diagnosis. However, it would be required before we start therapy. And immunoglobulin heavy chain mutation, it can be done at diagnosis because if it is present, then it would be, it doesn't change, the status doesn't change. Then you need not do it at the time of starting treatment. And the next is ZAP70 and CD38. So these are also surrogate markers for unmutated immunoglobulin heavy chain status. So what we can do if the immunoglobulin heavy chain status that mutation, that facility is not available, we can use flow cytometry and we can see ZAP70 and CD38. And if they are positive, then the prognosis is poor because these are surrogate markers for unmutated immunoglobulin heavy chain. So these are the things, and bone marrow for all these, for fish, bone marrow would be required, but that can be done before starting therapy and not mandatory at diagnosis.
Yeah. So perfect. So perfectly it is said that at diagnosis, as per IWCLL criteria also, the CBC and immunophenotyping is sufficient, but before starting treatment, and whom to start treatment, that we will discuss. So before starting treatment, we need to do all these evaluations, including bone marrow aspiration and biopsy, and as usual biochemistry, chest X-ray. And we need additional informations for prognostications also. For that, those molecular marker, including IgHV mutation status, will be required. And after diagnosis, how do we prognosticate? So how to prognosticate CLL?
Hello. I think this is a very, very important question in terms of the prognosis of the CLL, because if you really treat the patients, then the prognostication core is very, very important. If there is no indication for the treatment, as Santanu's question is the very right, that if we are planning to give the ibrutinib, the BTK inhibitor and the aclatabrutinib, in that cases the prognostication systems may not work. But yes, if you really want to treat this patient, based on the prognostication, the different prognostic scoring system is available. If you start from the very old, the RICE system, the modified RICE system, then come to the Binet system, and the more recently, that is the IPA scoring systems. So previously we were only working on issue of the lymphadenopathy and the cytopenia. But more recently, the immunoglobulin heavy chain status and the TP53 mutation status and the beta-2 microglobulin status have been also incorporated for risk stratification of the patient. But the important thing is that in terms of this, the newer era for the BTK inhibitor therapy, so whether we are using the BTK inhibitor in each and every patient, in that group of the patients, whether really you need the prognostication is questionable. But I think this is for the prognostication to the explanation of the patient. We have to do that yes, your long-term survival is this, even on this type of the therapy. Yes. So the prognostication is still valid even in case of the newer drugs.
So yeah, perfectly, Dr. Tufan, which he mentioned, that this prognostication is required when we are giving treatment to a patient. And it is actually making a difference, because after giving therapy, the outcomes are different depending on the CLL IPI score. And it is the slides please. The slides please. And it is separate depending on the CLL IPI. The prognostic groups are separated clearly in 4 prognostic groups. But then this interesting paper came out in 2020, that is International Prognostic Score for Asymptomatic Early Stage CLL, CLLE, IPSE. So IPSE means Early Stage CLL Prognostication. And it included IgHV mutation status, lymphocyte count more than 15,000, and palpable lymph nodes. Very simple, but the data are very robust. And before starting treatment, when the patient is not eligible for treatment, by applying these 3 criteria, clearly these early stage CML could be differentiated into low risk, intermediate risk, and high risk. And what information it can give that in low risk, less than 1% are treated at 1 year and 8% treated at 5 years. In intermittent risk, the percentages are 3 and 28. And in high risk, 14% needed treatment within 1 year and 61% needed treatment at 5 years. So probably, although the patient is not fit for treatment or filled up the criteria for treatment, we can prognosticate, we can give these informations to the patient that if you are as per IPSE, if you are high risk, almost sure that you are going to need treatment. So probably with these informations, and this study with ibrutinib in the early stages trial only, and it showed some improvement in the event-free survival, although it haven't come into a general recommendation of IWCLL. So with these informations, probably what Shommo was telling, that at diagnosis, these informations may help in prognosticate. So in future, probably this will come at the diagnostic workup also. Now, this patient with these informations, whether this patient needs any treatment or not. Shommo.
Rajiv, just an interruption. How easy it is to explain it to the patient?
We can share the information only, the data only. We can tell.
But don't we increase their anxiety level by telling high risk?
Yes, I am absolutely agree with Dr. Madhuchanda
I want
in
to be
terms
practical. Practically, how we can.
yes, in terms of your creating the more anxiety to the patient and the patient relative. If there is no indication for the treatment, I think these prognostic scoring systems, the immunoglobulin heavy chain status, the TP53 mutation is a very important aspect for in terms of counseling to the patient. But yes, there is another recommendation is there. If you have a TP53 mutation, if you have an unmutated, then you have to follow up the patient more frequently, and you have to initiate therapy early without any neglecting them. So this is the only perspective that in terms of doing this, the bad prognostic marker and pick up the patient early, that yes, your disease is bad. As Prantodai rightly pointed out, your disease is ugly, so you have to catch hold them early and we can treat them.
So more active surveillance.
More active surveillance needed.
And while counseling the patient, suppose a case of pediatric ALL, when we are saying that 80% survival, we don't know that particular patients will fall into 80% group or 20% group. So that dilemma will.
Now, when the patient first hears the term as leukemia, whatever it may be, chronic, acute, leukemia means blood cancer, he or she is tensed. So counseling part, especially for chronic leukemias, is very, very important.
So
I think this patient.
So treatment indications.
Yeah, this patient is, I think, don't need any treatment. Wait and watch is the best suitable for this patient, particular patient.
There are typical indications for treatment. These are there. I am not going into detail. We all know this. But usually CLL patients can be divided into three parts. 1/3 patient does not need treatment. 1/3 patient may need treatment. And 1/3 of patient is aggressive and they need treatment at diagnosis. So again, back to the case. After 4 years, the patient progressed as far as lymphocyte count is concerned. Patient was symptomatic with anemia and low platelet count, but ECOG performance status was 0. And repeat FISH study showed that there was trisomy 12 and TP53 mutation was negative. Now, whether Shommo will treat this patient or not.
I think the count is now the just previous slide. Yeah, count I think increased 120 from 80,000. Na? Okay, and now patient is symptomatic anemia. Yeah, patient is having anemia, thrombocytopenia, everything is there. So much of axillary lymphadenopathy, patient progressed. So immediately we have to treat the patient. We have to start the treatment. Yes. But CLL patient, before starting the treatment, counseling is the most important part. This disease is going to stay. It is not at all curable. You have to live with CLL. Okay, so that is the counseling is important, then we'll decide the treatment.
As per the guideline, this patient needs treatment. Now, Dr. Bashab, how you will start the treatment? With what agent you will start or what will be your treatment?
The patient is 63-year-old.
Yes.
Right. And there is a bone marrow...
Good performance status.
Good performance status, bone marrow cytopenias are there. And as far as I remember, unmutated immunoglobulin heavy chain. So unmutated immunoglobulin heavy chain means that conventional chemotherapy like FCR and BR won't work that good. So I would prefer in this case is either mostly I would prefer ibrutinib or a bruton tyrosine kinase inhibitor, ibrutinib, or we can also go for even venetoclax plus rituximab, but ibrutinib BTK inhibitor would be my preferred choice in this case because the patient has unmutated immunoglobulin heavy chain and we all know that
so Dr. Bashab will start with
Rajiv sir, may I interrupt for once?
BTK inhibitors. So any panelists differ with Dr. Bashab or just will agree?
Just one question. this is from our doctor's part, okay, whether ibrutinib. But the important, I have to ask the patient, do you need fixed therapy or do you need the continuous therapy? This is the
right.
price.
That is one important, that the patient preference, whether if the patient wants is okay with continuous therapy, then BTK inhibitors, and if they want a fixed dose therapy, then yes, then venetoclax rituximab is an option. Venetoclax obinutuzumab will also be an option, and even BR-FCR, though not so good, no, not so good, still they would be down the line.
I'm asking any panelist whether any of the panelists will start with FCR in this patient.
So, this is the 63 patient, there is only hypertension is there. I think there is a comorbidity is not much there, and the performance is also good. The another next question will be in my mind in terms of this, the finances. Because in India, the finance is very important aspect in terms of designing therapy. As Dr. Bashop and Dr. Somo is rightly pointed on, the book teaching is we have to give the ibrutinib or the aclotinib in this patient. But considering the financial aspect, I think I will start the patient with the BR chemotherapeutic regimen, and usually we give the 6 cycle and then we can follow up the patients. Another important aspect in that, we have to counsel the patient before, and that you have a treatment option with the BTK inhibitor, and you have to continue the drug till the progression of the disease, or it is the ineffective therapy, and this much finances is involved for treating you in this patient. But other alternative option is there, the BR, you may try with some salvage of the disease aspect.
Yes.
One,
so we have to counsel the patient about BTKI definitely, but if you are going to give FCR in these patients, you are not doing any wrong. So that is
another thing I wanted to mention, that another important thing was to ask whether the patient had any cardiac comorbidities or any renal comorbidities. Then again we'll have to think. If renal impairment is there, then no venetoclax.
Yes.
And if cardiac comorbidities are there, then no ibrutinib.
Rajiv, shall we never consider chlorambucil and prednisolone?
Nobody uttered these words.
There is no reason.
That is the problem.
That depends on the financial and the logistic support. If there is no logistic support is there is no financial support is there, then yes, if you want to give something, then you can give the chlorambucil prednisone, whatever you like, you can give it. That thing has to be explained to the patient and the patient clearly that you have a treatment option, this. If you don't take anything, then you have a poor man choices there, the chlorambucil prednisone you can take, and you have a feeling that yes, I am taking something for the treatment of this patient.
And Prantha showed the data also, that chlorambucil prednisolone, median
that's my point. That
time not reached. So those data are there. Probably they are not published in.
That's my point. In an uncomplicated case, chlorambucil and prednisolone can keep it well for a very long time.
Yeah. So main issue is basically this between chemoimmunotherapy and BTK inhibitor. That is whether you need indefinite period treatment or slightly compromised but definitive treatment, period for definitive time. These charts are there, so we are not going into details. I think our time is also running by. And what I want to focus is, so what are the areas where we will think of giving BTK inhibitors? These signaling pathways are there that we know, and these are 3 BTK inhibitors available, and at least ibrutinib and acalabrutinib are now available in India. So they have different toxicity profiles. Efficacy-wise, they are same. So these are the issues with novel agents. It is not that it is same size fits for all. What Shantanu was telling, that if we are going to start ibrutinib or BTK inhibitor, whether we need to do any of these investigations at baseline. So the thing is, these ibrutinib or acalabrutinib is not a magic bullet again. They have a lot of issues, the issues of toxicity, the issues of depth of remission. If we see all the data of BTK inhibitors, most of them, again, they are dealing with progression-free survival, overall survival. If we see the actual MRD status, so it is not that robust if we use single-agent BTKI inhibitors. And how to reduce the duration of therapy and toxicity. This is a burden for a patient. if I say that if you have to take this anti-cancer drug for lifelong, that means the disease is there. It is very psychologically challenging for a patient to accept that. So patients always want a limited time treatment. So keeping in mind all these issues, there are side effects profiles. So what are the challenges anybody faces when they start with ibrutinib in clinical practice?
Yeah, I have not used the second new drug. The first one, ibrutinib, I have used in few of patients. In CLL, MCL, Waldenstrom's, in all the patients. I am just giving you the data. Mild bleeding, bruising is, I think it is almost 60 to 70% patients I have seen mild bruises. But in one of my Waldenstrom macroglobulinemia patients, the dose is same as you all know, 420 milligram. The patient suddenly presented with loss of hearing in 1 ear. So I found nothing, no infection, nothing is there. I consulted the ENT surgeon, and then it was diagnosed that is a bleeding in the tympanic membrane area. I stopped the drug, okay, patient gradually. So there are few bleeding problems I have faced, and only in one patient I have found hypertension. The patient was normotensive throughout after starting, especially after 1 and 2.5 months, and it present till 3 and 4 months. Hypertension is there, but I have not found any patients of atrial fibrillation in my clinical practice. Though the data is only 8 to 10 patients. Hypertension and bleeding diathesis. These two I have seen in few of my patients.
Another thing I need to emphasize that sometimes we need to counsel a lot before starting ibrutinib because suppose the patient's count is total TLC is 20,000 at the start of therapy, and suddenly after 1 month or 2 months after therapy, the count becomes 50,000, 60,000, then the patient will obviously ask, this happens with ibrutinib. So patient will ask, is my disease is really going towards remission or is it going towards progression? So that thing we'll have to tell beforehand. That is an important aspect, I feel, beforehand, that your count may increase and you shouldn't be concerned about the count, but it will subsequently, after some time, it will come down. So that is one thing that happened to one of my patients. That is one thing I remember. Otherwise, I have not seen any. I have not seen any bleeding episode or atrial fibrillation in my patients. Before starting therapy, I do some screening,
Yes.
and so I have not seen those.
So these are the issues with ibrutinib because many of the CLL patients are older patients. Many of them are on ecosprin or antiplatelet agents because of cardiac reason. So it is not very easy to continue ibrutinib lifelong because this real world data said that there was total discontinuation was around 41%, and that is because of side effects. And median time to discontinuation was as early as 7 months. So again, this is not a magic bullet, and there are ibrutinib resistance also. Regarding this platelet dysfunction, this is really a concern. One of my friend from basic science, she works with platelet function in this kinase inhibitors, both this tyrosine kinase inhibitor as well as this BTK. And she said that ibrutinib stops the function of a platelet aggregation. So it is so strong. So when all these things are there, as far as the toxicity is concerned, especially the cardiac, hypertension, these things, we have an options of acalabrutinib. And Dr. Anupam has elaborately explained how good this drug is as far as the toxicity profile is concerned. So I'm not going to detail of acalabrutinib, but this Elevate-TN trial where it can be used in the treatment-naive patients, and it showed that it is good and with a very excellent progression-free survival, overall survival, and there is very little chances of side effects, especially as far as atrial fibrillation, only 3%, more than equal to grade 3 atrial fibrillation is less than 1%. As far as hypertension is concerned, bleeding is concerned, because it is very specific. So it is a good drug, but as far as efficacy is concerned, there is no significant difference because that is not proven. The trial is going on, head-to-head trial between ibrutinib and acalabrutinib. So we'll be find out as far as efficacy is concerned which drug is better. And when acalabrutinib was used in ibrutinib intolerant patient, the outcome was excellent. In relapsed refractory patient also, this acalabrutinib has got a role. So this is the recent ASH publication, how to approach a CLL patients in 2021 maybe. So if there is symptomatic CLL, again we divide into less than 65, more than equal to 65 fit, more than equal to 65 unfit, whether there is IgHV mutated or not, whether there is TP53 mutation is there or not. In this group, FCR and BR has got a role, but in other groups, BTKI inhibitor comes as a first line of treatment. So, is CLL profile is different in India? It is obviously different. Prantarda has said it is much lesser and we see more aggressive patients. It is there. This is the data from our department. The outcome of BR is not that bad. As we don't have much time, so to conclude, whether any of my panelists want to give the audience some take-home messages regarding management of CLL. Dr. Tufan, please.
Now, the important aspect is that in the CLL, as so much rightly pointed out, is the chronic cancer. So the cancer will remain. And the important aspect is that you have to select the patient for the treatment. If there is a really indication for the treatment is there, you have to treat. Otherwise, you have to follow up the patient before initiating the therapy. So you have to explain the financial status, you have to explain the side effect, and also you have to explain the risk of progression in future.
Yes. So
Rajiv, what is the take-home message for wait and watch? What support will you give the patient?
Till we advise wait and watch, if the patient is not fit for treatment, that is lymphocyte doubling time, that is symptomatic anemia or thrombocytopenia not responding to steroid or poorly responding to steroids.
No, I want to ask, what will the juniors tell the patient who is being opted for wait and watch, that what vaccination program or any other thing they have to do at home or for the next few years when he is under wait and watch?
The patient should be once the CLL is diagnosed, patient should be vaccinated, especially the pneumococcal vaccine and influenza vaccine needs to be given. And influenza every year and pneumococcal vaccine 2 doses followed by 5 years, that needs to be given. And immunoglobulin level we also do, and to have a close watch about the infection of the patient. And we need to advise to take proper protection against infections. So those things, and close follow-up, at least 3 monthly follow-up needs to be done. So ultimately take-home message is we need to reduce the toxicity. That includes financial toxicity also. So thank you, my learned panelists, my chairpersons and audience for a pleasant hearing. Thanks a lot.
Thanks to all the panelists and Rajiv for the wonderful panel discussion. And we come to the end of the session.
Thank you, chairpersons, speakers, moderators, and panelists for enlightening us with insights into CLL. So we move on to the next session on sickle cell disease. We shall overcome pain. So for this, I would like to invite as chairpersons Dr. Nilanjan Sinha sir and Dr. Prasoon Bhattacharya sir. Dr. Nilanjan Sinha sir is Assistant Professor, IHTM Kolkata, and Dr. Prasoon Bhattacharya sir is Professor and Head, Department of Immunohematology and Blood Transfusion, Medical College, Kolkata. Over to you, sirs.
now today this session is on sickle cell disease. For the first speaker, we have Dr. R.K. Jena, who is very well known to all of us and needs no introduction. But to say a few words, he is a BMT physician and professor and head Department of Clinical Hematology, SCB Medical College and Hospital, Kotok. He is one of the main passions is on hemoglobinopathy, and he is a very well-known expert on sickle cell disease. So today we are honored to hear from him a few words and valuable words on sickle cell disease in India. Over to you, sir, Professor Jena.
So respected chairperson, thanks for your kind words, and ladies and gentlemen. At the outset, and a thanks to BeSHCON and the team for making us to feel something close to normal after a gap of 1 year. In a few minutes, I will touch upon a few important points on sickle cell disease, which is peculiar to our Indian subcontinent. I think it will be discussed in a more descriptive way in the panel discussion. I will just quickly touch upon a few of the important points only. So this is the distribution of the sickle cell disease across the globe, and if you look at the Indian map also, it's more common in Odisha, Chhattisgarh, Madhya Pradesh, and Tamil Nadu, and so on, though it can be also seen in most of the part of the, different part of the Indian subcontinent, but these are much more common in our states, Odisha, Chhattisgarh, Madhya Pradesh, Gujarat, and Tamil Nadu. These are the few states. If you look at the haplotypes, depending on the beta cluster gene site where the mutation occurs, and depending on the peculiar geographical area, the haplotypes could be Cameroon, could be Senegal, could be Benin, and could be Bantu. But so far the Indian haplotype is concerned, it's called Arab Indian, which are seen in the Middle East and the Indian subcontinent. So depending on the mutation site, it can be 5 haplotypes, and the clinical feature also can vary depending on the haplotype also. If you look at the Arab Indian haplotypes versus African haplotypes, where the Senegal and the Bantu haplotypes are much more common, a study from Odisha by late BeSHCON has shown that the essential clinical features between the Arab Indian haplotype and the other haplotypes are, we have a high hemoglobin F level, which is 16.64, and we have alpha thalassemia gene co-orientates in a very high percent of cases, and splenomegaly is much more higher in comparison to the other haplotypes. And look at the leg ulcer, is extremely uncommon in our Arab Indian haplotypes, vis-a-vis with the other haplotypes, which can go up to even up to 40%. So these are the 4 salient clinical features and other features which are very peculiar to the Arab Indian haplotype, vis-a-vis with the other haplotype. And as you know, sickle cell disease can affect almost every organ of the body, and the most predominant organ is the brain, where prothrombosis and hemorrhages and various other complications can happen. It can also affect the heart, the liver, the kidney, the eye, and the bone complications are peculiar, and it can have the priapism and of course the leg ulcer. So these are the common organs which can be complicated with sickle cell disease. The main causes of the mortality, it includes infection is the leading cause, acute chest syndrome, strokes, renal failure, and pulmonary hypertension are the leading cause of the death in sickle cell disease. With this basis information, so let's go through few of the real case scenario, and we'll know how the Indian haplotypes are peculiar to our patients. Case number 1 is RS female child, 2 years old, 15 kg with recurrent polyarthritis with both hand and ankle joints. Since 10 months of age, there was a pallor, splenomegaly over 3 centimeter. Investigation reveals almost hemoglobin S is 84.6, hemoglobin F is 12.1, and other parameters were within normal limits. The diagnosis was very simple and obvious. It's a case of sickle cell homozygous with the hand-foot syndrome. The issue is that you have to manage with, since it's a symptomatic, you have to manage with supportive therapy, the folic acid you have to give, you have to go for the penicillin prophylaxis in the doses which has been mentioned, the vaccination which is routinely recommended, you can go for polyvalent pneumococcal, H influenza, hepatitis, even you can add this hormonal vaccination also. Now the question is that hydroxyurea should be given to a child or to an infant of 2 years old or not? Then comes the landmark study. You know, so 10 years before the hydroxyurea was never approved in the pediatric age group. Then comes the landmark study which called the baby health trial. It has proved that both in symptomatic and asymptomatic in infant up to 2 years old age, if you give a fixed dose of hydroxyurea, the total number of pain and the vaso-occlusive crisis, hand-foot syndrome, acute set syndrome, and the hospitalization duration is much more less in comparison to the hydroxyurea group, BCABS with the placebo group. And another interesting fact is that in a subset analysis where they segregated the when they segregated asymptomatic infant patients, newborn, that was very interesting find. When the asymptomatic patient also, the hydroxyurea decreases significantly, so the incidence of the dactylitis, hospitalization, and the transfusion requirement in hydroxyurea group in comparison to the placebo group. That is a very landmark revelation that even in infants, in an asymptomatic patient, hydroxyurea is beneficial. So now it becomes, since 2017, hydroxyurea is approved in pediatric age group, both in symptomatic as well as also asymptomatic group. Now the case number 2, so that patient certainly deserves to that hydroxyurea should be given. And even before that baby trial also, we have used extensively in pediatric age group, even without approval also. The case number 2, SS female, 23 years, 45 kg. She is a chartered accountant by profession. Her hemoglobin S was 72.3% and F was 22.7. And there was a recurrent vaso-occlusive crisis. Investigations were within almost normal limits. The issue is that how to differentiate between sickle cell homozygous and sickle beta thalassemia with these clinical features. What are the management, the dose of the hydroxyurea, and how to use the red cell transfusion in sickle cell disease. Of course, the iron chelation is a big issue in adult patient population also. Look what, here is a hemoglobin capillary zone electrophoresis with S about to 62.6%, F is 28.9%. So here the DD will come. It could be sickle cell homozygous. As you know, the hemoglobin F level is very high in Arab Indian haplotype. It could be sickle beta thalassemia. To differentiate between sickle cell homozygous and sickle beta thalassemia, we don't have any official hemoglobin F cutoff level beyond which you will tell that it's a sickle beta thal. So if you find presence of the microcytic hyperchromasia red cell, a high amount of splenomegaly beyond adolescent, and frequent red cell transfusion requirement, probably the hemolysis component is much more higher, and the diagnosis goes in favor of sickle beta thalassemia. Similarly, to confirm that, you have to evaluate both the parents, and you can go for the beta globin gene mutation analysis to confirm whether the patient is really having a sickle cell homozygous or sickle beta thal. So the case number 2 was we confirm it to a case of sickle cell homozygous. We give like your folic acid, methylcobalamin, other supportive therapy, and hydroxyurea was arranged at the dose of say 10 milligram per kg per day. With that also the pain continued. We increased the hydroxyurea to about 20 milligrams. Still the pain continued. At the last we increased up to 35 milligram per kg to an extent of so 1.5 gram per day. Calcium and other treatment was allowed to continue. Even with that also, still the patient has intermittent vaso-occlusive crisis. There was a dull pain still persisting and compromising our official work. And the MRI spine shows there was some abnormality in the bony structures. There is a marginal change of the change in the hemoglobin F level and S level by the effect of the maximum tolerated dose of the hydroxyurea. Then we added the L-glutamine sachet with a dose of 30 gram per day in 2 divided doses. The patient becomes asymptomatic. All the parameters become within normal limits. That young lady expressed a desire to marry, and hopefully she is going to marry very shortly. Here comes another landmark study, which was again L-glutamine study. I won't go to the detail of the study because of the interest of time. After that study only, now the current status of L-glutamine, though it is approved to be used in sickle cell disease, the current position is that it could be used or it could be added to hydroxyurea if there is a suboptimal response to hydroxyurea, or there is an intolerance or unacceptable toxicity to the hydroxyurea, then you may consider adding the L-glutamine. Now another important point is optimal dose of the hydroxyurea. We have a fixed dose at 10 to 20 milligram per kg per day versus maximum tolerated dose, and the target is that you have to maintain the absolute neutrophil count at about 1,500 to 3,000, and the absolute reticulocyte count should be in between 1 to 2 lakhs. This is the target and by which you have to titrate the dose of hydroxyurea. So to finalize the dose of the hydroxy, we have 3 randomized and a prospective study, Indian study, both by the Dr. Patel from Burla, western part of the Odisha, Dr. Deepti Jan from Gujarat, and another study from our institute, both in pediatric and adult population. We have conclusively proved that using the low fixed dose of hydroxy at the extent of 10 mg per kg is beneficial to the maximum number of the patients with the least side effects. So now it is official that we have to use the hydroxide and the low peak dose at the dose of the 10 mg per kg of the body weight. If there is a suboptimal response, you may gradually increase the dose of the hydroxide to maximum tolerated dose. So red cell transfusion is another important entity you have to consider, but you have to prevent the delayed hypertransfusion reaction. You have to avoid it. Unless and until if you go for the extended cross-matching that like your ABO, RHA, DCE and KL matching, the incidence of the allo antibody can be reduced even less than 5%. So ABO, RHA with all subtypes and KL match is the gold standard. So for the red cell transfusion in sickle cell disease is concerned. Iron overload and iron chelation is another important entity. We have the prospective study in about 100 patients. So what we have seen that this is the 208 patients of sickle cell homozygous. We have compared with the control with the normal population. What we have seen that so the serum ferritin more than 1000 nanogram per ml requiring iron chelation is only seen in 9.6% of cases. And equally important is also with 9.6% of cases, the iron could be low also and the hemoglobin could be low, where you have to supplement the iron to improve the hemoglobin level. So in our Arab Indian patients of sickle cell disease, iron overload is only seen in roughly 10% cases, while contrarily you can have iron deficient also in 10% of cases. So iron chelation is required only in 10% of cases in Arab Indian haplotype. So now the case number 3 is KP male 42 years. It's a diagnosis case of sickle cell homozygous, hospitalized for vaso-occlusive crisis. There was a fever for 3 days. These were the investigation parameters were near normal limits. The management was using the usual standard guidelines like IV fluid, antibiotics, liberal IV, analgesic, oxygen support, other supportive therapy. However, the patient have no response even after 3 days so far the vaso-occlusive crisis is concerned. So this is a case of a resistant vaso-occlusive crisis. So approach for resistant vaso-occlusive crisis is that you have to maintain the hemoglobin S level between 30 to 50%. At the same time, you never raise the hemoglobin level more than 10 gram, because once the hemoglobin level is more than 10 gram, the hyperviscosity increases, so the benefit will be attenuated. So that's the guideline. So that is possible. You can reduce the hemoglobin S level by the red cell apheresis, which is the most efficient way, or you can go for simple exchange transfusion. You know, so red cell apheresis is very expensive, it's not available in many of the part of our country. So you can go for the simple exchange transfusion. However, you have to also continue the other treatment also. Again, we have another 4 case series of the resistant vaso-occlusive crisis. What we have seen that if you go for the simple exchange transfusion with a median transfusion of 2 units only, there occurs a significant reduction of the vaso-occlusive crisis at the median time of say 2 to 3 days. So simple exchange transfusion is easy to administer without raising the hemoglobin level more than 10 gram, is very effective into our patients also. So the case number 4, SN female 28 years school teacher, married for 3 years. It's a case of hemoglobin SS with a vaso-occlusive crisis 4 to 6 times in a year. That is now she is asymptomatic after hydroxyl therapy with other supportive therapy. Her husband was evaluated who does not show any hemoglobinopathy. Now the parents or now the couple have really expressed desire to have the children also. Whether we could allow for the children or not. So this is again another landmark study, the first study in India. It's a prospective study. It was conducted in our institution with collaboration with the objective unit. So what we have seen, we have taken 60 female patients with homozygous, sickle cell homozygous, and we have controlled with the normal counterpart. So what we have seen that, so if we look at the maternal mortality is 0%. So with a proper treatment in an institution where all the facilities there, you can have a sickle cell mother, can have a baby with zero mortality rate. And look at the viable child. In 84.4% cases, we could successfully have a viable child, BCBS with 98%. If you look at the admission in the ICU unit, in a pediatric ICU unit, it's much more higher in comparison to the normal counterpart. And look at the incidence of the cesarean section on the second column. It's almost similar. It's almost similar. So 26% versus 24%. So sickle cell disease per se, though it's a high risk when pregnancy, should be done in an institution where all the facilities are available. The incidence of cesarean section remains same. You can have zero mortality rate. Still you can achieve the successful pregnancy in 84.4% cases. So pregnancy is safe and acceptable in sickle cell homozygous. This the study has given the message to the entire country. So now the case number 5 and 6 has been tagged up. She's a lady of 65 years old, Hindi female, having 5 children. She went to a surgeon 2 to 3 years back because she felt a lump in the left side of because of this splenic lump. And the surgeon was a smart one, she was a good surgeon. She did all the investigations like that. But whenever she saw these bony changes and look at the spleen, almost enter calcified scene. So the surgeon might suspected there could be some hemoglobinopathy and was referred to me. And she was a homozygous, sickle cell homozygous with the hemoglobin S brand to 80%. Look, 65 years old, having 5 children, so-called high risk pregnancy and getting detected at the age of even 65 because of some other reason. So do the asymptomatic patients need hydroxyurea or other treatment to prevent organ damage? Personally, I feel yes, hydroxyurea also can prevent organ damage, though I don't have any evidence or data to prove as evidence, but I still put all these patients. Once I know that there is a sickle cell homozygous, I put on hydroxyurea because it has many other benefits, including it prevents the organ damage also, as it has been seen in the pediatric patients in BeSHCON trial. Now the case number 6, it's a family members of sickle cell. The extreme right one is the father and the close one is the elder son. He was the engineering student in Bhubaneswar. In spite of our best treatment, he succumbed because of the acute chest syndrome. I escalate the right side or the up to 2 that check right side is a younger brother, again engineering student, apprehension with the apprehending that he could have similar effect. I escalated the dose of the hydroxyurea to 35 milligram per kg and my fear got through. Again he had an acute chest syndrome and he succumbed and we could not save him in spite of our best effect. So risk prediction is really unpredictable. In many cases, you cannot predict whether the patient is healthy or in the safe haven or what could happen. It's very, very difficult to predict in most of the cases. The factors contributing the clinical variability, there are many known factors like level of the hemoglobin F, higher is the hemoglobin F, lower is the clinical phenotypes. The gene cluster type, I told you that Indian haplotype versus Senegal, Benin, Bantu and Cameroon, there is a clinical variability. Alpha thalassemia mutations also attenuates the clinical severity. Environmental factors like social class, infections, diet, climatic change, they also influence the overall phenotypes. However, quite a sizable patients who do not know the answer exactly, what are the risks, why some patients are asymptomatic and why some patients really succumb for a sudden death in spite of your best effort. So this is a very interesting side. If you look at the clinical presentation of sickle cell disease, it's a spectrum. On one end of the spectrum, you have hemolysis endothelial dysfunction, where the predominant pathophysiology is a higher hemolysis or higher hemolytic anemia, which is characterized by high plasma hemoglobin arginase level, higher reticulocyte count, higher serum LDH, high bilirubin, and the pulmonary hypertension, leg ulcer, priapism, and strokes are much more common. So these are the phenotypes which are more common in the Senegal, Cameroon, and Bantu haplotypes. Where on the other end of the haplotypes, you have a viscosity and vaso-occlusion type, where you have a lower hemolytic rate, which is characterized by higher hemoglobin, higher plasma arginine, higher nitric oxide bioactivity, osteonecrosis, acute chest syndrome, and vaso-occlusive painful crisis. And look at the alpha thalassemia mutation. Alpha thalassemia mutation swings the pendulum from the left to right, so we have a more type of the viscosity and vaso-occlusion type. So our Indian sickle cells, they have a predominating or this right side phenotype, characterized by more viscosity and with all these many complications. However, there are many patients which can be in between these many spectrum, depending on which component is predominantly present in what component, the clinical features will vary. So there is a US FDA approval recently, hydroxy for children, L-glutamine, crizanlizumab and Baxlotor. I am sure there is a next speaker, is an internal speaker who will be talking on crizanlizumab. Then how to go ahead to manage the vaso-occlusive in 2021? You can go for a prevention with the lifestyle modifications, address to the precipitating factors. You should go for the vaccination. Hydroxyurea, L-glutamine and Baxlotors and crizanlizumab are the new approved drugs which needs to be used, or we need more data how to use in the best possible way. To conclude, ladies and gentlemen, sickle cell disease in India is a mild to moderate severity. So vaso-occlusive crisis is the commonest cause of the morbidity and mortality. The vaso-occlusive crisis should be managed by the experienced team. Hydroxyurea to all patients irrespective of the symptoms. So red cell transfusion should be utilized as per the specified indications with the extra care and adverse drug reaction. Iron chelation is not required in 90% of the cases. And so the pregnancy, though is high risk, is successful in 84 of the cases. L-glutamine, Baxlotor and crizanlizumab are new approved drugs. We need more data to use in the best possible way. So the best utilization of the drugs, we need new study how to use these drugs in which subset of the patient population. And the gene therapy PIPs in the horizon. And of course the prevention by control program should be priority because it's a huge social problem, has a tremendous socio-economic burden on our health problem. So the prevention is paramount important. So for even over and over its management. With this, I thank you for your attention and I will thanks for your attention.
Thank you, Dr. Jena, going for the excellent presentation on spectrum of the disease. So may I invite the next speaker, since the time management is an important part, question answer should be taken after the session. So may I invite our next speaker for the session, Dr. Julie Cantor. So, Dr. Julie Cantor, she is Director of the Sickle Cell Center and also Associate Professor of Hematology from the Okay, it's a virtual presentation of her lecture. So, thank you very much. Professor Cantor, please. Sound, please. Is there anything on? So I request all of you just to be patient, and since there are certain restrictions, so it will be a virtual conference and there are issues related to some sound. I think we'll sort out soon.
that while this was once thought to be a disease of red blood cells alone, and the fact that red blood cells sickle and get stuck in the microvasculature, while true, this is not the entire story of what's truly happening. And in fact, it's far more complicated. When we look on a microvascular level, we learn that the red blood cell is abnormal even before future of sickle cell disease, hydroxyurea, and beyond. These are my disclosures, conflicts of interest. So, learning objective. We're going to talk through some real-world cases today. Through these cases, we're going to review the pathophysiology of sickle cell disease, identify the clinical manifestations and complications, review the conventional therapies in sickle cell disease, understand how we are now using novel therapies in sickle cell disease, and then identify some of the unmet needs. We'll explore some of the barriers to care that individuals face. And we're going to start now with pathophysiology. So I start almost every talk with a slide that looks like this, because I think it's so important that we understand that while this was once thought to be a disease of red blood cells alone, and the fact that red blood cells sickle and get stuck in the microvasculature, while true, this is not the entire story of what's truly happening. And in fact, it's far more complicated. When we look on a microvascular level, we learn that the red blood cell is abnormal even before it sickles. It's at risk of hemolysis and breaking down, and by breaking down, it releases free heme. This free heme is very toxic to the endothelium, causing significant inflammation, and it acts as a nitric oxide sink. As a result, the blood vessel doesn't have enough residual nitric oxide to function normally. It also provides a stimulus for inflammation, white blood cells, and platelets to stick to the endothelium. And the endothelium develops a Velcro-like texture, which it allows to be more sticky, so that it's not just when the sickled cells stick, but also white cells and platelets that can cause a crisis. When we think about the clinical complications in sickle cell disease, we truly have to remember that sickle cell disease is a multi-system illness. It's important because when someone is headed for shoulder surgery, unlike our bone doctor colleagues, we can't just concentrate on the bones, but we have to make sure that they're healthy enough to undergo the surgery from a lung, heart, kidney perspective. We have to consider whether they can be transfused, what type of pain management they will need, what the risk is of acute chest syndrome. There is literally not an organ system that is unaffected by sickle cell disease. And it would take too long to review all of our system complications, but it is important to remember that preventative care can help with many of these issues, and that identifying them can help actually prevent complication. Moving on to Rory. Rory is a 32-year-old with hemoglobin S beta 0 thalassemia. At age 2, Rory had a stroke, leaving her with very mild right hemiparesis. And as a result, she's been continuously followed with hematology and receives erythrocytophoresis for automated blood transfusions every month. And our goal is to maintain a sickle hemoglobin percentage of less than 30%. Rory has required iron chelation with XJade, but she says it's nasty and doesn't want to take it. And current ferritin is 3,420. And she's very frustrated. She's had these ongoing transfusions. She doesn't like coming in every month and wants to know what else can she do at this point for her sickle cell disease. Again, we do a comprehensive workup. We especially look for red blood cell alloimmunization and antibody formation. We do urine studies for proteinuria. We refer to ophthalmology. We also assess the liver iron concentration, not just with a ferritin, but with a liver MRI. We look at cardiac function, and then we also look at brain MRI and MRA to better understand what type of stroke she had and what her blood vessels look like at this point. We know that blood transfusion is a disease-modifying therapy in sickle cell disease, and that it can prevent acute and chronic complications. We use 3 different methods of doing transfusions. One is a simple transfusion, or a top-up. We also do manual exchanges. This is where we withdraw blood through phlebotomy and then give blood back. And we do automated red cell exchanges. There are several complications, unfortunately, of transfusion. the biggest being iron overload, and second, alloimmunization and antibody formation. We also have seen hyperhemolytic transfusion reactions that can actually cause death and transfusion-associated circulatory overload. Simple transfusion, of course, does not remove a patient's hemoglobin S-laden red cells, but only transfuses healthy donor cells. Manual exchange, as I mentioned, is where we remove cells by phlebotomy and then give blood as a simple transfusion afterwards. This does help with iron exchange, but it's not nearly as efficient as the automated red blood cell exchange. Automated red cells exchange remove defective red cells, replaced with healthy donor red cells simultaneously, and is iron neutral as well as highly efficient. Iron overload remains a problem that I think we're just beginning to understand in sickle cell disease. In a much earlier study of 141 adults with sickle cell, 7% with iron overload, we saw a strong association between iron overload, hepatic cirrhosis, and myocardial fibrosis. In a subset of 31 autopsies, 7 had significant hepatic iron overload, and of those, 43% had both cirrhosis and myocardial cell iron deposition. We don't completely understand how this iron overload is correlating to death, but we know it is prevalent and contributing to our death in adults with sickle cell. Alloimmunization is an immune response to foreign antigens. It increases the difficulty, as everyone knows, of finding medically necessary compatible red blood cell transfusions, especially in life-threatening situations. As a result, we recommend not just matching at the A and B antigens, but also matching at C, E, and KEL antigens. In the United States, we have a primarily donor population that is Caucasian, and a primary sickle cell disease population that is African American. As a result, there's a difference, and that increases the risk of alloimmunization. In addition, however, it's not just this discrepancy between our donor and recipient. Instead, it's also specific to sickle cell disease. We know that chronic inflammation and immune dysregulation promotes alloimmunization, making it significantly worse in sickle cell compared to other hemoglobinopathies. So we do a comprehensive workup for Rory, and she is in fact well exchanged. Her hemoglobin S is 22%. Her hemoglobin is 9, and her retic count is suppressed as we want it to be at 2.3%. Her ferritin, however, is 4,300, and her liver iron is a very high at 15 milligrams per gram. Her echocardiogram, thankfully, shows no significant dysfunction. When we look at her brain, we can see an old ischemic infarct on the left, but we also see bilateral intracranial stenosis of the MCAs and significant left-sided stenosis with what we begin to see of moya-moya disease. So what are Rory's next few options for treatment? Well, unfortunately, right now, in individuals with significant vascular disease, red blood cell exchange is the only optimal treatment to prevent a secondary stroke. We know that hydroxyurea can prevent stroke if given prior to brain injury, but after a stroke, we also know that transfusion is our optimal option. However, transfusion, perhaps transplant, would be an option for someone like Rory. So she's heard about gene therapy and says, is this possible? We understand that sickle cell is amenable to gene therapy. Sickle cell disease is caused by a mutation in a single gene. So if we could just deliver a functional gene, could this reduce the symptoms of the disease? Gene therapy would prevent the need for a matched donor, would prevent graft versus host disease, and further, would make gene therapy and therefore potentially a cure more available. There are 3 different types of gene therapy being studied: gene addition therapy, gene transfer, and gene editing. Stem cell transplant, however, is another option. It is the only known cure at this time for sickle cell disease. And results of many studies show that transplant from a match-related donor, especially in children, can result in an 85% to 95% chance of cure. But there are risk versus benefit considerations, especially for adults who have accrued more sickle cell-related morbidities with age, such as this patient. And many people don't have a match-related donor. So we're now looking at half-matched or haploidentical transplants as another option for improved outcomes and quality of life in sickle cell disease. Moving on to Ronald. Ronald is a 27-year-old with hemoglobin SC disease. He had done well for many years without a lot of pain. He was on hydroxyurea when he was younger, but he really didn't feel any different, so he stopped taking it after several years. He does take folic acid, he takes intermittent ibuprofen, and tries to avoid the ER whenever possible. However, in the last 4 months, he's had to go to the ER almost every month and has been admitted. And he's frustrated and wants to try something else to decrease the number of pain crises. So what are the unmet needs in sickle cell disease? Well, first, hydroxyurea is not the best medication for everyone. It doesn't work for everyone, and some people can't tolerate it. We see hydroxyurea breakthrough, especially in patients who've been on it for a long time, and they start to continue to have crises. For hemoglobin SC disease, like this patient, there isn't a clear optimal therapy, and hydroxyurea doesn't always work, even less than it does in SS disease. We've discussed iron chelation. We need better options, things that are easier for patients to tolerate. And we need improved medications to treat acute vaso-occlusive crises. While we have improving preventative therapies, when someone has an acute crisis, we have very few options. We also need a universal curative treatment that is available and cost applicable. And we need better organ-specific therapy. We see at least 10% of adults having severe renal disease. So what can we do to prevent that specifically, not just prevent pain? So thinking about the factors we talked about earlier and the targets, we specifically are looking at sickle cell disease options to prevent the vasculopathy or vascular disease. Well, fetal hemoglobin induction, not just with hydroxyurea, but gene therapies and other new agents, can that prevent some of the vascular morbidities that we see? How do we prevent this multicellular adhesion that we know is damaging the endothelium and really resulting in the end organ injury? Oxidative stress from hemolysis and inflammation is also causing endothelial permeability, which is resulting in not just additional pain and swelling, but also end organ disease. Inflammation, this is truly a chronic inflammatory condition, and we know that long-term inflammation is also increasing the scarring of endothelium. We understand that selectins mediate white blood cell adhesion and rolling, and that selectins are expressed on endothelial cells, platelets, and leukocytes. P-selectin and E-selectin mediate rolling and tethering of blood cells to the endothelium. And we also understand that selectins and neutrophils can initiate vaso-occlusion even without a sickled cell. In animal models, where we've disrupted or bred mice that don't have certain selectins, we can actually see an interruption or complete ablation of crises. We've been focusing on P-selectin and E-selectin, as these are the most prevalent and seem to cause the higher amounts during crisis. P-selectin is expressed both on platelets and endothelium, where E-selectin is specifically focused on just the endothelium. Crizanlizumab is one of the agents that we've been studying and know the most about. Sickle cell-related pain crises were what a vaso-occlusive crisis was called during the SUSTAIN study. We understand that P-selectin plays a huge role in sickle cell disease vaso-occlusion. Crizanlizumab is a humanized IgG2 antibody that inhibits P-selectin. The SUSTAIN trial is a phase 2 randomized trial of crizanlizumab compared to placebo in patients who are aged 16 to 65 and who had had at least 2 and not more than 10 crises in the year prior to starting the study. A VOC was defined as pain that required acute care intervention. Patients were randomized to 2.5 mg per kg or 5 mg per kg or placebo. And in patients who were receiving the higher dose of 5 mg per kg, we saw a significant 43.5% reduction in the high-dose crizanlizumab group during the trial. It's also important in that patients were often already taking hydroxyurea, so we looked at individuals both on and off hydroxyurea as part of the trial. Looking at these graphs, the y-axis is the median rate of VOCs per year, and the x-axis is patients who are treated on crizanlizumab or placebo. In this left graph, you can see patients who are already taking hydroxyurea, and quantitatively as well as statistically significantly, a decreased number of crises. Patients who are not taking hydroxyurea over here on the right, you can also see a significant decrease in the number of crises. We also wanted to understand if this drug was effective not just in people with SS disease, but other genotypes. On the left, again, you see people with SS disease, and you can see significant decrease in number of crises during the sustained trial. On the right, you can see other non-SS genotypes, and again, you can see a significant decrease in the number of crises for patients treated. So for Ronald, we discussed potential therapies. We talk about hydroxyurea, even though he's had it before, glutamine, L-glutamine, and crizanlizumab. Ronald says, I am just not good at taking medicine, and wants to try crizanlizumab, given intravenously every month. After 3 months, he says, I don't know if this is helping, but he hasn't been to the ER recently. And after 3 more months, he says, I feel the same pain. Well, I feel the same as I did before. But then when he thinks about it, he realizes that he has not been to the hospital at all in the last few months or taken as much pain medicine at home. However, on a day-to-day basis, we sometimes see that patients don't feel any different. And so it wasn't until we presented Ronald with the understanding of his decreased number of crises that he recognized his own improvement. And he says, wow, this must be working, and agrees to continue. So what is our current crizanlizumab experience here? Well, we've had crizanlizumab approved in the United States since November of 2018. And in my institution, we got the approval to initiate using it in January of 2019. Here at UAB, we treat about 500 individuals with sickle cell disease, adults, in my clinic. Our pediatric clinic takes care of about 900. We have about 60% of our patients with SS-type sickle cell, and about 60% of those on hydroxyurea. We have 11% of our total patients on chronic transfusion. And in the last 15 to 18 months, our program has grown substantially. And we went originally from about 370 patients to 500 patients. We have what's called a specialized medical home setup. So we have clinic available 5 days a week, and that includes an infusion center where patients can come for acute pain crises. We have apheresis and transfusion. We have a primary care doctor at the same program, so patients can see both me, the hematologist, as well as a primary care doctor in one visit. We have a pharmacist, we have a case manager, and a social worker, and specialized nursing staff, and 2 hematologists, myself and my colleague, Dr. Ogunshile, who rotate through. So at the time that I put this presentation together, we'd had 45 patients who'd been prescribed crizanlizumab, and 37 were still receiving it. Overall, patients reported, this is the best thing I have done. This is even better than my hydroxyurea. I can't tell a difference, but my wife notices I'm better. Or, surprisingly, I had 2 different patients tell me their legs hurt less at night. That was important because we have not heard or studied the effect of crizanlizumab on chronic daily pain. Now, I mentioned that not everyone continued taking it. So why did some people stop? 2 people had an infusion reaction. One of those was an increase in pain when they received the medication. This did get better when we stopped, slowed the medication, and gave Benadryl. But that individual did not want to continue it. Of note, that individual has now gone back to taking it and is actually doing much better. The second person had a true anaphylactic reaction with some shortness of breath, which we know can happen with any medication. 3 people said they had more pain after taking it or felt their pain hadn't improved. 1 moved, 1 had transportation issues, and 1 was fired from our clinic. So what are the barriers to care in sickle cell disease? Well, there's a lot of issues with chronic pain and the perception of addiction. This contributes to issues with racism, frequent visits, because if patients aren't getting the care they need, they get more and more pain or other problems requiring emergency department and acute care visits. There's a clinician and patient knowledge deficit, and there's often a discrepancy in which our patients know more about their disease than the clinicians. And there is a significant amount of stigma that contributes to the chronic pain and perception of addiction. We know there are significant negative attitudes and stigma. These are based often on previous experiences. Patients report being treated rudely or being intentionally delayed, and in fact will sometimes avoid the ER completely. There's a lot of misbelief and distrust that goes both ways. Physicians and providers not trusting or believing patients, and therefore patients not listening or believing doctors. They're often very knowledgeable about their care and their disease. So when a patient comes in and says, I know when I have a severe crisis that hydromorphone, 2 milligrams, works well for me, that can often be mistaken as clearly this patient is a drug abuser in the emergency department. So just educating patients has been insufficient. We have to also educate our colleagues. There's also system-level barriers. There are not enough people or providers understanding sickle cell. There's not enough centers that treat sickle cell disease. While sickle cell is more prevalent than hemophilia or cystic fibrosis in the United States combined, when we were actually funded, there were only 10 comprehensive adult sickle cell centers funded. For the record, they're not funded at all anymore. And over 100 each for hemophilia and cystic fibrosis that received federal funding. So even though we have newer medications that may even work better, less than 50% of people who could get these medications are being offered them. So a lot of people have asked, how do we identify with all these new therapies, the right patients for the right therapy? We think a lot about patients' current concerns with their sickle cell disease. What bothers them? What is going to motivate them to feel better? What are their goals for their disease treatment as well as their life goals? I often start off the conversation with a new patient about what they want to achieve, not just as far as their disease, but do they want to work? Do they want to go to school? Do they just want to feel well enough to get up in the morning and take care of their children? How far away do they live from a sickle cell center? How can I help get them to and from? And what other support systems do they have in place? Or how can I help connect them to other potential support? Finally, we have Ray, a 40-year-old SS-type disease. He's very proactive, very compliant. He's had 4 crises in the last 12 months. He always calls and lets us know when he's in crisis. He's managed 2 of these at home and 2 had an ER visit. He has had a history of priapism. He also has hypertension, and he does very well taking his medication every day. And he's been on hydroxyurea for the last 3 years, and notice it helps. Well, the first thing we would do in someone like Ray is look at whether the hydroxyurea dose is sufficient, or should we increase it? Ray clearly has no issues or concerns with taking medicine. So this is someone we might talk to about L-glutamine, or if he has low hemoglobins, we might talk about voxelotor. Now, it's important to remember that voxelotor, thus far, has only been proven to increase hemoglobin and not necessarily to decrease crises. So we have a real conversation about the pros and cons. This is someone who's less likely to be interested in crizanlizumab, though I always explain it to everybody and give them options. And we sit together and form a shared treatment plan. And he's someone who often will choose a medication like voxelotor or L-glutamine in addition to hydroxyurea. Finally, Destiny. We have a lot of Destinies in my clinic. Destiny is 21, she has SS disease, and she does not and will not take hydroxyurea. She doesn't want chemotherapy. Nothing you can say to her will tell her different. She's had only 2 crises in the last 12 months. She almost never comes to the ER. In fact, it's even hard to get her into clinic. Really, Destiny just wants to pretend that she doesn't have sickle cell disease. So we talked to Destiny about how we can help prevent her from having complications, about the importance of frequent, at least twice-a-year visits so that we can monitor her kidney dysfunction. We can monitor any concerns for retinopathy. We can monitor for any other new issues that arise. Destiny might tell us that her grandmother's on dialysis and that she understands that kidney disease is serious, and that will have her coming into clinic a little bit more. We do talk about hydroxyurea, but as I said, she has already decided she's not taking it. So we talk about other preventative therapies. and most importantly, staying hydrated and drinking water and taking good care of herself, including not smoking marijuana or drinking alcohol. And usually we have a conversation about life balance and care balance and trying to make sure that she can keep herself healthy. So hopefully you feel that we've covered a lot of information today. We've talked about pathophysiology of sickle cell beyond our red blood cells, the clinical manifestations and complications of sickle cell that certainly include pain but also exceed pain, the unmet needs in sickle cell disease, what we're doing and how we're using novel therapies in sickle cell, what our current crizanlizumab experience has been here, some of the barriers to care in sickle cell disease, and how important it is that we individualize our care for our patients. We know our individuals are living longer, but we have to help them live longer, stronger, and better. I am very pleased to be here today and to be talking about the future of sickle cell disease, hydroxyurea, and beyond.
Now we have a very live and lively program, that is panel discussion on vaso-occlusive disease in sickle cell disease. What is the reality? The moderator is Dr. Priyanka Samal. Dr. Priyanka Samal is an alumni of IHTM and she is presently consultant and head of the Department of Clinical Hematology and Hemato-Oncology in Institute of Medical Science and Sam Hospital, Bhubaneswar, under Shikha o Anusandhan University. And her areas of interest are hemato-oncology and sickle cell disease. The other panelists are Dr. Ashutosh Panigrahi, Dr. Asif Iqbal, Dr. Monisha Jain, and Dr. Sumit Mitro. I shall request Dr. Samal to introduce the panelists and start the panel discussion.
Thank you to the chairpersons and thank you to the organizers. From my behalf, I give my obligations to my teachers all present over here. I am alumni of the student and a student of IHTM. Thank you for the live opportunity. We have been in virtual world for the last 1 year. And to continue the session, we will have 2 case discussions on sickle cell disease. These are the cases which we have experienced in our department. And as we know that Odisha is a sickle cell belt, so we deal with a lot of sickle patients. And then to start with my panelist, I invite Dr. Ashutosh Panigrahi from AIIMS Bhubaneswar, Dr. Asif Iqbal from Guwahati, that is a cancer institute in Guwahati, he is my junior, Dr. Manisha Jain, presently working at Gurgaon, and Dr. Sumit Mitra, he is presently at NRS Medical College. It's not moving. Slides are not moving. Yes. So case 1, this is a 23-year-old female visited to the local physician with a complaint of severe pain. There was no sign of trauma-related injury, significant skeletal-muscular pain on and off with abdominal discomfort and fever on and off. She was recently operated for cholecystectomy for gallstones 2 months back. There was history of hip surgery 9 years ago. She does not have documents of that. No history of jaundice or any other chronic illness were present, and on examination there was mild splenomegaly with pallor. So we investigated her and the hemoglobin was 8.5 gram%, TLC was within normal limits, but there was neutrophilia on differential count. Hematocrit was 20.7%, indices, RBC indices were normocytic normochromic, and RDW was 15%. Platelets were normal and coagulation profile was also normal. She had an HPLC which she had brought from a outside lab, and it showed hemoglobin S was 62.2%, HbF of 15.7% and hemoglobin A of 3.4%. So my questions to the panelists would be, how do we investigate for organ damage in this patient, and do we investigate in our clinical practice, do we investigate each of our patient once they are diagnosed as hemoglobin SS disease for the organ damage? We can start with Dr. Ashutosh.
Thank you. Hello. As we know that sickle cell disease is not a sickling only, it is a multi-system disease. So definitely, though the patient is presenting with pain, definitely he will be having all the systemic diseases as Hello. All the organs in the body are affected by sickle cell disease. So definitely whenever you are getting a patient of sickle cell disease, don't forget to evaluate all other organs, because this is the practical scenario or day-to-day scenario. First time a patient is coming who is diagnosed sickle cell disease and not properly evaluated because lack of proper treatment centers for sickle cell disease. So definitely yes, all organs that are prone for affection by sickle cell disease should be evaluated on first visit to the hospital.
Yes, this patient also had a history of the hip surgery as well as cholecystectomy, so other end organ damage should also be investigated in this patient. But an asymptomatic person may not require all the investigations at the outfront. So how do you define a VOC? Can I ask the second question to Dr. Asif?
Ma'am, VOC, vaso-occlusive pain crisis, is defined as any episode of pain which brings the patient to the hospital or which requires pain medication. So we usually identify vaso-occlusive crisis purely on the basis of patient's history.
Yeah, a lot of importance has been put on pain in sickle cell disease. If you look at the ASH 2018, 19 and 20, they have been addressing the issues of acute and chronic pain. Previously, we just used to know that it is a VOC which is causing a pain in sickle cell disease, but now it has been put up like acute intermittent pain, chronic daily pain, and acute on chronic pain. And if we look at what we practice and what we get in our patients, more of emphasis has been put on opioid withdrawal pain and the neurologic pain, which is more observed in the patients having the African Americans. But in our cases, when we look at our day-to-day OPDs of sickle cell patients, the pain is not the way which has been described in the ASH book or the African Americans. So it is a little bit different, and therefore we need to know what type of pain the patient is going through. So according to the discomfort, how do we, this is for Dr. Manisha. According to the discomfort reported by the patient, how do we characterize it? According to the intensity of pain assessed by the nurse or the physician, only the one that brings the patient to the hospital, only the one that needs parenteral opioids, only the VOC complicated by fever or other symptoms. Do we base our VOC according to it, or all the episodes are considered as VOC in sickle cell disease patients?
Thank you for the question, ma'am. Ma'am, VOC can be defined by any episode which is related by the patient intensity. Whenever patient complains of pain, irrespective required hospitalization or opioids or not, it is VOC.
Yeah, even if they are taking analgesics at home, still they
Yes.
are considered to be VOC.
Episode,
And these
yes,
are the
yes.
daily chronic pain which the
Pains.
patients suffer from. And this is what is not actually evaluated by the nurses or the staff. And even we as physicians, we try to ignore those sort of pains. But that is what is the importance of pain, and why so much of emphasis is being there on pain, because of the newer agents which have a very important criteria. The VOC should be more than 2 episodes, at least for 6 months or for 12 months, whatever the trials are on. And this is what we need to understand about the disease. So how do we normally in our clinic assess the severity of pain in a patient with SCD? Dr. Sumit, can you take up the question?
Thank you, Dr. Priyanka. So we have many tools for assessment of severity of pain. For example, we have the unidimensional tools like the visual analog scale, or we have multidimensional ones like the health-related quality of life index, or there is the McGill's questionnaire. So by these we can have a assessment of how the pain is impacting the livelihood of the patient's daily activities.
Yes, so this is the one which is actually available in the OPD tickets also, or else in the indoor tickets also, and this is the most of us use this, very user friendly, taken up by the nurses and the residents who are there in the wards. But apart from that, actually in the ASH by Dr. Deepika, she has mentioned a very good article in 2017, pain measurement tools in sickle cell disease. Where are we now? And here you can see that there are multiple aspects which have to be kept in mind while assessing the pain in a patient with sickle cell disease. You can go through this article. It is a good article for the juniors. How do you manage pain in sickle cell disease with VOCs? Again, Dr. Ashutosh, what is our way of managing the patient? Since morphine is not readily available to us in India, what is our way of managing the patients of SCD with acute pain?
Okay, so first of all, it is an emergency department management. We keep the patient for 6 to 8 hours in the emergency department with a target to absolute zero pain during that period. If it is not possible, we will admit this patient. There are two parts. One is control of pain. Second is the taking care of the precipitating factors that has produced the pain. And third part in the management will be what are the other associated conditions that is precipitating the pain other than the comorbidities and psychological aspects. So hydration, if there is anemia, blood transfusion. In addition, the control of pain, usually the gold standard is opioid, but if it is not available, then we start with usually tramadol, paracetamol. Then if it is not controlled, then we add in that. If it is very severe pain, we can use NSAIDs like ibuprofen, but not other NSAIDs, but that to be very short period of time and in specific populations. So these are our practical pain management in OPD basis. If at all after that it is not controlled, then we go for either photoinfinergan, any sort of sedation, or we can go for ketamine based on the scenario and what is the drug available. But in our setup, in our OPD and emergency department, we have now opioid available, so we are able to give both injectable and oral opioid to our sickle cell patients when they come to the emergency department.
Yes, and another thing, we also use buprenorphine patch. That is also very good, 20 microgram per hour. It can be there for 7 days, 4 days accordingly, and you can change it. Anything to add, Dr.
Actually, morphine is available. So we usually start with tramadol plus paracetamol, and if it is not controlled, then we add, we start tapentadol, and if it is not done, then do morphine.
Yes,
so
and another thing to mention, just an update, that previously a lot of emphasis was there for hydration of the patients, but many a times they have said that in elderly patients, now we see even elderly patients 40 years and above who might be having some PAH so they may land up in fluid overload. So that is why they have said that you have to judge the patient. If the patient has dehydration, go for IV fluids, or else you can encourage oral fluids to these patients. So what are the measures taken to prevent VOCs? This is important because whenever we serve a patient of SCD, apart from treating the crisis, they should also know what are the measures they should take so that they can prevent VOCs. So Dr. Manisha, you can take up the question.
It's seen that every time VOC is precipitated by any trigger. So avoidance of the trigger is the main treatment for these patients. Avoidance of dehydration, avoidance of infection. Vaccination should be up to date for these patients. That is the prerequisite everyone should understand. Change of temperature, wind speed, these are also found to have precipitate the VOCs. So this has to be taken care. Any trigger which patient understands better than us should be avoided.
Yes, Dr. Ashutosh, yeah, thank you. Dr. Ashutosh just mentioned that in case a pain is not controlled, acute pain is not controlled in a patient of sickle cell disease having a crisis, in spite of all the analgesics we have given, what is the role of transfusion in this scenario as per the latest guidelines, and when to transfuse, how to transfuse?
So transfusion, basically the trigger is the pain control. If it is anemic, means hemoglobin is less than 7 gram per deciliter, we give top transfusion. If the hemoglobin is high and it is not controlled by our conventional analgesics, then we go for simple exchange transfusion or automated exchange transfusion. So before transfusion, we should do a extended grouping and cross-matching of this patient and identify the allo antibodies if at all it is present in the patient. And if the patient is having, in addition to pain, other symptoms like any neurodeficit, irritability, or symptoms of acute chest syndrome, then also we don't hesitate to initiate exchange transfusion early, not top transfusion.
Yes. Yeah, sure.
In this particular patient, is transfusion needed?
If the pain is not controlled, I asked if the patient's pain is not controlled with the routine analgesia which we have given and the hemoglobin is less, then we can give a top-up transfusion. And if the hemoglobin is, we have some next slides on it, even if the patient has a hemoglobin of 12, in those cases you have to go for an exchange transfusion if the pain is not controlled. The whole idea is to keep a HbS level low. So since this patient was hydroxyurea naive patient, do we decide to start hydroxyurea to this patient? Dr. Asif?
After the pain is controlled, we should start hydroxyurea. There are many benefits of hydroxyurea. First, it increases the hemoglobin F level, and so the percentage of hemoglobin S should decrease in such patients. Automatically, the sickling crises will decrease. Secondly, it also alters the RBC membrane properties and adhesiveness. It decreases the leukocyte count. So overall, it has been seen that with hydroxyurea, we start with 15 milligram per kg. Per day, and majority of the patients benefit with reductions in the number of vaso-occlusive crises.
Yes. So just a question to all the panelists over here. If we receive a patient in crisis and the patient is admitted with an acute chest syndrome in the ICU, would you like to initiate hydroxyurea? If the patient was a naive patient, would you like to add on hydroxyurea at the outset in ICU?
No. We usually first control the pain. We give proper hydration. And we control the confounding factors. If the patient has acute chest syndrome, fever, cough, all those things are controlled. Then on discharge, we use hydroxyurea.
Yes, after stabilizing the patient, we can start. But if the patient was on hydroxyurea, we may even continue to bring down the counts which bring about the free radical injury to the organs. So this patient was given hydroxyurea, starting dose of 15 milligram per kg for 6 months. Her pain episodes decreased but not fully subsided, and she had some GI disturbance. Repeat HPLC, HbF was 25%, sickle percentage was 28.9, and hemoglobin A was 55%. So, do you see patient with normal hemoglobin level who are having recurrent ongoing pain even after hydroxyurea therapy in your clinical practice?
Yeah, of course. It is quite possible that people on hydroxyurea, they are having pain and are not controlled by analgesics. So there are patients.
So we may have hemoglobin up to 13-15% also having a patient with on hydroxyurea therapy having VOCs. Because most of the sickle HbS level will be around 80%, 90% in those patients. What would you like to do in this type of a patient?
So practical scenario is most of the patients, they have in their mind that so long taking a drug which is used in malignancies or cancers may harm someone. So that is a stigmata that is associated with hydroxyurea therapy. So many patients, they stop hydroxyurea treatment in between intermittently. They take, stop, that goes on. And another thing is hydroxyurea dose. We are, most of the times, we practically do not assess whether this patient is responding to hydroxyurea by our MCV value, or hemoglobin rise, fetal hemoglobin rise, transfusion requirement. It is not properly assessed. This is the practical scenario. Those who are adherent to hydroxyurea therapy, definitely with dose modification, the crisis rate is less, but still there is a possibility of pain crisis with hydroxyurea. So in that condition, most of the situations, newer drugs are not available to us. We have tried giving glutamine in addition to hydroxyurea. There is some pain control, but it has not stopped the pain or had not given a good quality of life to most of the patients. But I think in our experience, it will be around 40 to 50% of cases, patients, they have had benefit with addition of glutamate. And few patients we have kept on exchange transfusion or top transfusion to maintain adequate hemoglobin level and lowering the fetal hemoglobin level. And other supportive measures of pain management, psychiatric counseling, giving antidepressant, like this we can manage. But now there is availability of crizanlizumab has given some hope. We have only short experience and only few patients we have tried. but we cannot tell that yes, it is effective at present.
So one of the major challenges is that we are unable to increase the dose of hydroxyurea to the maximum tolerated dose. And what are the causes for hydroxyurea failure? As already said, adherence first to be checked in our patients. Most of them are not willing to take the drug every day. Adverse events, very rare in our patients because we do not go up to the maximum tolerated dose. The adverse events are more profound when we increase the dosage of this drug, and failure of hydroxyurea. So we have some slides on failure of hydroxyurea in the later part. So this was a study in which they have intentional and unintentional non-adherence to hydroxyurea among patients with sickle cell disease. So even after so much of counseling in Western world, we find that there is non-adherence to hydroxyurea. Leave apart in our clinical study, in our clinical day-to-day situation, we do not have enough of time even to counsel each of the patient how to take the drug, how long to take the drug, what are the side effects or the adverse events of the drug. So only 25, in this study it had shown that only 25% of the patients of SCD had adherence to the drug. Adverse effects, hematological, non-hematological, very rarely experienced in our clinical practice, and as already said by Professor Jena in his previous slides, most of our centers, they start at 10 milligram per kg, which is goes up to maximum 500 per day, and a very less amount of any adverse events is seen in this drug. So this patient, to continue, she had lost to follow-up for 1 year, and then after 1 year she comes back with severe pain, anemia and leg ulcer, and had developed higher level of serum creatinine, indicating possibly kidney injury. Patient had around 6 episodes of pain affecting the joint and abdomen during 1 year, and was managed with IV NSAIDs locally and acetaminophen. During last 1 year, she received 1 unit blood transfusion. She has not been taking hydroxyurea for last 1 year. So how do you attribute these complications now that she has presented? Possibly the creatinine is... Yeah.
So this is one thing that actually I disagree. So we should not use NSAID. I do not know what the majority of the centers do, but in our places where the follow-ups are not that regular, we will not be able to use NSAIDs. So even with majority of our patients are very easily controlled with morphine, oral morphine. So we should stick to the opioids to manage the pain crisis. So the possible reasons of the kidney injuries may be the vaso-occlusive crisis, repeated vaso-occlusive crisis itself, or it may be the use of non-steroidal anti-inflammatory drugs.
Yes. So what next would you like to do with this patient? Yeah.
Okay. So now she has come with another episode of painful crisis?
Yes, he comes back with severe pain, anemia and leg ulcer.
Yeah, so now we have to again reassess this patient, and we will have to do just like we have done before. We have to again start this patient on opioids, we have to give oxygen, we have to start hydration and treat this acute episode.
Yes, we restart at the dose she was on, or we escalate the dose of hydroxyurea.
Yeah, so now this patient is hydroxyurea intolerant. So this is a situation where...
she had not been on hydroxyurea for last 1 year. She had left it on her own.
No, but she has come back with a leg ulcer.
But that might be because of the vesicle itself.
Okay. So we have to then continue the hydroxyurea dose.
Yeah, we started for her with the same dose. Once she tolerated, after 3 weeks, we went up to 20 milligram per kg because she had still the creatinine was not very high. It had subsided, and the leg ulcer, but the patient came again back with the leg ulcer after 1 month. At this point of time, would you like to continue hydroxyurea with the escalated dose, or you would like to come down?
In fact, we can escalate the dose of hydroxyurea even further, or we can start using alternative therapies in these patients. So we have some available alternative therapies.
But this time when the dose was high and the leg ulcer persisted, we could not increase the dose any further. Maximum dose is still 30 milligram, that is according to the Western literature. We have not gone up to that high. So now we come to what are the causes of hydroxyurea failure. As we said, adherence. And to define the failure, it is important. Failure to respond to hydroxyurea is defined as failure to reduce the frequency and severity of VOCs at the maximum tolerated dose. Then only we say it is a failure. Failure of response should be assessed on clinical criteria rather than on the lab criteria like MCV, ANC, etc. And a significant proportion of failure is due to non-adherence or failure to escalate the dosage, which we find even in our clinical practice. So now, since the patient is having leg ulcer, we could not escalate the dose further. What would you like to do in this patient? And what is the role of the newer therapeutic agents? Dr. Sumit, you can take up the question. How would you
Now, the maximum dose of hydroxyurea as reported in Western literature is 30 mg per kg. But due to various reasons, we cannot go up to that high dose. So we must think of some other alternative like hydroxyurea. In place of that, we can start with glutamine, which is available in India readily. So it's an oral drug, compliance is good, taken twice daily. And even if the patient fails to respond to that glutamine or hydroxyurea or combination of both, then we can shift to IV crizanlizumab.
Yes. So previously when we did not have these drugs, even blood transfusion was one of the options to put on these patients so that the healing of the ulcer, leg ulcer can be better. And with the advent of the new drugs, we now have multiple drugs which are available, but based upon their cost, finances, how the patient can reach us, that is what decides the management next in these patients. So these were the new drugs which had already been discussed. We'll go to the next case. This is a 38-year male with hemoglobin SS disease presented for a follow-up visit. He has a history of 10 years of chronic pain in his low back, knees and hips, describes pain as tingling, aching and throbbing with sharp radiation to bilateral lower limbs and is exacerbated by physical activity and relieved with rest. Reports intermittent swelling of his hands and feet, morning stiffness in the small joints, chronic fatigue, decreased sleep at night. So with this, when we examined the patient, he was afebrile, RR was normal, blood pressure was almost normal, SpO2 94% in room air. He was morbidly obese. He has bilateral swelling of the knees, feet and hands. The range of motion evoked pain in all the joints. So on evaluation with the lab findings, hemoglobin was 9 gram%, MCV was 63, microcytic hypochromic, retic was 4.5%. TLC, there was TPC, the platelet counts, thrombocytosis. TLC was 6,100 with NRBCs of 10 per 100 WBC. HPS was 88%. Serum electrolytes normal, vitamin D was low and RFT was normal. So with this history and physical findings, what would you like to further investigate in this patient of yours?
Though she is sickle cell homozygous, there is high chance that it will be a chronic pain associated with sickle cell disease, but other arthropathies or immune inflammatory arthropathies, osteoporosis, means joint damage due to sickle cell disease, those things has to be also considered for evaluation of chronic pain in these type of scenarios. Then recurrent bleeds and infection also should be taken into consideration because these are also immune compromised patients. So these are the other things that need to be evaluated.
Yes, looking at his joints actually, we also, and it had been there for last 10 years, ANA was done, CRP, ESR, routine urinary and the X-ray of the joints were done. CRP, which is elevated in both the cases, since sickle cell disease is also an inflammatory condition, may not guide you, but baseline CRP and then follow-up can say whether the disease activity is high or not. So these were the X-rays for the patient, and even when we did the hip joint, there was left avascular necrosis of the head of femur. So ANA titer was high, CRP was 5.5, ESR was high, RA factor was positive for the patient and anti-CCP was also high. So the final diagnosis of the patient was sickle cell disease with seropositive rheumatoid arthritis with anemia of chronic disease. He had at that time microcytic hypochromic anemia and avascular necrosis of the left hip joint. So in this case, since the pain has been there for constantly, dull aching pain has been there for last 10 years, which he used to mention, how would you manage this case? So just a little bit about the chronic pain, I wanted to put this case because we do not often think about arthritis in a patient of sickle cell disease. So this has to be kept in mind, and chronic pain means more than 6 months duration. It should be a dull aching pain which is there. This is regarding the neuropathic pain which the patients also develop, but we do not have much of opioid withdrawal pain in our patients, though central sensitization and vaso-occlusive pains are the ones which we encounter. So for this patient, we had to go for a multidisciplinary approach. So Dr. Manisha, can you say how do we manage this patient having rheumatoid arthritis as well as sickle cell disease and a pain which is hurting him for last 10 years?
Ma'am, as the patient is having sickle cell disease with rheumatoid arthritis, so a multidisciplinary approach involving rheumatologist is required so that the rheumatoid arthritis disease has to be controlled. Patient should have adequate analgesia and use of other agents like amitriptyline, gabapentin that relieves his neuropathic pain can also be considered in these patients. Also, if pain is not relieved with this, exchange transfusion or simple transfusion depending on hemoglobin level can be considered in this patient.
So to have a good quality of life is also a very important part while managing chronic pain, and it has to be a multidisciplinary approach. So the causes of pain in our patient was here ischemia mediated VOC of sickle cell disease because of the underlying sickle cell he had 88%, destructive inflammation of multiple joints for the rheumatoid arthritis. He was seropositive RA, that means he had more of pain than a seronegative RA patient. The patient was, initially when we discussed with our rheumatologist, they had started with a high dose steroid in this patient, and that should be kept in mind because it can cause exacerbation of pain, and AVN can be exacerbated when we give high dose of steroids. And nighttime hypoxia, as he was morbidly obese, he is a contractor by profession, and because of the pain he had been in home for, he had restricted his activities. Obstructive sleep apnea was also a contributing factor for hypoxia and vitamin D3 deficiency. So we had even involved a pulmonologist for that. And since he has multiple comorbidities, this is a patient of sickle cell who should not only be started on hydroxyurea, but other new agents should also be kept in mind while considering management of such patients in 2021. So as I said, patient was started on hydroxyurea, short course of steroids and rituximab was given for rheumatoid arthritis. We have to keep in mind that some of the drugs which cause myelotoxicity in rheumatoid arthritis are prescribed. Along with that, if we give hydroxyurea, needs monitoring, intensive monitoring. L-glutamine, now lot of into talk because it is available and has some effect in sickle cell disease. Riverna, it is crizanlizumab available in India now. We have a trial going on in our center and we have recruited 2 patients into it, but we still don't know, it is in its infancy, whether it is, how it is working and what will be the effects. Vitamin D3 supplementation not only for this patient but all patients of sickle and thal should receive it, and take care of the obesity and the obstructive sleep apnea. So concluding, sickle cell disease in India is different than the Western data, and it is not simple to understand. Our pain patients present with is quite different from what the presentation is in the West. Pain crisis actually leads to end organ damage, so whenever the patient comes, we have to take care of all the organs which may be involved in patients of SCD. Vaccination, already said by our colleagues that vaccination should be given because of the autosplenectomy they have. Hydroxyurea patients, important to counsel them to adhere to the drug in order to have the maximum benefit. 20% who do not respond or fail to respond to hydroxyurea, the patients in whom other new drugs should be thought about. And this is what I would like to conclude with. A cocktail is there with us, and which patient when to take is important to decide after discussing with the patients. Thank you to all my panelists and the chairpersons.
Thank you, Dr. Priyanka.
Thank you,
Dr. Jena, and all the expert panelists. Just I have only one suggestion. Is there any of you practice this PCA approach in this chronic pain of sickle cell disease?
No, sir. We have not. We have not.
So we may take 1 or 2 questions, invite from the audience also.
P-selectin inhibitors, am I audible? P-selectin inhibitors is a very good drug, probably to prevent the veno-occlusive disease, pain and crisis. Is it available in India? And is it, what is the cost of this drug?
Sir, please repeat. Sir, we are not able to hear you, sir.
Won't get you, sir. Yeah, sir. Crizanlizumab is available in India. It's in the name of Riverna. I think it comes at 50 milligram vial, 100 milligram vial, and you have to dose it according to 5 milligram per kg. Each vial is approximately 60,000 rupees. Actually, sir, in our center we are having a trial. It is available free of cost, and 2 vials mostly for a patient. First, for day 1 and day 15 is the first induction dose, and then it is followed by monthly maintenance, monthly once. So, and we have just started recruiting, sir. What is the advantage, how it is working, we do not know.
Ma'am, one question from me.
Yes, please.
Ma'am, okay.
Just
so
we should conclude now.
Because you have probably recruited patients, I just wanted to know that are these patients, I mean the...
Hydroxyurea naive or hydroxyurea?
Yeah.
Patients, there are inclusion-exclusion criteria for the study. If they are hydroxyurea naive, you do not have to do anything, they can be easily recruited. But if they are already exposed to hydroxyurea, they should not be on any dose increment for last 6 months. Whatever the dose the patient has to be on a fixed dose.
Thanks to all of you. We will discuss later on, okay? So please, we should move to the next session. Thank you.
Thank you, Chairperson. Thank you, speakers, panelists. And it was a wonderful session. We learned a lot about crizanlizumab also. So moving ahead for our next session, it's cutting-edge technologies in hematopathology. I would like to invite our chairperson, Professor Shikha Das ma'am. She was ex-HOD, Department of Pathology in Agartala Medical College. And I would also like to invite our second chairperson, Dr. Tamal Kanti Ghosh. Sir is Special Secretary, Medical Education to the Department of Health, Government of West Bengal. I welcome both of you to the dais, sir, to carry forward this session.
Check, check. Check, check.
Good evening. Now we are going to start the session on cutting-edge technology in hematopathology. Now the speaker is Dr. Mayur Parihar, Consultant Hematologist, Laboratory Services, Tata Medical Center, Kolkata. Now I will request Dr. Mayur Parihar to come on the dais and do the presentation. Thank you.
Good evening, everybody. Foremost, I would like to thank Dr. Tufan, Dr. Prakash, and all the members of the organizing committee for having me here. It's a pleasure to be here today. So for next 15 to 20 minutes, I'm just going to give you an overview about what a droplet digital PCR is all about. Slides are not moving. Yeah. So before I start, I thought I should just cover some basics about what is a PCR reaction. So all of you know that a PCR reaction is a polymerase chain reaction. And what do we do with that? What we do is we amplify the genomic area of interest. So you want to study a specific gene or a specific genomic area. So you would have to amplify it. And after you amplify it, you can sequence it. You can do all kinds of things you want to do with that. And that is why it forms the basis of all molecular tests, both in diagnosis as well as research. So what do you need for a PCR? You need the template DNA, right? So I would just like to explain you with an example. So, you know, when we were students, we would go and get books photocopied during exams. So when you take a book to the Xerox shop, you put tags that you want photocopy from this page to that page. Now that is your DNA. That is your DNA of interest. Then the tags you put for the photocopy guide, these are the primers. So these are the primers which are actually going to tag and flank your area of interest you want to photocopy. Then what do you need? You need some ink. So what is the ink here? The ink are the DNTPs. So you add your DNTPs, which are nothing but the ink which is going to be required for photocopying your DNA of interest. And then you have the Taq polymerase. So Taq polymerase is an enzyme. Now the Taq polymerase is a heat resistant enzyme which actually synthesizes and then adds on the various nucleotides. And it is just like the light you see in the photocopy machine when when you photocopy, you see the light coming and going. And that is what your Taq polymerase is. And then you add the buffer. So PCR reaction, basically what it does is just amplifies your genomic area of interest you want to study. Now what you could do with it? You could put it in a gel and then you could get different PCR products based on your interest. And based on that, you can say if a specific target is present or absent. You could also quantify your target if you want to quantify it. And I'll show how we do that next. So, we have had generations of PCR. So one is a qualitative PCR, as I said. You amplify your genome of area of interest, you photocopy it, you put it in a gel, it gives you a band, and yes, this is present or absent. Sometimes you can do both qualitative and quantitative real-time PCR. I'll tell you what a real-time PCR is, where you want to quantify a specific transcript. So you want to quantify, for example, PML RARA. You can do that by real-time PCR. And now we have a more sensitive technique called the droplet digital PCR, which kind of does an absolute quantification, and I'll show you how it does that. So all of us know the concept of the digital watch as an analog watch. So when you look at the analog watch here, okay, it's 12:45 seconds, maybe 35. So it's giving you some amount of information. But when you look at the digital watch, it actually gives you 12:45, 36 seconds. You could even actually break down your seconds, in more advanced digital watches. So digital measurement quantitatively and discretely measures a certain variable, whereas in analog measurements, we extrapolate certain measurements based on the measured pattern. So that is what is the difference between a digital PCR versus a real-time PCR. So what is a droplet digital PCR? It is a PCR reaction that is partialed. So, right from biochemistry and, whenever you want to quantify an analyte, if you fractionate the solutions, you will get much more sensitivity. So what we do here is, we fractionate the amount. So what happens is, the same PCR takes place, what I told you in the first slide, but here it happens in small droplets. And these are around 20,000 droplets that are there. So 20,000 PCR reactions are going on within this droplet. And that is what is a digital droplet PCR. So this is your traditional PCR. You put all your primers, your genome, you put your buffers, you put your magnesium chloride, and then you run the PCR. In ddPCR, what you do is, you break this into multiple droplets. And the PCR reactions then happen within these droplets. So what are the technical advantage? One of the very significant is, yes, it is increased sensitivity. It is very good for quantification. And the amount of reagents required are less. So it actually cuts down on your cost also. There is no relative quantification. I'll explain you relative quantification as I go ahead. It's an endpoint measurement. It has a high precision with reproducibility and discriminability. And in order to pick up rare events, so if you have to pick up measurable residual disease with a lot of background, your digital droplet PCR does a good job out of it. Coming to the real-time PCR, all of us know real-time PCR is commonly used in our labs to quantify different transcripts. So what is the principle? So this is the normal, you can say, a part of a sequence of genome. And this is the mutation we are trying to look at, which is blue color in the A. Right? So you put your primers. Now your primers start moving. And then what it has is, it has a probe. And the probe, if you see, I can't point, the pointer is not so good, but it has a gray color and the blue color. So the purple color is your fluorescence. And that fluorescence is continuously quenched by the gray color. Right? Now here the Taq polymerase has an exonuclease activity. And as it goes on to add, If there is a mutation, it cleaves this probe. And the moment this cleaves the probe, the fluorescence is released free from the quencher and it gives a fluorescence signal. And this fluorescence signal is recorded, right? So that is what is done in a real-time PCR. So if there is a mutation, you get a fluorescence. If it is wild type, you do not get a fluorescence. But it is not so easy. When you do a real-time PCR, you have to create standard curves. So what are standard curves? So for example, BCR-ABL here, you take known BCR-ABL, you do different plasmids with different serial dilutions, known ABL, different plasmids with serial dilutions, you run a lot of standard curves. And like I said, in analog measurement, you're going to extrapolate your sample, what you see by an arrow, and calculate it based on the presence of these various standard curves. So you have to run standard curves here, and based on that, you quantitate your transcript in terms of the numbers. So this is for the BCR-ABL, so you run multiple standard curves, and the arrow you see is basically your sample. Now there are certain issues with real-time PCR. You must understand here that we are trying to look at very rare events. A patient of CML on imatinib, you want to look whether he is in molecular remission. You are going to look at very small amounts of this transcript when it is present or no. And since it's an amplification, clonal amplification process, small errors can lead to big differences in the results that happen. So this is a paper from Scientific Reports which says that since the RT-PCR is based on the CT value, so the moment, and you know the real-time PCR is based that you think the amplification is clonal, that's how it goes. So the CT values depend on the chemical and protein contaminants. So if your Taq polymerase, if there is some contamination, the efficiency of Taq polymerase may go down. It may affect the primer banding and it may change the CT values. Whereas the digital PCR, you won't have these issues. And especially with high level of impurities, and if you are looking for a low target concentration, you would rather like a digital interpretation rather than an analog interpretation. So this is how it works. You can see, you can see you have the multiple droplets here. Now as I said, the PCR reactions happen in the drops. You see this is the background DNA in blue, and then you have the target of interest. Now what happens is when the sample is put into these droplets by the machine and it's kind of inserted within the droplet and the PCR reaction is happening within the droplet, it may be possible that some of them may not have any DNA, some of them may have extra copies of DNA, right? And that is why you see what you see here. You see the background which is blue and target of interest, and that is amplified. The other difference is in real time, the fluorescence is measured 3-4 times at different time points, whereas in digital PCR, it is measured at one single time point, and that is why you get more specificity. So this is it. You have random distribution of sample. I'll come how the data is analyzed. And partitions are PCR amplified to the endpoint. You drop the reader to determine the fraction of positive partition, which is done by Poisson's distribution. Now Poisson's distribution is nothing but it's a probability. It is by a French statistician. So you know it measures the distribution. For example, if you take a call center gets about 180 to 200 calls a day. Now if you look at the Poisson distribution, there is a possibility. So when you do the distribution, so the probability of the variant, so the probability that the call center gets, how many calls it gets per minute would be about 2 or 3 maximum. It may go from 1 to 4. It may be possible that you may get 0 calls, or it may be possible, which is very unlikely, the call center may get 10 calls in 1 minute. But the most probable is 2 to 3. And that is how the Poisson distribution works. Don't ask me the formulas, I don't understand much about it. So, and he's told TK. So the workflow, we go for sample preparation and droplet generation. So you take the sample and you take your master mix. What does your master mix has? It has your DNA or the RNA extracted, it has your primers, it has your probes, and then you see this strip here, right? So in center you put your sample, you put your oil, and then what happens is the machine, the capillary tube you see there, actually forms oil droplets, and this DNA is introduced into this oil droplets, and then, so this is your oil droplet generator. You can see that the sample is coming from one end and the oil. So it is just like in flow cytometry, how in a capillary, the cells are reduced to a single line and they go through that. And then you run a PCR like any other PCR. So then you put it on a thermocycler which does PCR, and about 20,000 PCR reactions are going on in every droplet. And then you have a droplet reader. So what does a droplet reader do? Let me see if I can use the mouse. No. Okay. So what you see here is that the droplets are coming and they are converted to single droplets in a capillary, just like a flow cytometry. And you have a laser which actually measures the fluorescence. So every time a droplet passes, it gives you a call. Now if the mutation is present or the transcript is present, it will give you a fluorescent signal and it is counted. So you are actually counting each droplet one by one, and the fluorescence is then calculated. Thank you. Yeah. So you see here, these are the droplets. They are put into a single line, and then you have the laser here, and every time the droplet passes, you get a call. So this is as simple as that. You prepare your master mix, you distribute, the machine does the distribution, it distributes it into multiple droplets, you do a PCR reaction, and then you just quantify and read it out. So it's the same workflow in a more, what explains. So you have a droplet generator, you add the sample, it generates the droplets, the DNA or the RNA goes into the droplets, a PCR is done, and then you have the read droplets. And the Poisson's distribution, I have already explained it to you. So you have a sample 1, you have no positives here, the green is positive, so 0 out of 143. Then you have 6 out of 143, the Poisson corrected is 6.2 by 143. Here you have 34 reads, and the Poisson correction has been done based on whether you have one DNA segment or two DNA segment or no DNA segment in the droplet, and gives you a 38,143, and this is the sample 4 showing a high concentration, and that is how it reads it. How do we analyze the data? The machine comes, we have a software there. So what you see here, now this is the fluorescent intensity, and what you see are each of this is a droplet which actually has the transcript you want to measure, and that has given the fluorescence, right? And you have the threshold which has been put here, and these are the negative drops without any fluorescence, gray color. And the blue color actually gives you the positive droplets or the positive this. So this is an example of BCR ABL. So you have BCR ABL copy. We do it for P190 in our institute. So you have the ABL copies. So you have 3540 copies per microliter. You do it into 20 microliters. You get these numbers. You get this number. You take a ratio. Now some of you may ask, why are you putting ABL if it is absolute quantification? In true sense, it is not an absolute quantification, but what it does is it gives you enough statistical power to make a call when you have a rare transcript present. Now what may happen is, if you do not put the control ABL, you don't know about the RNA quality. A sample comes from the collection center, from the wards or from the OPD. Now it may be lying for 1 hour, 2 hours, or sometimes we get a delayed sample, and the RNA is extracted at different time points. So the quality of the RNA may vary. And in order to factor in that, we also run an ABL here, and then we take the control just like in the real-time PCR. But you always have to do a limit of detection analysis before you actually make a call. So once you have 3 droplets that are showing the signal, you call it positive. So 3 events, you call it positive. So this is an example of how we went about doing our NPM1 serial dilutions to actually get to know our limit of dilution. So this was a patient with 17% NPM1 allele frequency. We did serial dilution, and you can see we have 4 drops here. So our sensitivity is 0.0017%. So that is how you can actually use an NPM1 mutation in a patient of AML who is NPM1 mutation positive to actually do a measurable residual disease estimation using a digital PCR. What has been our experience at Tata Medical Center? We use it for cell-free DNA. I'm coming to some solid tumors, I'm sorry, but for EGFR mutation detection. I put it here just to show that even when you're looking at circulating tumor DNA where the amount of positive DNAs which are the positive mutation are extremely low. Even then, the digital PCR is good enough to identify them. We have done the T17, again that's a resistant mutation for lung cancers. Coming to what we do in hematology, we do the BCR-ABL absolute quantification for P190 transcript. We have done NPM1 both at diagnosis and MRD monitoring for patients of AML. We have done the PML-RARA quantification using the digital PCR and the DNA-based quantification of the JAK2V61F and the BRAF V600. So this is some data. This is slightly old data, about a year old. You still have to, but we have done quite a fair number of samples and we have had a fair amount of experience and we are quite happy with it. So if you see this example, now patient on 21st of August, the RT-PCR was negative, but the DD-PCR was positive. So do we take action? Actually not, because there are enough papers from Grimwald et al. That shows that in AML, when you are actually monitoring a patient by using this transcript, a single time point does not hold. You have to repeat within 4 weeks or 6 weeks and then look for a trend. If you see a trend of increased quantification, that is when you act. So no action was taken, fine, but then when he came 2112, it came positive and we had 0.23%. Similarly, we have another patient, negative on RT-PCR, positive, and later he came positive and then 0.46, and as we moved ahead, this patient actually came back with a relapse. So you can see the pictures here. This is 1980 copies not having the mutation, and you have 1, 2, 3, 4 droplets showing the mutation, showing the PML-RARA transcript. Similarly here, this is from the second patient. So this whole work actually involves a complete team, both from the clinical part and from the lab hematology, the cytogenetics, the molecular genetics, all of us work together. I just get to come here and give this talk. Thank you, and I acknowledge the whole team of Tata Medical.
Dr. Parihar,
Yes,
you were very good in your demonstration. That's how I feel. And I need 2 questions.
Yes, Rajiv.
So when we take decision depending on the result, suppose it is a BCR-ABL quantitative, so whether it should be mentioned that it is done by droplet PCR or it is done by conventional PCR, because then if it is positive by droplet PCR, then all the recommendations are based on the standard PCR.
Totally
so whether
agree
to intervene or not at that point of time. So whether it needs to be mentioned.
Yeah, so if you look at all the IS standards in CML, they are based on real-time PCRs, and that is why the common transcripts we do by that. For 190 transcript, we do not have any IS standards. So that is the only transcript we are doing by digital PCR, whereas all others we do by real-time PCR because there are guidelines. And I think now there is work going on wherein hopefully in future as we go on for molecular remission, treatment-free, and stuff like that, digital PCR guidelines would come through in future, wherein then we will go according to that as per the guidelines.
Okay, thank you.
Answering what Rajiv has asked, now Bio-Rad has got a international scale kit available, which is currently under standardization with us. They haven't yet got the import license to get it into India. So we are the institute which is doing the standardization assay right now. And once that kit comes, the digital droplet PCR will be in the IS scale. So it will be comparable to the conventional real-time PCR, what we do on the real-time platforms.
But here, in case of the COVID-19, the RT-PCR becomes sensitive only for 70 to 80%. If you do the digital PCR, then I think that it will be much more sensitive. Why not the government is doing this digital PCR instead of the RT-PCR to detect the COVID-19?
Dr. Pranab, I think your question nobody understood.
Yeah, actually.
Why COVID-19 detection is done by RT-PCR, not by the digital PCR.
Okay.
That is a much more, because RT-PCR has got only 70% sensitivity.
Yes.
The government can move to the digital PCR, which gives you a higher sensitivity, much more higher sensitivity. That is my question.
To answer your question, sir, the COVID PCR is basically an endpoint. You're just looking for positive or negative. You're not quantifying the transcript there, or you're not quantifying the amount. So you don't have to go very, very sensitive out there. I would rather say, then I think all of us would turn out to be positive.
The problem is that in case of the COVID-19, with the RT-PCR, that when it becomes negative even in the RT-PCR.
Sir.
So in that case, if you do the digital PCR, the chances of become negativity diminishes.
Sure, sir.
And in that case, the positive value is become
I
positive.
think with exceeding the time,
sure.
we will stop here. Thank you, Dr. Parhia.
Thank
you very much.
Sir, I have one question, small question. Sir, is there a concept of housekeeping gene in DDPCR also?
Yeah, so I told you we put the ABL1 as the housekeeping gene, and that's why I mentioned it there itself. Why? Because we don't know the quality of the RNA extraction. Suppose we do not get any amplification. How do we know that the DDPCR has actually not worked, right? So that is why we always put a housekeeping gene, so that we at least know that to factor in the quality of the RNA and whether the PCR has worked.
And for PML, still most are doing RT-PCR.
Yes.
It's a qualitative one. How to take action on
See,
this
for
DDPCR?
PML RARA, if you look, the guy who did all the RT-PCR was Grimward et al. So he's clearly shown that at one time point doesn't matter, because you could have the transcripts coming out from non-malignant cells also, you know. For example, 821 is also there in erythroid cells. So you have to do serial monitoring.
Discussion later,
Okay.
because others are waiting to
Yes, thank you, ma'am.
listen and to talk also.
Thank you, ma'am.
Thank you. Thank you.
I will. So now I request, thank you very much, Dr. Parhia. Now I will request Dr. Shudipta Roy to give his presentation. He is Director of Lab Services, Amri Group of Hospitals.
Thank you very much. So at the outset, let me sort of thank the organizers. How is my slide moving, please? On the cutting edge technologies, we are still on hematopathology. The organizers have asked me to talk on capillary electrophoresis and how it differs from HPLC. So let me first thank the organizer for asking me to talk on this topic and bringing us from online to offline. And thank you very much, the chairpersons, meeting people and doing socialization. The topic here is with the theme, is HPLC the gold, is capillary electrophoresis the platinum? And we'll see how we go along. Since it's about the hemoglobinopathies, we'll stick to first the hemoglobin structure, which we know consists of a tetramer of two pairs of polypeptide globin chains attached with a heme group which binds to the oxygen. And we are talking something which is inside the RBCs. Red cell indices are very important. I'll stick to very basics, and because I see a lot of young juniors, so red cell indices are very important for us in the interpretation of hemoglobinopathies. And the normal hemoglobins, we have 2 alpha and 2 beta chains for hemoglobin A, 2 alpha, 2 delta for hemoglobin A2, and hemoglobin F is 2 alpha and 2 gamma. And we have very common abnormal variants. So the idea is, do we have cutting technologies to diagnose these abnormal variants? But again, as I have to stress that the patient comes first, clinical importance is important, and the history of the patient, age of the patient. As you know that we have a difference from newborn to adult in the concentration of the normal hemoglobin that we see, the adult hemoglobin, the fetal hemoglobin, and A2. Say, for example, in an adult, if you had a fetal hemoglobin of 75% and he was not dependent transfusion, then he goes for a beta thalassemia minor. So this major minor criteria, age is important, clinical history is important, and therefore, whatever I discuss today, please feel that the patient comes first. So what is electrophoresis? It's separation of solutes based on different rates of migration through an electric field on a background of electrolyte. So these positive ions, and you all know this, the charge and the size influence the movement of the charged particles in opposite ways. So we had in the historical development gel electrophoresis when we were students, and one of my teachers are there in the audience, Dr. Konjaksha Ghosh. He taught us this. The basics in hemoglobin electrophoresis is used to take a red cell lysate and subjected them to electric fields under alkaline pH or acidic pH. So the ionic strengths of the various hemoglobins are different. The concept is separation of different hemoglobins is largely, but not solely, depend on the charge of the hemoglobin molecule. And why does the charge change? A change in the amino acid composition based on the genetic constitution of the globin chains results in alteration in the charge of the hemoglobin molecule. The whole physicochemical thing changes based on amino acid changes, and this results in a change in the speed of migration. So when we did gel electrophoresis, it causes different hemoglobins to migrate at different speeds, and that is how we separate it. So when we were students, we were told this: at alkaline gel electrophoresis, you have certain things called band and lanes. So you have the carbonic anhydrase as the first band, and the fastest moving is here, the top band, which was called the H lane. Then you have the J lane. Then you have a group of fast hemoglobin. And the A lane is where your adult hemoglobin came. The F lane was your fetal hemoglobin came. But the problem is, S lane, you have so many, hemoglobin S, D, G, and hemoglobin lipoid. Now you have seen in sickle cell the discussion that with sickling we have a lot of other hemoglobins can come. So therefore the problem was, can we identify each separately? C lane you have hemoglobin C and E coming along with A2. So therefore there was a difficulty in interpreting clearly. So we went on to do an acid gel electrophoresis to see can we separate the band, but that was the limitation. So what we actually did was we had various normal controls, and it is very important to start your adult, fetal, sickle, and C control. Then you can match these bands. The problem is these are all qualitative. If you had to quantify them, you had to elute and then do a biochemical. So the gel electrophoresis was definitely difficult, and so what we did was people switched on to capillary electrophoresis. The disadvantage of traditional electrophoresis is a long analysis time, lack of resolution, difficulties in detection, and difficult to automate. So the capillary electrophoresis came, and it was an automated high-resolution approach to electrophoresis. Separation is carried out in a micro-bore fused silica capillary, which is around 25 to 75 micron internal diameter. The separation takes place in free solution, and convection currents are controlled by the capillary. And once it got introduced, the applications were wide range. It was for proteins, nucleic acid, peptides, carbohydrates, anions, cations, vitamins, organic acid, and various things in the industry. But we'll stick to today's evening is only for the clinical thing. And there are various types of capillary electroseparation, but for clinical thing, we'll take capillary zone electrophoresis for our discussion for the evening. So there are three sort of baseline machines available: capillaries 2, capillaries 2 flex piercing. The difference is the throughput of these machines and what is your primary sample. Some uses whole blood and others use hemolysate. So what is a capillary electrophoresis? The principle. It's a capillary tube like here. You have two buffers. So you have the positive charge here and the negative charge. You have a power supply. And when you use a sample, it could be the whole blood or the hemolysate, you take this and put here, and then with this electrical field, there's a migration of ion. These capillary tubes are silica, as I said, and there's a detector here which, like your HPLC, has the same UV or the various optics, and then the data is acquired with the software and interpreted. The variables governing the electrophoretic mobility in a capillary tube is the charge, the radius, and the mobility. The tube in capillary electrophoresis is typically silica, which may be coated or uncoated. For a clinical use, we use uncoated silica, which leads to something called an electroosmosis when run at a neutral basic pH due to protonation of the silanol groups, the silica charged groups. I'll show you a figure of that. In the normal polarity mode, the samples which are positively charged will go to the negative end, and so on and so forth. The observed mobility will be the sum of inherent electroosmosis plus the electrophoretic mobility. So initially we had for a gel the electrophoretic mobility, the electroosmosis comes in, and this actually brings down the time for analysis. It's more efficient in separation of the peaks, and the separation is much easier to detect objectively. So where does electroosmotic flow come from? This is your capillary tube, and it's silica thing, And you see that this is charged thing. The interior wall of the capillary contains charged sites that are created by the ionization of silanol groups on the fused silica. This flow is a phenomenon resulting when a solution is contained in a capillary wall with fixed charges along its wall. It is also known as an electro-endosmotic flow. So how do we interpret this? The hemoglobin zone electrophoresis actually has 15 zones. And if you see from zone 1 to zone 5, zone 2 is hemoglobin C, zone 3 is for hemoglobin A2, 4 for hemoglobin E, zone 5 for sickle, zone 6 for hemoglobin D Punjab, zone 7 for hemoglobin F, 9 for adult hemoglobin, and you have the rare hemoglobins also. So therefore you can see that A2 and E is separate, but if it is so many variants, at times it can be an overlap of the graphs. So let's take some examples. But before that, let me tell you for the juniors that hemoglobin electrophoresis, the normal pattern that we take for every day is hemoglobin F adults, less than 1%, A2 less than 3.5%, and the rest is adults, around 96-97% would be adult hemoglobin. But we always have to correlate with the MCV and MCH. If it is normal, is report normal. If they're low, you exclude iron deficiency anemia because that's where an interference takes place. A2 more than 4, you are between 4 and 7 is beta thalassemia trait. But A2 between 3.6 and 3.9, you still have to wait. So however, most of the times you can make a diagnosis for a routine thing, but accurate diagnosis, we have the genetic testing, and we'll come to the significance later on. We used to use Menzer index, but this is just a theoretical possibility nowadays. The probable cause of lowered concentration of A2 that may mask a minor beta thalassemia is iron deficiency anemia, pregnancy, neonatal period, and more rarely delta thalassemias. So these are the clinical things you should be considering when you're interpreting. So let us take a results of the capillary zone electrophoresis. As I said, they're from zone 1 to zone 15, and zone 9 is your adult hemoglobin, and this is your A2, and you don't have anything, the fetal hemoglobin F here. So what you have is these peaks out here at the various zones, and you have a quantitative evaluation like here, 97.4% adult and 2.6%. Your MCV and MCH was normal, so reported as normal. So again, a normal here, but you have a beta thalassemia trait where your hemoglobin A is 93.9% and A2 is 6.1%. You can see the difference in the peak. So you have a quantitative which you could not do in your gel electrophoresis. So it's a very clear separation and easy to interpret. But life is not all that easy. You know, if you see the kit literature, they say that we can diagnose 150 variants of hemoglobinopathies, and the database is there based on the various zones. And the various zones from 1 to 15, you have various types, subtypes of hemoglobinopathies. Like for example, if you take this 6, you can see there are so many, but for our ethnic purpose, for us it would be D Punjab. So one more important point is the ethnicity of the place that you're working would be important to identify what you're doing. Otherwise you get confused. So you have a huge amount of data out here, but you should be knowing based on the clinical thing, based on your red cell indices, based on the ethnicity and the patient's blood transfusion history or not, when to diagnose and the limitations of the technique. So this is one of the limitations. You have something called a yellow triangle where hemoglobin A and A2 is undetected in the absence of fetal hemoglobin. You know, therefore you don't get a zone. So what you have to do is, again, you have to run the sample with a normal control or adult F, like you did for electrophoresis, AFAC control. So once you have these centered on the control value of adult hemoglobin, then you can identify this peak was S and this peak is C. So therefore you can try to interpret S and C. But if you don't have an A, then it's difficult. That's one of the limitations. The second limitation is when no zones are identified and not a yellow triangle. There's no yellow triangle here. Again, you have to overlay with a control value. Therefore, control is very important. Running a normal sample along with a A is important because that's where you know where zone 9 is, and therefore you can extrapolate what is fetal hemoglobin. But the important is you can differentiate A2 and E, which you have a limitation in your conventional way of HPLC. The advantage over here is that is easily done. So as I said, you always have to know the control, the volume, the values of the control to run, and at times it's not easy, you have to run twice. So what are the differences? The difference is HPLC is a more mature technique and capillary electrophoresis is young, developing fast. The solvents, you in HPLC you use a high pressure and here you use an electrical field. In HPLC you have less number of plates, 10,000 or it's more number. The time over here in liquid chromatograph is more than the HPLC. The curves are parabolic in plug, I'll show you here. So the capillary electrophoresis, you have a flat flow, greater peak capacity, simpler for the operator, and limited to thin capillaries. HPLC, you have a pump flow with a parabolic flow. We'll explain this, but a more complex instrumentation. But in the industry, these number of peaks, it comes for a clinical thing, 30 peaks. I think all of us will get confused. But in the industry, it's got a huge application. But it's not so for our clinical use, because in clinical use, so many data we are not able to diagnose. So we'll come back to HPLC. It's where you have a column, which is called the stationary phase. You load the sample, you do a high pressure so that the sample passes through the column, and at various times, based on its physicochemical nature, it elutes out, and then you identify based on that. So we'll take the variant, the Biorad variant. So you have the retention time of 1 minute for F. You have P2, P3, which are associates with hemoglobin A, and hemoglobin A is at 2.5. A2 is this. So you have different windows, like we had lane, you had zone, and you have windows, D window, S window, and C window, and some sort of along the time figure, you have A. But important is here, E and A2 comes out together, and you need to be very discriminate seeing the amount. So you have a high E, I'll show you examples. If you run for 9 minutes, you have much more peaks and you can separate. I don't have an experience of a 9 minute starting, but you can separate a little bit of E and A2 is what the company claims. So this is what happens in a HPLC. You have a parabolic flow, so at the base of the curve, you have mix-ups, but in a capillary electrophoresis, the peak is very good. So I think whatever is being said, both techniques are similar at the modes of detection, the UV and the optics, and it can be used for complementary to one another. That's the final goal. So what is a big deal of capillary electrophoresis? We'll go through some published data, comparison of the quantification of this, and they used this paper in 2009, used capillary SEBIS versus an HPLC. The result, the percentage hemoglobin variance of the two methods were similar for HBS and for C and D Punjab. So what they say is, because this is the time when capillary was introduced around 2009, they say the Sebia capillaries 2 is suitable for the presumptive identification and quantification of hemoglobin variance, producing results comparable to the existing gold standard of HPLC. We go for a further study, which is around 2012, where they took the common variants and 10 rare variants, and they also say for A measurement, adult hemoglobin, the two methods were equally good. F, when the F concentration was low, the two methods were comparable. Samples with the high F was excluded, then the agreement was good. A2 variants, this was the problem. When there was an abnormal hemoglobins, there was a bias for A2 in the capillary electrophoresis. So the conclusion is that, by and large, for the common variants, the capillary flex and the HPLCs are equally quantifiable. So we go to a more recent paper where they have stated variant and they have used capillaries and other chromatographics. So 5 techniques head to head. If they take adult and sickle homozygous and C, and you see all of these results are the same. So this is a Dutch study, and with their ethnicity, they really did not find any difference, and I'll show you the examples from there. This is the normal, A and A2, and C HPLC is the same. Hemoglobin A and sickle, you have an A peak, you have an S peak, you have an A2, you have an A peak, you have an A2 peak, and S peak there. A and C, you have this C and A2 gets fused at this point, as I said, in the zones. So again, you have a good separation. A and E, you have, here is the problem, you have a separation out here, but here the quantum of E or the quantum of A2 is high, so you need to have the ethnicity to diagnose this. This is where the HPLC has a limitation. A and D, not much of a problem in both the systems. A2 high is also easily diagnosed here, but may be a little difficult out here. And with an increase in AE, the percentage matters to differentiate between what is D Punjab or E Iran and all this stuff. P2 and P3, I said, you can have a peak of J Oxford at P2, one of the rare examples. This is a paper from Dr. Nishimadan. So the disadvantage of HPLC is the co-elution of A2 and E. That's what I said. And so HBE, HBD, and these two hemoglobins co-elutes with A2, making quantification of A2 impossible when these variants are present. The measurement of A2 is complicated in individuals with hemoglobin S because hemoglobin A2 is falsely increased the presence of S adducts. Capillary zone electrophoretic method can be used to quantify A2 in the presence of S, and I've shown you examples by eliminating the interference of these adducts. And to the take-home message is you have to have your clinical thing. HPLC is standardized in our setting and is effective in screening and confirming. Separation and quantifying the common hemoglobins is, we are used to it and we are pretty confident. Family analysis helps to it. And rare cases, additional molecular testing is important. Since the molecular testing is now readily available, so those data, those papers which were there in 2009 and 13, thought that you add this capillary electrophoresis as an adjunct, but since we go for molecular testing, the clinical use of capillary electrophoresis is getting refined for routine use. So therefore, we need some more time and experience. Start capillary electrophoresis as a complement to HPLC, mainly for a large-scale screening because it's cheap, it's easy done, and it's variable. So to end, I might say that HPLC is gold. C, not really platinum. For a clinical use, you need to have a platinum coat over gold, or if your money permits, you can have a gold platinum together. Thank you very much.
Thank you, Shudipto. Dr. Shudipto. Yes. We don't have any time for questions. You can discuss them later with the speakers.
Now I will request Dr. Deepak Kumar Mishra, who is Director of Lab Director, Tata Medical Center, to present his topic, NGS in Hematological Malignancies.
Prakash Mandal and the brilliant organizing team of BeSHCON, the 5th BeSHCON annual meeting. The topic that has been assigned to me is next generation sequencing in hematological malignancy, what we have achieved till date. This was actually the first talk of this session, but for good that I changed it to the third one because Mayur, my colleague, did a wonderful job in introducing the various techniques of conventional molecular genetics. And I thought to begin with, NGS wouldn't have been a good idea to do, and that had just happened by default. As you all know that in hematology, molecular biomarkers are extremely important in hematolymphoid neoplasms. Some of them are quite diagnostic in acute myeloid leukemia, ALLs, myeloproliferative neoplasms, myelodysplastic syndromes. It is also used for MRD monitoring in the form of either real-time PCR or nested RT-PCR or the digital droplet PCR that Mayur has already alluded to. The ddPCR is a newer addition and it is called the partisan PCR, and he has given a brilliant exposition of this subject to you, and it has gone down to the label of sensitivity to the label of 10 to the power minus 5 to 10 to the power minus 6. And it is a wonderful tool for rare event detection and for detection of minimal or measurable residual disease. Pharmacogenomics is extremely important because there are certain genetic markers which modifies your treatment decisions. Like you have something like TPMT mutation, the thiopurine methyltransferase, particularly in pediatric malignancies, you modify the dose of 6-mercaptopurine based on that. Then you have the BCR-able fusion, the bread and butter of molecular genetics and hematology. You diagnose CMLs and non-CMLs because of the presence or absence of this. And the FLT3 ITD and the FLT3 TKD mutations in acute myeloid leukemias, because today you have a targeted drug against FLT3, that's the sorafenib and the midostaurin. Then you have the PML-RARA, which is also a pharmacogenomic mutation, because you treat them with all-trans-retinoic acid or the arsenic trioxide. Besides it, there are a host of other genes which are pharmacogenomically relevant, which I'm not going into the details. Post-stem cell transplant, chimerism is also molecular-based, and molecular tools can tell you exactly how much recipient and donor are there in a particular transplant recipient. So if you compare the different sequencing techniques, I'm straight going into the sequencing technique because to save time. If you talk about the direct sequencing or Sanger sequencing, it can only identify small-scale mutations. It cannot detect large-scale mutations. But next-generation sequencing not only can detect small-scale mutations, it can detect large-scale alterations and epigenetic changes as well. Sanger sequencing can assess one region of one gene at a time, whereas NGS can assess multiple genes from multiple patients simultaneously. The next-generation sequencing, it has low sensitivity. 20% is the overall sensitivity, 15 to 20%, whereas the NGS has got a higher sensitivity up to the level of 1 to 5%. The turnaround time in Sanger sequencing is faster compared to the NGS. NGS, it is about 4 to 7 days. So from turnaround time point of view, Sanger sequencing is much preferred than the NGS. For using a Sanger sequencer, you need little expertise and very little computational knowledge. But whereas you want to interpret next generation sequencing, you need a greater degree of expertise, and you should have specialist data entry operators as well as bioinformaticians to interpret the NGS data. If you look at the Sanger sequencing, I'll just give you the principle that it works on the principle of ATGCs, what he has mentioned, Mayur has mentioned in one of his slides. So here what you do is that this technique is used to determine the DNA sequences, the ATGC sequences, where you have the DNTPs and you have the dideoxy NTPs, and they are incorporated sequentially in alteration reaction using the DNA polymerase. So what happens is that once it is incorporated, the addition of fluorescent labeled DDNTPs at different positions along a template strand of DNA is monitored by capillary electrophoresis, which is nothing but a Sanger sequencer. We have 8 capillary Sanger sequencers. You have 16, you have 32, you have 64 capillary Sanger sequencers as well. The chromatogram that you see looks like this, where every color is one nucleotide, A, T, G, and C. The next is Iron Torrent platform, which is nothing but a next generation sequencing platform. We have this platform with us. The principle of the NGSs are different in different platforms. The platforms that belong to the Thermo group of companies are actually the Iron Torrent series. Here you have a synthesis, you have a sequencing by strand synthesis of the DNA, which occurs by the addition of specific DNTPs over a semiconductor microwell array. This is the array. And in that what happens, the process of primer extension causes the release of protons which change pH in the well, and that change in the pH actually corresponds to a change in the sequence. This is the NGS workflow. This is the Iron Torrent personal genome machine that we have, and where you have the RNA or DNA extraction, you have library preparation, you have amplification, you have sequencing, then you have the data analysis, and finally, you annotate the result. This is coming to the next platform. That's the Illumina. Whether it is MySeq or HiSeq or NovaSeq or NextSeq, the principle remains the same, only the scalability changes. So here what happens, you have the DNA strands, you have adapters, you have ligation reaction, and following that you have the incorporation into the flow cell, and after that there is strand bridging, like here it bridges. And after the bridging, you have the double strand denaturation, then the cluster generation, and finally you have the reading of these clusters based on certain ledger inputs. And then finally the data analysis. It looks very simple, but everything happens in the machine, and there are algorithmic analysis based on certain pipelines. And the information that the analysis gives, the bioinformatician interprets it, whether there is any mutation, there is any deletion, whether there is any insertions, and all this can be examined by the analysis through the pipeline. So the techniques that we have in our center in various platforms are the Sanger sequencing, which I've just mentioned. We have the ABI 3500 Sanger sequencing platform, which is a 8 capillary platform. We have 4 next generation sequencing platforms. Extremely rare to have 4 platforms in a diagnostic lab. We have 2 from the Thermo. We have the Ion Torrent PGM, which I just showed you. We have the Ion Gene Studio S5. We have the Illumina MySeq, and we have the gene reader from QIAGEN. The only thing that we don't have is the instrument from Beijing Genomic Institute, the BGI machine, which I think the people from BGI are very keen that we must have one of them on our benches so that we have comparisons of all the next generation sequencing platforms on the diagnostic setting. We use the Sanger sequencer for fragment analysis, like FLIT3, ITD, TKD, and the many other NPMs, as well as for the chimerism analysis. We have allele-specific PCR, which is a variant of endpoint PCRs. Mayur has already shown you what endpoint PCR is, and I'll not go into the details about the various variations to the PCR reaction, whether it is quantitative or qualitative. And the digital droplet PCR he has already alluded to. This is just to show you some screenshots of the laboratory that we have. So this is the extraction platform, completely automated for RNA DNA. Then this is the one same thing. Then we have the hoods, which are exclusively for RNA and DNA. We don't mix up the samples because of the contamination issues. Then we have the PCR machines, multiple of them. Then we have the, these are the tape station, the qubit, and the nanodrop for the quality and the quantity of DNA and the RNA quantification. Then we have the PCR machines. These are the 2 hoods. And we have 3 next generation R-Cube Mason platforms, which is the ABI 7500. We have the Rotogen from the QIAGEN, and we have the Gene Studio or the Quant Studio 3 from the Thermo platform, and we are going to acquire the Quant Studio 6 soon to augment our capacity to do real-time PCRs. This is the gel doc, and these are the sequencing platforms. This is the Sanger sequencer. This is the Ion Torrent PGM. This is the gene reader. This is the S5 from Thermo, and this is the Illumina MySeq. So all are in the diagnostic setting for various types of assays. Ours is a composite lab, which does not only the hematological diagnosis, but also large number of solid tumor molecular genetics. Digital droplet PCR, this is the one that we have, which Mayur have already described. These are the sequencing. I'll not go into the details. So what we do with this? So we look at the myeloproliferative neoplasms either by the next generation sequencing or by the MPN reflex panel. In the MPN reflex panel, we have the JAK2, exon 12 and exon 14, and the calreticulin mutation and the CMPL. We do it in a reflex manner. If it is polycythemia vera, we first do the JAK2 exon 14, followed by JAK2 exon 12, and then CMPL and calreticulin. But if you have a patient of myelofibrosis, the algorithm is different. It starts with JAK2, followed by the calreticulin, CMPL, and then JAK2 exon 12. Sometimes we don't do JAK2 exon 12 in essential thrombocythemia and myeloproliferative neoplasms. In myelodysplasia, we do the 69 gene comprehensive myeloid gene panel that I'll come to later. For CMLs, we do both RT and RQ-PCR for both P210 and P190 transcript. For acute myeloid leukemias, we have next generation sequencing, the same 69 gene comprehensive myeloid gene panel, and the AML panel 1 and panel 2. I'll come to that in the next slide. And in the APML, in addition to the 1517 break apart probe that we use in the FISH, we use the RT-PCR for PML-RARA transcript detection, because that is important to know whether it is BCR1, BCR2, or BCR3 transcripts in PML-RARA. The NPM1 mutation is by fragment analysis and also by ddPCR. As I mentioned, NPM1 is a wonderful target for measurable residual disease in acute myeloid leukemia. Similarly, for 821 and inversion 16s, we do nested RT-PCR for treatment monitoring following the 7-3 protocols. So the tests that is performed on the acute lymphoblastic leukemia side, we have the RT-PCR for ETV6 RUNX1, the TCF3 PBX1, and the KMT2A FF1, which are the standard transcripts that you find in acute lymphoblastic leukemias. In the lymphomas, we do the IgTCR gene rearrangements for clonality assays, and also we do the IGHV somatic hypermutation for chronic lymphocytic leukemias. The TP53 mutation is done alongside the 17p deletions by FISH, and also we do the germline mutations for TP53 in next generation sequencers. For all lymphoplasmacytic lymphomas and Waldenstrom's macroglobulinemias, we look for the MYD88 mutation in addition to the CXCR4 mutation for characterizing the two different mutations. For hairy-cell leukemias, we have the BRA V600E, which is a standard allele-specific PCR technique, which can detect it to the extent of less than 1% in sensitivity. TPMT polymorphism for drug monitoring, also we have it in the Sanger sequencer. Chimerism analysis is also in the Sanger sequencing platform using the ProMega 16 gene STR kit. So we have the two panels, the ML1 and the ML2, as I mentioned. The ML1 has the FLT3 ITD and the FLT3 TKD, in addition to the NPM1 and the CBPA, which are the recommended 4 genes that you need to look at in cytogenetically normal acute myeloid leukemias. In addition to that, in AML panel 2, you have IDH1, IDH2, NRAS, and KRAS. Now you have targeted drugs against the IDH1 and IDH2. This is the 69 gene Oncomed myeloid research panel. This has got 29 fusion drivers, which are RNA based. And in our standardization exercise, all those that we have found by FISH has been shown to be positive by these fusion driver gene assays. And we have 40 hotspots as well as full genes. 23 of them are hotspots, and 17 of them are full genes, like ASLX1, BCOR, calreticulin, CBPA, ETV6. ETV6 will appear on both sides because one is a fusion, another one is a mutation. TP53, NF1. So there are many genes, RUNX1. So these are retinoblastoma 1. These are all genes that are full genes, and there are some hotspots as well. So this 69 gene comprehensive myeloid gene panel is very important in the diagnosis and characterizing acute myeloid leukemia and other myeloid malignancies. So the Oncomine Myeloid Research Assay has two pools of DNA and one pool of cDNA, which is from the RNA, which consists of 526 and 700 amplicons respectively, and this targets the 400 base pair chemistry, and the iron torrent personal genome machine is the one that we used, and recently we have shifted from the PGM platform to the Gene Studio S5 of Thermo in the lab. So the 40 gene targeted panel with 29 RNA fusion sequencing genes is very much sufficient for setting to provide a balance between the cost and number of genes to be included in the assay. So a single assay will tell you everything about the thing. I'll just take 1 minute, so I'll not go into the details. So all the genes that are associated with AML, MPNs, MPNs can be characterized. So this is quite good in characterizing these disorders. And these are the number of samples that we have run so far, about 97 myeloid malignancies so far we have studied by this comprehensive myeloid gene. 60 are AMLs, 22 are MDS, and the others. This is the spread of the mutational spectrum of the myeloid neoplasms, or TMC. And this is the Sirkos plot showing relationship between the neoplasm and the mutations. And it is very characteristic. And what we have found that there are certain mutations which are more in our setting than what is published in Western literature. I'll not go into the details. This is the positive fusion RNA sequencing that has resulted from fusions, which has been picked up by the fish, as well as by the 69 gene myeloid research panel. So if I conclude, the Oncomine myeloid gene panel is extremely good, and it should be used by most centers who have the facility of next generation sequencers. With that, I thank you, and I
thank you, Dr. Mishra, for sharing.
If you have any questions, I would be happy to take a couple of them.
We'll take the questions after.
Okay. Okay, thank you.
Thank you, Dr. Mishra, for sharing your experience.
Now I request Dr. Atul Thatai to come and give his presentation. He is consultant molecular biologist in Dr. Lal Path's lab.
So, good evening, everyone. And at the outset, I'd like to thank Dr. Rajiv Dey and the organizers for giving me this opportunity. So, I think we are going backwards. We started with the advanced techniques like ddPCR and NGS, and now we are going to set up a molecular lab. So, anyways, I know that my colleagues have done a wonderful job introducing you to two of the most advanced techniques, and let us now try to set up a molecular lab. So, if you look at subdivisions between molecular, so while we, in this conference, what we have been discussing is more about leukemias, the CLL, CMLs, the MDS, and the others. There are other areas where molecular is also playing a vast role, which includes solid tumors such as lung, oral, breast, ovarian, and others. And the other part where molecular is also playing a major role is the germline, the mutations which we inherit from our parents. Like we could be doing a whole genome sequencing, we could be doing a whole exome sequencing, or a clinical exome. The difference between the three being like in a whole genome, what you are studying is the complete genome, including the exons and the introns, the exons being the part where, which ultimately form from the proteins, and introns, which play a more of a regulatory role. In a whole exome, what you are studying is only the the part which is actually being translated into the proteins. And if you go down further, it is the clinical exome, in which you are actually seeing only the clinical relevant exonic parts. So you could also be having organ-specific panels like a CKD panel or an abortion panel, and down to a single gene testing such as a DMD or an SMA. If you look at the infectious portfolio, you could be looking at HBV, HCV, TB, H1N1, and now definitely COVID. And then you could be looking at drug resistance to, say, an HCV, HBV, or a TB at the molecular level. If you look at the genotyping part of it, you would be doing a matchmaking at the DNA level, like a HLA typing or a paternity. You could be looking at these disease associations like a celiac disease or a factor V laden. And Dr. Mishra just did touch upon pharmacogenomics as well. And then there are panels like a carrier screening, in which you could screen the individual for being a carrier to any of these diseases. Another part which is very common in the Western world and not so common in our is things like nutrigenomics, where what nutrition is best based on my genomics. What kind of fitness test should I be looking at if I look at what my genes are, and what is my endurance level at the genetic level. And then one of the most emerging fields is metagenomics, and all diseases and wellness are ultimately linked to the gut microbiome. And stool transplant is one of the hot areas what we are seeing, and even the vaginal microflora has been linked to premature deliveries. So another very exciting area is the reproductive health, where things like NIPT or the MBFD test which we do, which looks at basic trisomies, also looks at microdeletions or even single gene disorders like thalassemia, based on the fetal DNA which is found to be floating around in the maternal blood. So in these cases, you don't take the fetal, you need not be doing an amniocentesis. What you take is the maternal blood and look for diseases in the fetus. Even pre-implantation genetic screening, wherein you are able to screen the embryos even before you transplant them. And then there is the field of newborn screening, wherein you can be doing the TREC assays for kids, or be looking at common mutations for, say, a G6PD or other diseases. So basically, when you are planning out a molecular lab, you need to know that what you want to do. And based on what you want to do from this portfolio, you can decide that, okay, these are the equipment which will be a part of my lab, and then design that lab. So if you look at the instrument-wise capability, a real-time PCR can do a targeted detection and quantification, also do the SNP genotyping. Indels it can do, but not to a greater extent, only to the form of that only 4 or 5 base pairs, maybe like in an NPM you can go in, but an FLT3 ITD will be difficult to do on a real-time PCR. Capillary electrophoresis, or the Sanger sequences as we normally call it, you can do indels, you can do mutations, you can do SNP genotyping. NGS can definitely be used when you are looking at things like PGS and NIPT, and digital PCR if you are going to go further down in the sensitivities as we saw in the previous lectures. So this we covered that what is a PCR. So ultimately what you have is a cell has chromosomes has DNA, from DNA what you do is make multiple copies, and this is the, he's Gary Mullis, the inventor of the PCR technology, and I happened to meet him. I have a very beautiful DVD with him. If anybody is interested, can contact me. So basically what is happening is that you have the template, you denature, and you make multiple copies of the same kind of DNA in a very short time. And while you are making these copies, it adds to the advantage, but it has a major disadvantage of the PCR technology is that it is highly, highly prone to contamination, and you have to be careful while you are using this technology. So what is contamination? It is the introduction of unwanted nucleic acid into specimen, and there are only two kinds of PCR labs which are around: those who have faced contamination or who are going to face it. So we can only mitigate the contamination, and we need to take certain measures to be able to mitigate the contamination issue. So what are the potential sources of contamination? Cross-contamination between specimens, amplification products, the laboratory surfaces, ventilation ducts, the hair, skin, saliva, clothes of the lab personnel. So all these could be potential sources of contamination, and we need to take care of them. So lab design is one of the major way we control contamination. Typically, a molecular lab has three different areas. What we call is area 1 is our reagent preparation area. Area 2 is a specimen or a control preparation area, and also the PCR setup areas. So, and area 3 is where we do the amplification. So this is a 3-room setup kind of a situation. You could also have a 4-room situation in which you could split up the specimen control preparation and the PCR setup areas into 2. So these have to be physically separated and preferably at a substantial distance to each other, and this is one of the mandates from NABL that you need to have different areas to perform different functions. And you need to have unidirectional flow. So a person who has gone to the area 1 is allowed to go to area 2 to do the DNA or RNA extraction, but he cannot come back and handle the reagents. So both personnel, including cleaning personnel and specimens, need to have a unidirectional workflow. There is the supplies also are specific to each of these areas. And this could be one of the layouts in the lab, wherein you have the master mix preparation area. You have within this area you need to have the reagents storage area, and this needs to be at a positive pressure. When I say positive pressure, a blast of air is continuously coming out of this room, so that no contaminant from outside can actually go inside. The specimen preparation area is under negative pressure because what you are handling are specimens over here. Air from outside is allowed to come inside, but nothing from inside is actually allowed to go outside, because this could be a potential biohazard. And similarly, the amplification area is two is under negative pressure, because you don't want your amplicons to come out and go to these 2 rooms. So this 2 is under negative pressure area. So while this is good to have a situation wherein pressure differentials will aid in contamination control, but this is not the mandatory requirement from NABL as of now. So as we discussed, area 1 is where you have the reagent preparation. So you need to have a laminar flow cabinet or a clean bench wherein you are going to handle your reagents. The reagent storage at various temperatures needs to be within this area. Area 2 is your sample handling area, where you need to again store the reagents and also do the DNA RNA extraction. This could be automated, this could be manual. And your area 3 is your PCR and the post-PCR analysis area, where you could be doing real-time PCR, you could be doing Sanger, you could be doing NGS, you could be doing ddPCR, or you could be using the Luminex platforms. So what you can do at using the various instruments, say if you want to look at various translocations like a BCR ABL or a PML RARA, as Dr. Mishra was telling us, you could be using a real-time PCR instrument. And You could be looking at the various infectious markers like BK virus, EBV, adeno, parvo, by using your real-time PCR equipment. By using the capillary electrophoresis equipment or the Sanger sequencer, you could be looking at paternity, chimerism, FLT3, NPM1. You could be looking at dystrophies such as the myotonic dystrophies by using triplet prime PCRs. You could be looking at DMD and SMA by looking at the fragment analysis on a capillary electrophoresis. While if you use your capillary electrophoresis as a Sanger sequencing, it is typically used for germline mutations, but can also be used for somatic if the percentage of tumor is high. And you could be looking at EGFRs, KRAS, or QFPCRs for aneuploidies. So the technique comparison between a Sanger sequencer and a NGS. If you have a 50% tumor content, then it is very good. You are able to see the overlapping peaks. But as your tumor content goes on decreasing, this small green peak over here goes on decreasing. And this is where anywhere between after 10%, it is very difficult to call on a Sanger sequencer. So that is where actually NGS steps in. And if you want to go down further in sensitivity, digital PCR is the choice, which we already saw. So depending on the technique and the sensitivity level desired, you will choose your equipment within the lab. The features of the three areas, each area has to be separated, has to have separate sets of equipment like refrigerator, pipettes, centrifuges, lab coats. So all these things need to be separate. And a dead air box with a UV light serves as a clean bench area if you are looking at the saving costs. So air pressure, we discussed positive in the reagent preparation area and a negative in a sample prep or a post-amplification area. The reagent prep should have a single entrance. Reagents used for amplification should not be exposed to other areas. Specimen prep, the specimen should not be exposed to post-amplification work areas, and size of each area should consider space for equipment and bin space needed for preparation. So this could be one of the layouts where you could have the reagent preparation area is actually the smallest area. You could have a vestibule area and a positive pressure area, and this could be used as a reagent preparation. And then the specimen preparation lab is actually a bigger lab because you need to handle a lot of samples over here, and you could be looking at automation also sometimes down the line. Your sequencing lab could be under negative pressure, and your amplification and analysis definitely has to be on under a negative pressure area. So when you are introducing a new testing system, you need to do a validation or a verification. And guidelines suggest that you need to definitely check for FDA cleared or approved methods. You need to do only a verification, while if you are trying to modify it or an in-house developed method, then you need to do a complete validation. You need to have a quality control plan in place. You need to check what kinds of controls you require, what frequencies you will be running them at, and you need to do the evaluations of the controls as well as of the calibrators. One of the things which is definitely required as per guidelines is the internal control. An internal control is a DNA which tells you that okay, the sample has been collected adequately and has also been processed adequately. And definitely when you are running any assay, external controls such as positive or a negative control is required. So take-home messages: separate laboratory space for reagent prep, sample prep, amplification and detection. And precautions and special laboratory practices must be made to minimize the risk of contamination. And a quality control plan to monitor the quality of the testing process and a process which detects error should be in place, and definitely continuous quality improvement is essential. Thank you.
Dr. Thantai, we will have questions after the session because we are running very late. That's why. Thank you, Cholo.
Thank you, chairpersons and speakers, for the wonderful session, for making such a difficult topic so easy for all of us to understand. So for the next program, I would like to hand over the mic to my co-host, Dr. Avriti.
Good evening, all. We thank you all for being the part of BeSHCON 2021 hybrid. Now we come to the highlight of today's session, that is Professor Chatterjee Memorial Oration 2021. So we welcome the chairpersons for the memorial lecture. We invite Professor Utpal Chaudhary, ex-president, Bengal Society of Hematology and former director, IHTM, Medical College, Kolkata, to come to the dais. And we also request Professor Pradeep Kumar Mitra, ex-DME and ex-official secretary, Department of Health and Family Welfare, Government of West Bengal, come to the dais. Welcome, sir. Now I request our chairperson to introduce our orator, Dr. Sharmila Chandra ma'am. Ma'am, I welcome you on the dais.
Good evening. Good evening, my colleague, students and others. Now,
and that time I didn't know what to do till I came across this patient. And this is a patient of mine. This boy, he was about 20 years at that time, and he was diagnosed with beta thalassemia at 6 months of age, transfused regularly and well, advised to take desferrioxamine regularly, but he used to cry a lot while taking, and the mother used to cry more. And the inevitable happened, and he expired at the age of 25. And before he died, the parents decided to take a second child, but at that point of time, in the 80s, there was no prenatal diagnosis available in the city of Calcutta, and the parents decided to depend on destiny, and the second child was born, again with beta thalassemia. And after this very traumatic experience of mine, I started to look a little more into the problems of thalassemia. But before doing that, I was working in a blood bank at that point of time. We had to do a lot of work on donation, blood donation, good blood, safe blood, and I had to do this, go everywhere in blood donation camps and see to it that we get a supply of safe blood. At that point of time, I came across this very interesting article published in 1977, the health status of professional blood donors in Calcutta, and extremely poor state of the donors in Calcutta. Along with blood donation, we also had to look at the diagnosis. And you can diagnose a thalassemia by his faces. This is a book picture, but we get patients like this, a wailing child wriggling in mother's lap, and we have to make a diagnosis. And sometimes we get patients like these. This lady had a breast cancer, got admitted in the hospital for an operation, but had an anemia, and we realized that she has NTDT or thalassemia intermedia, E-beta thalassemia. And this gentleman, if you see him on the roads, you won't even realize that he has thalassemia, but the telltale splenectomy scar should make us aware that he has a thalassemia. Now, this is the paper electrophoresis machine. Sudipto has given us a very good preface to the electrophoresis of different types of proteins. Now, this is the machine that Professor J.B. Chatterjee used. It's still there in tropical medicine, but we have to look at the blood slide and the parameters in the Coulter counter. But we were experimenting in the 80s with cheaper ways of diagnosing thalassemia. So we devised an agarose gel plate where we could test multiple samples at the same time, and a very cheap way of diagnosing many, many patients at the same time. And we used to use single plates with the same agarose gel and separate out the bands and estimate the quantity of A2 to diagnose carriers. A very time-consuming and painstaking process, and these two papers are already published in the 80s. Now, these forays into the diagnostics had to go on at the same time as the development of the treatment centers, and we had the first daycare center in Eastern India where lots of children used to take blood transfusion. They used to get packed red cells. These days we try and give them phenotype matched blood, which is available in many private blood banks, and also medical college helps us a lot with phenotype matched blood. Now, this is probably the first daycare center in India. This was way back in 1985 when this daycare center started. And soon we started collecting data, and our first publications in the field of transfusion-transmitted diseases, we started documenting seropositivity in as far as HBsAg, anti-HCV, and HIV was concerned in these multi-transfused patients. And we found out that a lot of our hemophilics were infected with HIV as early as 1991. One of the earliest publications in this field of transfusion-transmitted diseases. Now, of course, there are many, many publications, but way back in 91, we were one of the first. Now, if you give transfusions, then iron overload cannot be very far behind. And we started to think about how to reduce iron overload. Desferrioxamine was a very inconvenient way of iron chelation, and none of the patients took adequate amount of injections, and they could not afford it, or they were non-compliant and they refused to take it. And we were really looking for an oral iron chelating agent, and then Cipla came out with L1 or deferriprone, and we took part in the trials of L1. And this is a publication in Indian Pediatrics with deferriprone as iron chelating agent in our patients. And it showed that it was an effective way of chelating iron from the body, although it has few side effects like joint pain and very rare agranulocytosis. Now, more into the diagnostics. Soon after the electrophoresis things, in 1994, HPLC arrived, and we had one of the earliest HPLC machines, and in 2005, I did an analysis of 2,355 cases and discovered so many types of mutations, so many types of diagnosis that we saw. But later on, these white background slides have been supplied to me by Dr. Prakash Mondal, and the two medical colleges have done exemplary work in mapping out the hemoglobinopathies in West Bengal, and they have done many patients, large number, 18,000 patients, and they have done the distribution of different heterozygotes and found out that beta trait was 6.61% and E trait was 2.78%. And of course, this figure changes from time to time, as you will see later. And this is comparison of the prevalence of carriers and traits in different publications. And this slide has also been supplied by Dr. Prakash Mondal. This is the work done, a very wonderful work done by the medical colleges, started by Professor Utpal Chaudhary and NRS Medical College, now carried out by Moitrey Bhattacharya, by Professor Dolai, Dr. Prakash Mondal. Really very interesting work. Now, this is district-wise distribution, also very interesting. You will see that in North Bengal, this is a publication from North Bengal, a very high percentage of E disease. So E is practically very predominant hemoglobinopathies in North Bengal. Now, it is from publication of Dr. Mondal, much less in the South Bengal region. E trait was 2.78% and beta trait was 6.61%. Something that we also found earlier. Now, year-wise breakdown of the diagnosis of hemoglobinopathies, it's gradually increasing, number of patients screened increasing. Don't think that this has gone down in 2020. It's just that the statistics is only up to March. So maybe this is even higher. Now, year-by-year breakdown of the different types of thalassemia and hemoglobinopathies diagnosed by HPLC. This is published in 2020, the report of a study of a large number of cases. Very interesting data done by West Bengal. Now, we were not only diagnosing thalassemias and treating them, but we started way back in the 90s thinking about what are the mutations responsible for the thalassemias. Now, this is a publication of the different gene mutations that we found in 1999, and this led to a very normal thing, is prenatal diagnosis of beta thalassemia in eastern India way back in 2004, and we had done about 68 prenatal diagnoses. In 2010, when we had the last Hematocon in Calcutta, I had done this analysis of 283 consecutive prenatal diagnoses, and we found that 201 normal and carrier babies could be born from the prenatal diagnosis. And the failure rate was only 2 out of 283. Now, this is a picture which I borrowed from Professor Utpal Chaudhary, a very, very interesting picture. showing variable phenotypes of E beta thalassemia. This is the eldest sister who is intermediate, totally transfusion dependent, something in between, and we wanted to know whether there was something identifiable which could explain the different phenotypes. And this is a paper published in 2001, but no single factor could be identified. Now, at that time, we were discovering cases of alpha thalassemia in Bengal, cases of hemoglobin H, which presented like beta thalassemia without the diagnosis, and we were very interested in alpha thalassemia. At that time, we had 3 papers on alpha thalassemia, co-inheritance of a hemoglobin Sun Prairie mutation, and absolutely new mutation called Kolkata mutation. I'm happy that Kolkata has gone into hematology as early as 2005. All this was published in British Journal of Hematology. Now, these 2 papers from Calcutta. Now, influence of BCL11A and another hemoglobin F increasing mutation. And now this was studied way back in 2012. Now I'm happy to say there's so much interest on BCL11A. Now by gene editing we want to increase the activity or decrease the activity and cure thalassemia. Very, very interesting. Professor Dolai will have a paper on all this later on. Now, what are the new therapeutic targets in beta thalassemia? Even this year in ASH, there were a lot of papers on all this, and there are many, many ways people are thinking of ameliorating the disease process or the pathophysiology of thalassemia and producing a relatively mild disease. But I'm not going into the details of this, as Tufan will later on definitely go more into the details of this. I will only say that I find gene editing a very interesting idea of ameliorating this disease, and gene editing, I hope, will become the future of hematology, of thalassemia treatment later on. Now, what about the future? Now, Prakash asked me to talk a little bit about the future. Now, I can only say that prevention of thalassemia is a necessity in West Bengal and is absolutely imperative that we carry it out, not because we have a high carrier incidence, not because the treatment of thalassemia is so expensive, but because we want to avoid disasters like this. I have more pictures of twins being born, both being born with thalassemia, a real disaster which will affect anybody, and will make us aware that prevention is the only way out in our part of the country. I think I will stop here. I've finished my time, and well, I can only say that I'm an out-and-out clinician. I can ask questions when I see a patient, and I expect my colleagues who are in different fields of science to answer these questions, and they have done. I have to thank my colleagues Uma Dasgupta, Professor Subroto Banerjee, my colleagues Dr. Debashish Banerjee, Dr. Ujjal Mani, who have helped me always in carrying out these.
Thank you, Didi, for the wonderful and lucid lecture. Traditionally, we don't have a question and answer session in an oration, so we conclude this oration here. Thank you once more for this oration.
Hello, now the felicitations organizers will have to be present. Okay, that's it. So the next announcement.
Thanks, ma'am. Thanks, ma'am, for giving us a glimpse of hemoglobinopathies in West Bengal in such a lucid way. And this brings us to the end of the memorial oration. Now, I request the chairpersons to be seated, and we'll be starting with the felicitation ceremony. For the felicitation ceremony, we now invite our guests of the evening, Professor Ghosh, ex-director, National Institute of Immunohematology, NIH, Mumbai, and Mrs. Uma Ghosh, our special guest, to the dais. I also request Dr. Prakash Mandal sir, organizing secretary of BeSHCON 2021, to provide us the summary of life. Now I request Prakash Mandal sir to come on the dais and give a brief summary about sir.
So, very good evening. I think and I feel it is the most tough job for me in organizing the whole of this conference along with my team to introduce and say something about our sir, Professor Ghosh. Because when I requested sir to provide me his CV, you just cannot imagine, it is more than a textbook. Font size is 10, space is 1, and page number is 89. Just imagine. I never can imagine CV of a person can be such big. And in a nutshell, I am trying to encourage, rather in my future generations who are sitting over there, just trying to say something about sir. And I have concised the whole, it's not coming. It's not moving. Yeah. So, 3rd December 1952, I am starting the journey, describing his journey from 1969. So, education years, it spans over 44 years. You start with MBBS, Medical College, University of Calcutta, and 2013. FRCP. So in between so many, I am not describing it categorically because of shortage of time. Then come to, different merit scholarships. Again, 68, 2013. Okay. Now academic and professional positions. As research officer, 1980, lecturer in hematology, PGI, Chandigarh, assistant professor, senior specialist, overseas visiting register, UK, director NIH, where sir worked for long time, then director Surat, Raktadan Kendra, Surat, and many different honorary positions in different capacities. Now, as a teacher, sir guided more than 6 DM students, 19 PhD students, not in hematology only, in genetics, biotechnology, different disciplines. Examiner in, you just imagine, medicine, hematology, laboratory medicine, transfusion medicine, medical biotechnology, neurology, immunology, and many others. His publication, 779, as of now, in various national and mostly international journals. Out of the 779, I think more than 500 are international publications. 34 chapters in different books and monographs. More than 32 orations in various national platforms, seminars, CMEs, social services. He is very famous for this purpose. Especially, I can mention about this regarding services in hemophilia and thalassemia care across the country and especially in West Bengal. Professional and society memberships, you start with one, you just try to read out till 19. Because of lack of space, I could not accommodate many others. Members of special committees, selection of director, Hafkin Institute, Mumbai, then peer reviewer of different projects submitted to ICMR, MRC, member chairman, ethics committee of different ethical committees. Journal editor and reviewer, former member of different editorial boards, Indian as well as international, reputed indexed peer-reviewed journals. And his peer reviewer of, I have highlighted few, and there are many others. Mostly you can see are international journals. Patents, there are more than 8 patents in his credit. Starting from mismatch PCR for diagnosis of a founder mutation of factor 9 deficiency in India, detection of red cell antigen using a nanotechnology platform in association with UICT Mumbai. So, other than this, his very vast knowledge of background and history of evolution of medical science has made us suspicious whether he also holds a master's degree in history besides all his other medical degrees. So he has the answer to everything all of us know, and in truest sense, he is the master of everything. Pranam sir.
Only one thing I can add, this is my personal experience. Actually, in any conference, if one speaker, a national or international speaker is, suddenly you miss one speaker, then you can ask Konjakoda to speak on any topic in any subject. And in 1 or 2 occasions it has happened, I know.
I'll just add 2-3 things because I was his classmate in Medical College, Kolkata. First thing, I feel proud because I was his classmate. And second, one incident, he was doing MD medicine in All India Medical Science. I spent one night at his room. I saw he is teaching something to another student. And I found what he is teaching. He is teaching anatomy of middle ear, one of the very difficult thing, to a student who was appearing in the MS ENT final. That is what Konjaku is. And lastly, this is discovered new to me also. He writes poetry very nicely. He has possibly 1 or 2 books of nice poetry, and extempore, within 1 or 2 minutes, he can write one poetry in both Bengali and English, and we are really surprised. So I'll be happy if he can say a few lines at the end of this.
Can I just take 1 minute? He was my teacher in PGI days. I have seen one of the golden period when he was very active. two things I have to share from my memory. One, what he was known in PGI was, he is a walking encyclopedia. I think nothing better can be described of Dr. Ghosh, my teacher, and we also say Konjakoda. And my first interaction was, there was a room, far corner he used to sit, very unprofessional room. First time I saw was such a big fat book which he was reading. It was Melzack and Wall's Pain. So I was thinking what a hematologist was doing with that. And, you know, ask a question that time, he knew everything on it. That was the impression that we had, and rightly so. PGI, he was known, and I want to reiterate now what Dr. Prakash said, my teacher, Dr. Ghosh, you are truly a walking encyclopedia.
Okay, then we can continue. So actually from the degree also you can see he has not left M and N, M and F for us. Everything has been backed by him. Anyway, so continue.
Thank you, sir. Thank you, sir. So now I request our chairpersons, Professor Chaudhary and Professor Mitra, to present the felicitation to Ghosh sir.
I feel very shy because so many things have been told and eulogy is showered on me. But Dr. Utpal Chaudhary, and today I actually went to Dr. Molay Ghosh's house to see whether he can be persuaded. But he has broken his ankle, so he probably wouldn't have come, but now he is not able to walk. Basically, when we started studying, Sharmiladi has already left. So we were in clinical side, Sharmiladi has already left. So we didn't have anybody except Professor J.B. Chatterjee's name in front of us and Dr. R.N. Roy Sandadi as the hematologist in front of us. And it is a very important thing that hematology is not a very common subject. And from one class, one batch, three of us, Molay Ghosh, Utpal Chaudhary, and myself, took up this subject mostly because Sandadi and R.N. Rai actually was instrumental in making us interested in hematology. Then motivating us. Then when I came to AIMS, I was going through the library because I was thinking what books I should see. In AIMS library there are also MD, PhD theses. Then I saw a thesis of Dr. Sharmila Chandra. That time she was not Chandra. And with a very famous hematologist of that time in the guide of India, his name was Dr. Arup Manglik. And actually I continued some of the work which Sharmiladi did, that was looking into B12 binding proteins in chronic myeloid leukemia. Actually she measured B12 binding protein in chronic myeloid leukemia. Probably if I can remember well, it may be 76 or 77 that thesis was there. Then of course you have all said, you all know I went to PGI. And this journey has been a great journey with few of my great friends who are here. And I could do this much what I could do because of them. Thank you very much.
I request the chairpersons to present the Manpatra to sir. I request our chairpersons to give a token of appreciation to ma'am also. Thank you very much, chairpersons. Thank you very much, sir, ma'am. So now we are heading towards our Mrs. Aparna Ghosh Memorial Gold Medal in Hematology 2021. This gold medal was donated by Professor Malay Kumar Ghosh, former head of the Department Hematology, NRS Medical College, for the best student in University 2020 examination in DM Clinical Hematology. And the prize goes to Dr. Manisha Jain. Sir, I request Ghosh sir to come on stage and please present the gold medal and certificate to Dr. Manisha Jain. Now, thank you, sir. Thank you, ma'am. Now I request Professor Tufan Kanti Dolai to come on the dais and present a small token of gratitude to our chairpersons. Thank you, Chairperson. Thank you, Ghosh sir. Thank you, ma'am. And thank you, Dolai sir. So now we are heading towards the inauguration ceremony of BeSHCON 2021 hybrid. And for this, I'll be inviting the dignitaries to the dais. First of all, we welcome our chief guest, Professor Debashish Bhattacharya, Director of Medical Education and ex-Secretary, Department of Health and Family Welfare, Government of West Bengal. Then we welcome our guest of honor, Professor Tamal Kanti Ghosh, Special Secretary, Medical Education, Department of Health and Family Welfare, Government of West Bengal. We welcome our organizing chairpersons of BeSHCON 21, Dr. Shantanu Basu, sir. Now we request Dr. Sharmila Chandra ma'am, President of Bengal Society of Hematology, to come to the dais. I would kindly request Professor Tufan Kanti Dolai, sir, Secretary, Bengal Society of Hematology and Scientific Committee, Chairperson, BeSHCON, and Professor Prantar Chakrabarti, sir, Joint Secretary, BeSHCON, Bengal Society of Hematology, to kindly come to the dais. Last but not the least, we now invite Dr. Prakash Kumar Mandal, sir, the Organizing Secretary of BeSHCON 2021, to kindly come to the dais. Thank you, dignitaries. Now I would request Mau Mukherjee, Swarupa Bhattacharya, Mrs. Roma Roy Shaimal, Miss Soma Sen, Byapti Banerjee, and Mrs. Ankita to come on the stage and facilitate our guest. We will now listen to the welcome song based on a Sanskrit hymn sung by Dr. Suranjana Basu, Mau Mukherjee, Swarupa Bhattacharya, Mrs. Roma Roy Shaimal, and Mrs. Soma Sen. I request you to come on the dais.
একটা হারমোনিয়ামের মধ্যে দেবেন আর এইটা আছে না এটাতে রাখা যাবে এই যে এই যে এই যে এই তো টেবিল
Please, Mau Mukherjee ji, Basu ma'am, then Swarupa ji, Roma Roy, and Soma Sen, please come on stage and start the Sanskrit hymn.
না না এইখানটাতে মাইক আছে ও আচ্ছা আচ্ছা ঠিক আছে এটা ফেলে দিই
Meanwhile, since the arrangements are going on, I request our guest of honor, I request our chief guest, Professor BeSHCON Bhattacharya, to come on dais and speak few words.
Good evening. It's really a pleasure to be here among all of you. And particularly when Professor Kanjanku Ghosh was there, it is really nice to have him here amongst us. Truly speaking, he himself is not only the living encyclopedia, but is a living inspiration to all of us, and particularly for the new generation, so that we can really go ahead following his footsteps, which is very difficult to really follow. But as a director of medical education, I do feel that all of us should work together so that we can give a vision for the future of West Bengal, which we are going through a very difficult time at these times. So we have to go ahead and taking everybody's good suggestions, we must do something good, not only for Bengal, but for our whole country. I wish and pray to God that really we can do something for India. Thank you.
Today we shall present to you a Vedic chanting compiled by and set to tune by poet and Nobel laureate Rabindranath Tagore. He chose 3 wonderfully significant mantras or sacred hymns from 2 different Upanishads. The first 2 hymns are from the Shetashvatara Upanishad and the last hymn belongs to Brihadaranyaka Upanishad. These hymns are addresses of hope to mankind. It starts with, "Hear this, O children of immortal bliss, I have come to know the imperishable, indestructible, immortal, luminous soul or Brahman. We are all divine. Let everyone hear this message wherever he or she is in this world or elsewhere. Let us reach out in as many ways as possible. All wise beings must help to spread this message for the benefit of humanity. The sage says, I have known the great being who exists beyond the darkness of ignorance and is self-luminous as the sun. Every human being must realize him within one's own self and attain salvation. There is no other way to freedom. The ancient sages say to us again and again that we have to know the Brahman or cosmic self who is always residing within us. He is not somewhere far away. The Upanishad says that when we realize this self or Brahman, there is nothing further to know. This knowledge is ultimate, final. By gaining this enlightenment, the sages or seers, who were the composers of Vedic mantras, reached this goal of realization. They felt gratified and fulfilled. Having detached themselves from all worldly desires, their minds were always tranquil. From the last hymn, we learn that the luminous Supreme Being exists in the sky and in the air. It is everywhere, inside and outside of us, and throughout the universe. This Supreme Being is full of bliss and sweetness. The main refrain of the three hymns is that one must realize the Brahman or cosmic self within one's own self to go beyond the cycle of birth and death. There is simply and truly no other path to salvation.
Vishve Amritasya Putra Aye Dhamani Divyani Tasu Vyavritam Purusham Mahantamaditya Varanam Tamasa Nana
at times good things may happen with the delay. So thanks a lot, Didi and ma'am, for the beautiful song. So now we have our inaugural lamp lighting session, and for this I request our chief guest, Professor Debasish Bhattacharya sir, to light the lamp and address the audience. I request Dr. Shantanu Bashu sir, the organizing chairperson of BeSHCON 2021, to address the audience.
Good evening, friends, ladies and gentlemen. It's my proud privilege to welcome you to BeSHCON 2021. We have gone through bad times, but hope springs eternal, and we are trying to open a new window. This last year, we have lost friends, relatives, colleagues to a vast scourge which has blighted our lives. Let this be a new beginning. Let's take this fight to those viruses and try to open a new vistas of a new normal. A group of very young academics have planned this and executed this against impossible odds. I salute them for their good deed. Please join us in making this conference a grand success, and please be safe and stay safe. Thank you.
Thanks a lot, sir. Now we invite our guest of honor, Professor Tamal Kanti Ghosh, to release the Journal of Bengal Society of Hematology and then address our audience. Thank you. I invite our guest of honor, Professor Tamal Kanti Ghosh, to address the audience.
First of all, I would like to thank the organizers, Professor Doloi, Prakash, Dr. Prakash Mondal, and Dr. Basu, the dignitaries on the dais, and my teachers, Professor Utpal Chaudhary, Professor Konjako Ghosh, and beloved Dr. Pradeep Mitro, Shikhadi and others, and my dear colleagues. It's a great pleasure to be here. Actually, hematology is very close to my heart. Dr. Utpal Chaudhary is here there. He was my teacher in my undergraduate days. And when I was working as a demonstrator in pathology in Medical College, Calcutta, I used to visit his OPD. There was only a single room, and he was having a department with only one medical officer, Dilip Da, and a technician. From there, he made the department to the Institute of Hematology and Transfusion Medicine. I think Director of Medical Education is there. In West Bengal, we have only 2 centers of hematology, Medical College and NRS Medical College. So I think the hematology services should also be given to people in North Bengal and also some other part in the West Bengal. And hope in future we'd like to have more Institute of Hematology in North Bengal 1 and in South Bengal. So I hope the society, Bengal Society of Hematology, will progress and also help us in achieving this goal. Thank you very much.
Now I welcome Dr. Sharmila Chandra Ma'am, the President of Bengal Society of Hematology, to release the souvenir and say a few words on this occasion. Now I request Dr. Sharmila Chandra Ma'am to say a few words on this occasion.
Well, we conceived of Bengal Society of Hematology to make hematology popular all over, to the students, to the doctors outside who are practicing, to other medical colleges where there is no hematology department, to other districts where no hematology is available. And I am happy to see the 5th BeSHCON conference aimed at popularizing hematology, and a hybrid conference having so many people and so many attending the last evening conference today. And I hope this will see more and more successful ventures in the future. The journal pleases me immensely, and congratulations to the NRS group who have made it possible to see this day. Thank you very much.
Thank you, ma'am. Now I invite Professor Pranta Chakrabarti, sir, to address the audience.
Good evening, everybody. I think people are hungry, so it's all about a journey together, and I echo what Shantanuda said, that we have to keep safe, we have to go on adopting like this,
but learning will continue, and I think every day is teaching us. Thank you, everybody, and the great learning we will have, we will cherish it for years together. Thank you.
Thank you, sir. Now we invite Professor Tufan Kanti Dolai, sir, the organizing secretary of BeSHCON, to say a few words and give a vote of thanks.
Before that, on behalf of the Bengal Society of the Hematology, this is our 5th endeavor of the 5th BeSHCON 2021. So during the COVID pandemic, we thought we will do the hybrid physically and a little bit of the virtually also. I think in the first day and the second day will be a lot of academic discussion in the field of the hematology. Apart from that, the Bengal Society Hematology is one of the most vibrant society in this part of the country, creating the awareness in the field of the hematology and giving the education. We did the several live webinar in this the COVID pandemic also to educate the postgraduate, creating the people attractive to the hematology. And apart from that, this year we are able to create our own journal. That is the Journal of the Hematology and the Allied Sciences. This is the one of our dream of the Bengal Society of the Hematology. And apart from that, the Bengal Society of the Hematology, this is the first society in this country have a own register office. And thanks to our Professor Chaudhary and other group for making this successful, for creating this our office of the Bengal Society of the Hematology. And apart from this, a lot of the endeavor on behalf of the Bengal Society of the Hematology, I thank to all the executive members, all the delegates, those who are with us for making this hematology as a successful super specialty subject. I think in future it will be also flourish. And thanks to the DME sir and the Special Secretary sir for supporting us. Thank you very much.
Thank you, sir. Now I would request Dr. Prakash Kumar Mandal, sir, the organizing secretary of BeSHCON, to say a few words and give the final vote of thanks to all.
So it's customary that organizing secretary must say something at the end of any session. So as part of that, I feel proud and privileged that Bengal Society of Hematology decided this year someone who is least experienced in this type of job. And finally, when the Bengal Society of Hematology members, executive members, sat to decide whether there will be a conference this year or not, we had a lot of fight amongst ourselves, virtual versus physical. Finally, I was one of the proponents who suggested why not it could be a hybrid. Then everybody asked me for the explanation, what do you mean by hybrid? I just gave an example. If it can happen that cricketers, they are playing in the ground and everybody is millions of people watching it, then why not this conference can be like that? Maybe not like that. So that was the starting point, and finally all members, they actually helped me and approved my suggestion or appeal. And finally what is happening now, that is this hybrid conference, BeSHCON 2021, 5th annual conference of the Bengal Society of Hematology. So in running or planning this program, I had supports from many. It is very difficult to name each and every person. Please forgive me if I forget to mention anyone who actually contributed a lot, maybe in comparison to other. But I can say one thing, that it's a teamwork, and because of this teamwork, this program was made possible. Whether it is successful or not, that feedback we will get from you all tomorrow or day after tomorrow. Now, the most important person or key person who is instrumental in planning and executing the whole of work is Mr. Biplav Bhomik, who perhaps is not taking sleep over last few days to make it possible. And of course, we all are very much grateful to our chief guest of honor, and all other dignitaries, especially my teachers who are sitting over there. Now, I must congratulate, welcome, and appreciate that in spite of all this adverse situation during COVID-19 pandemic, there is a huge response in registration. At one point of time, we had to take the decision that there will be no single registration from this day. Our cut-off date was 31st January, and by that time, it crossed our expectation or limitation. So there are a lot of requests to me and other people in the team. Please consider one, please consider one. By that, we perhaps refused more than 150 number, maybe. But we were helpless, because by that time, we had made certain arrangements where we could not accommodate many more people. So please forgive me or us for that. Next, all you will appreciate the ambience you feel here in ITC Royal Bengal. I think the arrangements they have provided us, supports they have provided us, we all are enjoying that. Next, I will come to MIE conferences. They also are in their very beginning stage of life in their professional career, but they are doing excellent job. I feel so. New Moviton, another organization, they are supporting us, all people sitting over there in all these audiovisual systems, all those, they are supporting us. And of course, last but not the least, are all of you feel that without whose support this type of or this kind of conference is never possible, is our friends from the industry. And I must not forget to thank my family members who basically tolerating my absence from my routine household jobs. So I thank you all. Please enjoy the scientific session and give us feedback so that there is every chance to improve, so that we can improve our quality of this scientific endeavor. Thank you all.
A very humble thanks to all the dignitaries and the delegates. Now we conclude the inauguration ceremony of BeSHCON 2021. Thank you.
Thank you all. So here comes the end of today's program. So after this academic feast of today, it's a time for the real feast. So I request everyone to move for dinner, and we'll meet tomorrow at 10 a.m. Same place here. Wish you all a very good night. Thank you.
Hello. And enjoy the dinner that is available in the outside this hall.